Jaipur, the Pink City. I extend my deepest gratitude to the visionary organizing chairpersons, Dr. Dhavendra Kumar from the UK, Dr. Ashok Gupta and Dr. Hemant Malhotra for their noble and novel vision in making this impactful conference a reality. Rare diseases, though uncommon, remind us of the profound truth in the saying, even the smallest spark can ignite a great flame. Every discovery in this field carries immense potential to transform lives and revolutionize healthcare for most in need. With this thought, I wish everyone here a successful and rewarding experience at the conference. To begin with a morning session on rare cancers in clinical practice, it is my absolute honor to invite Dr. Hemant Malhotra to the stage this morning to deliver the welcome speech. Dr. Malhotra is the professor and head of medical oncology at the Sri Ram Cancer Center, Mahatma Gandhi Hospital, Jaipur. With over 3 decades of experience DM in medical oncology in the state. He also introduced hematopoietic cell transplantation in Rajasthan, marking significant milestones in advancing cancer care. The first to venture into the unknown lays the foundation for all who follow. Dr. Malhotra's efforts have truly laid the groundwork for the future of oncology in Rajasthan. A respected leader, Dr. Malhotra has served in key positions, including immediate past president of the Indian Society of Medical and Pediatric Oncology. Please join me in welcoming Dr. Hemant Malhotra, a beacon of inspiration for all.
So thank you, Aditi. Good morning to everybody. And those of you who are hardcore members of the ICBD must be wondering what I'm doing here and why am I an organizer for this event. So rare diseases is like something which is important to all of us, and we have a whole bunch of rare cancers also. I have no idea about, I'm not a pediatrician, I'm a hardcore adult medical oncologist, so nothing to do with pediatrics, nothing to do with birth defects, but we certainly are interested in rare cancers. And we thought that when we talk about rare diseases, we should have a segment which addresses rare cancers. And why is this important to us? Because these diseases are so rare that it's difficult to generate evidence for their approach, their diagnosis and their treatment. And most of the times you base your treatments and you base your treatment recommendations on case reports or case series. And it is important to have some kind of track how to approach these patients. So my most hearty welcome to all of you. You know, when you organize a conference today, you can get the best faculty in the world. That's the easy part. The hard part is to fill the halls. So I'm sure that gradually that will also happen as the sun rises. We'll have more people come in. And I really truly believe that quality is way more important than quantity. So we will make do with what we have. And again, welcome to my city, my institution. We're very grateful for the effort you made to come over here. I have 2 very dear friends of mine who are going to do the oncology track today, Dr. Vijay Patil from Bombay and Dr. Geeta from Delhi. So thank you very much. You braved the fog and everything and made the trip. So really truly appreciate it. So ladies and gentlemen, I hope you enjoy your trip here in Jaipur and we have a good successful conference. And I'll hand over proceedings back to Aditi so that we can have the first lecture. Thank you very much.
Thank you so much, sir. It is my privilege to introduce Dr. Nimish Mehta. Dr. Mehta is the chairman of the Center for Digestive Sciences and also the professor and head of the Department of HPB and Liver Transplantation Surgery at the Mahatma Gandhi Hospital, Jaipur. With over three decades of experience in the field, he has been a pioneer in liver transplantation and advanced HPB surgery, performing over 1,500 liver transplants, both adult and pediatric. His expertise in minimally invasive and robotic HPB surgery is well recognized, pushing the boundaries of medical innovation to improve patient outcomes. Dr. Mehta's leadership extends to his instrumental role in shaping the medical landscape, not only as a clinician, but also as a visionary educator and researcher. His contributions have significantly impacted transplant surgery in India, and his work continues to inspire the next generation of healthcare professionals. Please join me in welcoming Dr. Nimish Mehta, to the stage to present on the topic pediatric liver transplantation with a focus on rare diseases.
is much more than what you are very skeptical that if these disease is affecting at a very young age, what is the lifespan, how it is going to affect, especially in a female child, how will it affect her life beyond, and whether she'll be able to lead a normal healthy life with their children and the family where she goes into after marriage. So some of these issues are then eventually addressed. The pediatric transplant is technically a much more difficult procedure because of the size of the child, the vessels, the size of the vessels what we get, and you also need a good infrastructure and manpower in specific management for pediatric liver transplant. So coming to the indications of pediatric transplant, we know that in the cholestatic disease, biliary atresia is the most commonest cause, followed by the hepatitis and metabolic disorders, tumors, and then there are various miscellaneous causes where you would require transplant in the pediatric age group. There are certain patients or the younger children who present to us with acute liver failure, and in those mainly it is either hepatitis A virus related. We did one acute liver failure child yesterday who was suffering from HIV infection and had to undergo an emergency liver transplant. The other reasons for ALF could be an acute Wilson's, and these are the main reasons why you take this patient up for transplantation. Now coming to the rarer disorders, metabolic disorders are comparatively lesser than in the pediatric population requiring transplant, but there are certain diseases where they are cured by liver transplantation, and some of the metabolic disorders would be improved by liver transplantation. So some of these are Crigler-Najjar syndrome type 1, urea cycle disorders, Wilson's disease, MSUD, hemochromatosis, primary hyperoxaluria type 1, and familial hypercholesterolemia, which will be cured by transplant, whereas some of the other diseases, which I am not going to name them and waste the time, will be improved post liver transplantation. So how do we evaluate liver transplant? Just by the meaning we say we go ahead and transplant doesn't mean we take the patient straight to the OT. So there is a thorough evaluation by a multidisciplinary team, which includes the transplant surgeon, pediatric hepatologist, a gastroenterologist, transplant coordinator, critical care specialist, anesthesiologist, cardiologist, neurologist, psychologist, and various other departments who are going to support us and the child throughout this journey of peri-transplant and post-transplant care, and then eventual follow-up in the life. So there are various other essential evaluations. One is for the diagnosis, the other are specific for the disease, and I will not bore you with the details of these, but the evaluation is done in detail. The various challenges as a surgeon, what we come across in pediatric liver transplant is most of our kids are around a year in age, so they are smaller. The size is smaller. Sometimes we get a large size donor or a bigger size graft from a living donor. You may need to reduce the size, which I'll show you in the next subsequent slides. So you need to innovate, you need to think out of the box and change your transplant technique depending to the individual whom you are catering to. So the various transplant techniques, one is reduced size graft, as we were just discussing. So what you can see on the left hand side of your screen, that was a graft attained from an adult parent who had donated the left lateral segment, but even that was too big for a small child, so that had to be reduced on the bench. Split liver transplant, where you get a big liver where you divide into two. The right part will go to the adult and the left will go to the child. And living donor liver transplants, as you had heard, in a smaller child you go for left lateral, and a bigger child you may need to undergo a left full lobe donation. Coming to domino transplant, another modality for the surgeon where you try to cure two patients from a single liver. So if you get a liver from either a deceased donor or a living donor, it is put in a child who is suffering from a metabolic disorder where the liver per se is not bad, and in these cases the liver of the child which comes out is transplanted into another child which is probably suffering from the liver cirrhosis due to other various reasons, or a tumor developed in the liver. Auxiliary partial orthotopic transplants or APOLT, where specifically done mainly in metabolic disorders, where you remove a part of the liver and put another liver from the donor which will fulfill the metabolic requirement of that individual, and that is how an APOLT would be done. Eventually, mainly we try to do it in an acute liver failure setting where the original liver or the native liver will grow back in size and will try to get back to normal function, where you can allow the implanted graft to regress or atrophy, thereby reducing the chances of requirement of lifelong immunosuppression. So that is still a little bit work in progress. Coming to liver transplant for Wilson's disease, again as I said, there are two phases. One is end stage liver disease, or the Wilson's patient can actually present with acute liver failure or neuropsychiatric involvement, and when these patients do present, if it is done at the right time, then usually the recovery rate is much gratifying than if it is done at a later stage in their life. So there are many transplant registries which give good result in Wilson's disease after receiving a liver transplantation. The indications here is, again, if it's an isolated liver driven disease, liver transplant definitely provides a survival benefit. If it is a minor neuropsychiatric involvement, again in both these cases with the compensated or decompensated liver, if transplant is done, there is some bit of recovery and patient can lead a normal life. This was a young child who is standing in the center at Mahatma Gandhi Hospital who was suffering from Wilson's disease, presented to us for transplantation, and this was one of the first few pediatric transplants done at Mahatma Gandhi University of Medical Sciences and Technology in Jaipur. We have another child who was suffering from a large tumor in the liver, which was actually infiltrating into the inferior vena cava, going to the right atrium. And this patient eventually had to undergo, this 3-year-old 11 months child presented with abdominal pain, distension, ascites, a liver tumor, and undergoing end-stage liver disease. Biopsy was suggestive of inflammatory fibromyoblastic tumor. As you can see on the scan, there was a large tumor seen infiltrating into the inferior vena cava, the tumor thrombus going into the right atrium. Eventually underwent a living donor liver transplant with replacement of the IVC. To the best of our knowledge, we do not have any other case presented in the literature who has undergone a living donor liver transplant with a simultaneous open heart surgery in a pediatric age group. So this is a small video of the intraoperative evaluation on the table where the scans are re-evaluated. That's a tumor going into the atrium, and the chest is opened. We have opened the pericardium, trying to loop all the vessels. That was the aorta. Patient was put on a cardiopulmonary bypass machine, as you can see, and then with a beating heart. This is obviously was done by my pediatric cardiac colleague. The right atrium is incised. Once you incise the right atrium, as you can see, the tumor has come in the view, which was infiltrating through the IVC and reaching into the right atrium, trying to remove the tumor from the surrounding atrial tissues. That's the bundle of his fibers between the atrium and the ventricle. And we wanted to remove the tumor in toto. Once that is separated out from the atrium, the right atrium is now partially reconstructed, and the rest of the defect of the right atrium had to be reconstructed. That's a large defect in the right atrium. So to cover up this defect, we had to take the pericardial patch, which was then used to reconstruct the right atrium in this child. So the right atrium is now reconstructed. Once that is done, once you have reconstructed the right atrium, you need to reconstruct the IVC. So that's a YPTF, you're an artificial graft where we are connecting and making a new IVC or a neo IVC. This now is ready to be pushed down into the abdomen through the diaphragm, but we need to remove the liver. So with both the limbs ready, now we start the abdominal part where we are removing the tumor in toto through the diaphragm. That is the porta, where we are cutting the portal vein and the portal structures, separating it. The artery was cut, and then we go down to the suprarenal IVC. This was the tumor again around the pericardium and the diaphragm. Part of it is removed. This is the suprarenal IVC now being disconnected, and the whole tumor with the segment of the IVC is removed. The two limbs of the Y graft are now removed and pushed through the diaphragmatic opening. The one of the limb is anastomosed to the inferior vena cava, now be making a new IVC or a neo IVC. Once that anastomosis is complete, the left lateral smaller segment of the graft will be now inserted. The other limb of the artificial graft is now being used to anastomose it to the left hepatic vein or the left lateral hepatic vein, as you can see here. That anastomosis is completed. This is a portal vein anastomosis. So once we complete this anastomosis, and we will be reperfusing the liver. Once this anastomosis is complete, we will start with the arterial anastomosis. So that's now the portal vein, which is one of the main supply to the liver, is being reconstructed. Once that is done, we are now reperfusing it. Once the reperfusion is done, the clamps are removed, and then we complete the arterial anastomosis as well. That's the reperfusion of the graft, as you can see. So this patient withstood the surgery pretty well, and the histopath confirmed inflammatory fibromyoblastic tumor. This is the post-transplant CT scan showing both the vessels, the neo-IVC as well as the left hepatic vein draining into the left lateral segment of the liver. This was the right hand side, was a child who had presented to us at that time before the surgery, and this is this is about 7 years or 8 years down the line. She was celebrating her 10th birthday, leading a normal life. Coming to the other rarer disease, PFIC, again we all know the various types of PFIC, and the indications here is with patient presents with end stage liver disease with severe pruritus and growth failure. The outcome would be there is an improved quality of life, the symptoms would reduce, and the patient, if done at the right time, will have a catch-up growth with improved psychomotor ability. The survival rate of 5 and 10 years are significantly high, and in long-term management also you can have a regular follow-up with liver function test. However, these patients do have some bit of allograft steatosis, may have vascular complications, and the risk of hepatocellular carcinoma is a bit higher as compared to the rest of the population. Compared to the 3 types, the recurrence of the symptoms is much higher in PFIC type 1. PFIC type 2 usually has the best outcomes post-transplant, and even PFIC type 3, the recurrence rate is much lower. Now, some of these patients do have persistent cholestatic symptoms, and initially what we try is doing an partial internal biliary diversion in these cases. So, this is one of our case which we recently operated. A 2-year-old young girl had presented with PFIC type 1, and here we are making an isolated jejunal segment where we are going to anastomose it to the biliary system, whereby we will be draining the bile and reducing the biliary load and thereby reducing the absorption and breaking the enterohepatic biliary circulation, thereby reducing their symptoms. So, this was the anastomosis started between the jejunal loop and the gallbladder. This is the anastomosis between the jejunal loop and the colon. So this is an interposition jejunal loop between the gallbladder and the colon. So directly, instead of going through the distal part of the ileum where the absorption is much higher, it directly bypasses and reaches the colon, thereby reduces the incidence of significant itching. You complete this surgery with ending the jejunal anastomosis, and this patient is about 2 months down the line post surgery, and the pruritus has significantly reduced. But many a times now what is happening is there is a good study where you try to combine the internal biliary diversion simultaneously with liver transplantation. So there have been studies from our country where the comparison was between the liver transplant without internal biliary diversion and liver transplant with total internal biliary diversion, where in those cases who underwent a simultaneous procedure, it was seen that the graft steatosis and diarrhea was much lesser. It improved the growth velocity and overall survival rates. However, in those patients who had undergone a sequential, that is post liver transplant, they underwent an internal biliary diversion. Even in these patients, they had reversal of the graft steatosis. So internal biliary diversion is one of the good armamentarium in the surgical field, where you can try and reduce the outcome and the graft steatosis and improve the survival in this pediatric population. Outcome and prognosis in these patients of metabolic disorders who undergo liver transplantation. So metabolic disorders account for about 15 to 25% of all pediatric liver transplants, outcomes in these patients, if they undergo a liver transplant at the right time, is probably better in compared to those patients who undergo transplant when they come to us with a decompensated liver disease. However, in a younger population, the challenges which still remain is chronic rejection, because some of these kids who grow up and the teenage group, sometimes they are difficult to ensure that they continue with their immunosuppression. They may become non-compliant, and that is where chronic rejection does become a major issue in this group of patients who have undergone liver transplant. If they have to undergo a retransplant, it will have a higher morbidity and mortality. And as I said, prolonged immunosuppression can actually have long-term complications which still needs to be studied. So some of our patients, the difference what transplants can make is the photo on the right is a pre-op and the photo on the left is post-op. So that generally changes, again here it's the same, generally changes the whole life view of the patient as well as the family, the type of difference which can be made, and these patients can go back in their society and eventually can lead a normal and healthy life. So that's thank you from all. These are most of our, recently we had a organ donor day, and most of our organ donors and the patients have formed a human chain. So thank you very much for Mahatma Gandhi University of Medical Sciences and Technology. I'll be happy to take any questions if there are any. Thank you so much. There are none, I guess. Thank you so much.
Thank you, Dr. Mehta, for this enriching talk. It is my absolute honor to introduce our next speaker, Professor Meena Upadhyay. She is the Professor Emerita at Cardiff University, Wales, and also Professor of Practice at University of Wales, Trinity St. David. Dr. Upadhyay is also a visiting professor at Sir Gangaram Hospital, New Delhi, India. Her work, which includes 200 plus papers and 5 books, has earned her international recognition. Professor Upadhyay's contributions have been recognized by numerous awards, including the prestigious Order of the British Empire, OBE, and St. David Award for her outstanding services in the field of medical genetics. Many congratulations, ma'am. She has also been a driving force behind initiatives supporting ethnic minority women in healthcare. As the saying goes, the journey of 1,000 miles begins with a single step, and Professor Upadhyay has taken countless steps to advance healthcare through genetics. We are deeply grateful to her for traveling all the way from the UK to be with us today. Please join me in welcoming Professor Meena Upadhyay to deliver a talk on neoplasia in rare diseases, a model of retinopathies.
Can I get my talk? Oh, yes. Okay, thank you very much, Aditi, for your very kind words. I'd like to thank the organizers for inviting me to this wonderful conference. Okay, so I'm going to speak about, in fact, I'm going to give a brief introduction of rasopathies, followed by tumors related with neurofibromatosis type 1. So rasopathies are developmental disorders caused by germline pathogenic variant in one of the genes encoding a component of RAS-MAPK pathway resulting in its dysregulation. Although RASopathies are rare syndromes, but collectively they affect 1 in 1,000 individuals worldwide. It is caused by multiple pathogenic mechanisms, all of which lead to a similar outcome in RAS-MAPK pathway activation and dysregulation. These syndromes are caused by altered functions of GTPases, RAS-GAP, kinases, and other proteins. Because of the common underlying RAS-MAPK pathway dysregulation, they share overlapping phenotypic features, including cancer, facial dysmorphia, neurocognitive impairment, pain, cardiovascular, musculoskeletal, gastrointestinal, and cutaneous abnormalities. Okay, so this slide here shows 9 RASopathies which have been well worked out, and out of these, 6 are caused by a genetic, by pathogenic variant in a single gene, whereas the remaining 3 have genetic variant in more than 2 genes. So if you look at here at the top, neurofibromatosis type 1, capillary malformation, arteriovenous malformation, SYNGAP1, all these 3 syndromes are caused by germline mutation in RAS-GAP. Then we have Costello syndrome, which is caused by germline mutation in HRAS, Legius syndrome, germline mutation in SPRAD1, and CCLA is caused by germline mutation in ARAF. Then if we look at Noonan syndrome, so far we have got more than 22 genes which are associated with Noonan syndrome. 5 genes are associated with cutaneous facial, cardiofacial cutaneous syndrome, and 2 with Noonan syndrome with multiple lentigines. Okay, so not all RASopathies have been identified. Next generation sequencing has found several genes that were altered in patients with so-called RASopathies. However, the functional validation of these genes as RASopathy-associated genes is not yet complete, and these include RAS-A2, SPRY1, and MAP3K8. So now I move to neurofibromatosis type 1. It was first reported by von Recklinghausen, a German physician, some 135 years ago. It is the first reported RASopathy, and it affects 1 in 3,000 individuals. 50% of patients, NF1 patients, represent new mutations, and the penetrance is almost 100% by age 5. The disease is characterized by benign neurofibromas, caffeolate spots, axillary or inguinal freckling, and Lisch nodules. So, individuals with NF1 have 60% lifetime risk of developing cancer and are 4 times more likely to develop cancer compared with the general population. You can see there are lots of NF1 patients can be associated with both benign as well as malignant tumors. And it is probably the first few inherited conditions where multiple tumor types can occur simultaneously or at different stages in life. The variety of tumors associated with NF1 highlights the need for comprehensive monitoring and early screening for cancer in NF1 individuals. So this is the RAS-MAPK pathway. I haven't got time to go through it in detail, but it would be suffice to say that RAS, when it is bound with GTP, it is in active form, and when it binds with GDP, it is in inactive form. Neurofibromin is a gap protein, and its function is to down-regulate RAS. So patients with NF1 have reduced neurofibromin in their tumor. When neurofibromin is reduced, it is unable to hydrolyze active RAS into inactive form. And therefore, this RAS here gets activated and sends signals along its downstream effector, resulting in cell growth and proliferation. The other thing, because it is a tumor suppressor gene, so biallelic inactivation is required for tumor development. Each NF1 patient is born with a germline mutation, and for tumor to occur, the second, the wild type allele is inactivated through a somatic mutation. Neurofibromas are the hallmark features of NF1. They arise from nerve and therefore have the cellular composition of nerve. It is important to remember that it is only the Schwann cells which carry the somatic NF1 mutations. So there are different types of neurofibromas. Cutaneous neurofibromas are benign tumors. They develop from the tip of the nerve, limited to the skin, and represent as nodule or plaque. They usually develop in teens, but can develop early, and they tend to increase in number and size, particularly in pregnancy. They definitely have impact on quality of life of the patient, and notably, they never become malignant. So the other neurofibroma, subcutaneous neurofibromas, are located underneath the skin, and they are indicator of increased internal tumor burden. Then we have spinal neurofibromas, which are associated with spinal nerve. They can cause motor and sensory deficit. So there are two types of families with the spinal neurofibromas. The first one have classical features of NF1 and have only a few tumors associated with spinal nerves. The second type have bilateral spinal tumors, and in these families, there are only few capsular spots, but you don't see freckling or cutaneous neurofibromas. So it has a milder phenotype, and my lab and other centers have shown that these patients have excess of splice site and missense mutations. Then plexiform neurofibromas, they are usually congenital. They grow along the nerve and are associated with nerve fascicles. They can be quite disfiguring, and about 10 to 15% plexiform neurofibromas can become malignant. They can get transformed into malignant peripheral nerve sheath tumors or MPNSTs. Selumetinib, which is a MEK inhibitor, was approved in 2020 by FDA, and it has been used to treat inoperable plexiform neurofibroma before the age of 18. And this drug, although it does have its side effects, but is proving to be promising for plexiform neurofibromas which cannot be operated in children. Okay, so the next type of neurofibroma is atypical neurofibroma or atypical neurofibromatous neoplasms of uncertain biological potential, in short, ANUB. These, the key signs of concern for ANUB include pain, elevated submax, and growth. Although these signs are not exclusive to ANUB, they are really the precursor lesions to MPNSTs. They are frequently symptomatic, and these tumors are associated with pathogenic variant in CDK and 2A. And most importantly, early detection and management of ANUB is a possible strategy to prevent MPNST. So MPNSTs are present, well, the lifetime risk of developing MPNSTs is 10 to 15% in NF1 patients. This is a rare malignancy, and about 50% of MPNSTs are associated with NF1 and are highly aggressive and are their major cause of morbidity and mortality. 5-year survival rate could range from 20 to 65%. Currently, we have lack of immunological and molecular markers to make accurate diagnosis. Surgery is the primary treatment, and these tumors are often resistant to radio and chemotherapy. Poor survival and poor outcome because of delayed diagnosis or poor therapeutic success has proved to be challenging. So in my lab, okay, so the primary risk factors for development of MPNSTs include NF microdeletion. Now, about 5 to 10% of NF1 patients have microdeletions. So in these patients, it's not just the NF1 gene which is deleted, but there are 13 genes in this region which are deleted. And and these patients represent with severe disease features. The other risk factors is previous radiotherapy, high total number of internal neurofibromas, atypical neurofibromas, and in rare cases, you can have neurofibromatous neuropathy and a previous family history of MPNSTs. Clinical examination alone does not always discriminate between benign and malignant tumors in NF1 patients, making it challenging to accurately diagnose malignancy at early stages. So in my lab, we wanted to define the molecular basis of MPNSTs and other tumors associated with NF1, because we feel it is important to elucidate genetic mechanisms by which inherited and acquired mutations lead to the development of tumors. And to understand the molecular basis, we ask few fundamental questions. What causes the development of tumors in NF1 patients? Is there any interaction between germline and somatic mutations? What are the mechanisms controlling age-dependent development of tumors? And what is the underlying mechanism which is involved in transformation of benign tumor into malignancy? So to investigate these, we first defined the somatic mutation spectrum of NF1 in different tumor types. We then looked for copy number changes in benign as well as in malignant tumors. And then finally, we focused on exome analysis. So this is just using a targeted array, we found that many genes were amplified in MPNSTs but not in the benign tumors. And similarly, genes were deleted in MPNSTs but not in benign tumors. Then we used another platform, 32K whole genome back array, and we found similar findings. Then we went on to analyze our samples with Affymetrix genome-wide SNP6, which also allowed us to define a pathway which was likely to be impaired in MPNSTs. And then we finally focused on exome sequencing. So we used exome sequencing for a panel of MPNST, plexiform neurofibroma, and cutaneous neurofibromas. And interestingly, we found that we found somatic mutation in this gene, SUS12, which mapped to the deleted region of NF1 patients. We found somatic mutation or recurrent somatic mutation in SUS12 in MPNSTs, but not in the benign tumors. Now, SUS12 here is a component of a complex called PCR2, and the function of, or the role of this complex is to silence gene by trimethylation of lysine 27 of histone H3. When SUS12 or EED in MPNST samples is deleted, this complex becomes inactivated and is no more able to silence genes through methylation of lysine 27. As a result of this, lysine 27 becomes acetylated, and then it combines with BRD4, which is a bromodomain protein, and this then regulates the transcription of genes. So what we have shown, we published our findings in collaboration with Eric Ligius and Karen Chichowski from Boston several years ago. And we were able to demonstrate that in NF1, you have a genetic, if you look at the genetics of NF1 loss, results in activation of RAS-MAPK pathway, which results in cell proliferation and differentiation. Simultaneously, deficiency of PRC2 components decreases the trimethylation of lysine 27 levels, thereby contributing to acetylation of lysine 27, further elevating the transcription of RAS-regulated genes. So this was an interesting finding, and it also offered a target for inhibiting a target for treatment for MPNSTs. And the Boston group was able to show that mice that were heterozygous for NF1, P53 and SUS12 were treated with the bromodomain inhibitors plus the MET inhibitor, BEC inhibitor, and significant shrinkage was noted in these mice. So this slide here shows 4 different MPNST tumors. The top one doesn't have mutation in SUS12, but the next 3 have different mutations in SUS12, and you will find, as a result of mutation, the SUS12 is absent in the MPNSTs, and also we find the absence of the trimethylation of lysine 27. So this is sort of a useful biomarker for the detection of MPNSTs. So this slide just summarizes the development of MPNSTs. So Schwann cells have a germline mutation, and then for the plexiform neurofibromas to develop, somatic inactivation occurs in the wild type copy, and then loss of CDKN2A in Schwann cell results in ANUB, and further inactivation of PRC2 results in MPNSTs. So you might ask, is the mechanism of development of sporadic MPNST different from those associated with NF1-associated MPNST? And the answer is, it is believed that these sporadic MPNSTs arise via different mechanism. But what we have shown is that about 90% of sporadic MPNSTs have mutations in SUS12 and EED. There are several ongoing clinical trials for MPNSTs, but we're still waiting for the results. So, looking at the future perspective of MPNSTs, identify the biomarkers of MPNST and their validation in preclinical models are critically important to the success of clinical trials. And what we really need in future is a comprehensive database, including genomic, transcriptomic, phenotypic, metabolomic data, drug treatment responses, and tumor microenvironment niches is requisite for accelerating our understanding of molecular basis of MPNSTs. And finally, in summary, what I've discussed is that rasopathies are caused by pathogenic variant in genes encoding for component of RAS-MAPK pathway. NF1 gene product neurofibromin is a tumor suppressor protein. Biallelic loss of NF1 alone is not sufficient to induce tumor formation. MPNSTs exhibit both genetic and epigenetic changes. And I think our study has demonstrated that trimethylation of lysine 27 in histone H3 is a biomarker for MPNSTs. So I'd like to thank all my collaborators, and I think I'm finished in time. Thank you very much for listening to me. I'm happy to take any questions. Yeah. Have you got a mic? Yeah. Selumetinib is a MEK inhibitor, and it is already being used for treatment of inoperable plexiform neurofibromas in children under 18 years. Yeah.
Meena, thanks. That was really, really excellent. I just wanted to ask you that, has your lab looked at neoplasia in other rasopathies? So has your lab looked at neoplasia in other rasopathies, for example, rhabdomyosarcoma in Costello, JMML in Noonan? Have you looked at other neoplasias other than just the NF1 related ones?
I think we know, but the answer is we haven't looked at the
You have
rasopathies. My focus has
always been NF1. Thank you.
yes, another syndrome which I've studied in detail is Legius syndrome.
But you don't have neoplasia there now. No. Thank you.
Thank you very much. That's good.
Thank you so much, ma'am, for this exceptional talk. It is an honor for me to introduce our next distinguished speaker, Dr. Vijay Patil, an internationally acclaimed medical oncologist, currently serving as the professor and head of oncology at PD Hinduja Hospital, Mumbai. Prior to this, he held the position of professor in medical oncology at the renowned Tata Memorial Hospital, Mumbai. He is a leading authority in head and neck cancers, brain tumors, thoracic cancers, and urological malignancies with over 16 years of experience in the field. He has authored more than 500 publications and has been the principal investigator for over 30 clinical trials. Dr. Patil has recently received the esteemed Adley Research Award in recognition of his exceptional contributions to oncology. His dedication to advancing medical knowledge has opened new frontiers in the field and offers promising solutions to critical challenges. We thank you, sir, for taking your time out from your busy schedule to be here with us today in Jaipur and for inspiring fellow scientists with his remarkable work. Please join me in welcoming Dr. Vijay Patil to the stage to share his insights and knowledge on the topic, genetics, diagnostic workshop, and treatment principles in rare cancers.
So Aditi, if you permit me, I'd like to add that Vijay is one of the few people who is a out-of-the-box thinker, and I really truly admire him for that. And he is also the founder of like a new initiative which is known as the Sun Tech Center in Mumbai, which is focusing on cell therapies for solid tumors. So Vijay, we look forward to hearing you talk.
No, I don't have banda, just मैंने को भेजा था ईमेल किया था मैंने और सुबह अभी हाँ ईमेल से निकाल लो हाँ दे दो नो इश्यूज Sorry for the delay. Give me a minute. No, that's okay. Don't worry. Yeah. So So rare cancers, let's not waste time. So I am a clinician and I'm not going to bore you with genetics and stuff. I'll tell you how things you do in clinic and what we do in clinic when we come across rare cancers. So the interesting thing is the definition of rare cancer also differs across the Atlantic. NCI says any cancer which incidence is below 15 per 100,000 population. The Europeans say 6 per 100,000 population. Now the issue in India is that our population is large. So even if we say in this definitions, if we see even ALL in India would come into a rare cancer. Ewing sarcoma also would come into a rare cancer. Even nasopharyngeal cancers would come into a rare cancer in India. But just because of the sheer number of our population, we all see many of these patients very routinely. So what I am going to use is primarily when the cancers are seen uncommonly, which means those which are not accounted by the Globocon database for India, I would be talking them as a rare cancer for this talk, which means we don't have good level 1 evidence how to treat these cancers. Now this has already been talked about. Now any rare cancer, whenever you diagnose, the first thing which you do is please follow the conventional diagnosis. If in conventional diagnosis you come across, and let me talk by giving examples, you come across a midline tumor in the nasopharyngeal area, the conventional diagnosis cannot just say that it's nasopharynx. That's the time you think about genomic sequencing or RNA sequencing, because you might be looking at a nut-related primary, and you might think about doing a nut mutation in this situation. Same way, any tumor in the midline and you're not able to get a diagnosis, it's coming as a poorly differentiated cancer, then you may want to have a word with your pathologist about doing sequencing to look at whether this is actually a germ cell tumor or not, which is there in the midline. So the wisdom here is, if your conventional diagnosis works, if your conventional methodology gives you a diagnosis, please do not go for any sequencing or anything. If it doesn't work, then it needs to be put up in a multidisciplinary tumor board. You need your pathologist, you need your radiologist help to be taken, and then you go for integrated analysis of such tumors. Now there are multiple publications which are talking about work which is done from University of California on identification of ovarian immature teratomas, or work which is done for identification of rare histologies like squamous cell carcinoma in prostate from the Quidingo municipal hospitals. But the basic principle here remains, if conventional protocol works, then stop there. If no, then go for sequencing. As I told, I'm a clinician and I'll discuss more about management. First thing is, if you have a rare tumor, know the key differences with the common cancers. And to give you an example of this, I'm going to choose mucosal melanoma. Very uncommon tumor seen in India. And let me give an example of adjuvant therapies, how we see with respect to mucosal melanoma, with respect to cutaneous melanoma. Even cutaneous melanoma is uncommon in India, but mucosal melanoma is far uncommon than cutaneous melanomas. Now what we see here is the incidence is very low, and I want you to see on the targetable mutation, which is the last column. When you look at cutaneous melanoma, BRAF mutations will be seen in 50% of the patients. But in mucosal melanomas, only 3 to 15% of the patients would have BRAF mutations. Now, even the treatment pattern for these two therapies differs. And this is where, just because both are labeled as melanoma, doesn't mean both will be responding to same kind of treatment. And just to prove that point, this is a good phase 2 randomized study done by our Chinese colleagues, in which mucosal melanomas were treated after surgery with interferon versus cisplatin and temozolomide. This was a phase 2 study which showed that cisplatin and temozolomide in mucosal melanoma gives good results as opposed to interferon, which gives good result in cutaneous melanomas or immunotherapy oriented. This further was again a phase 3 randomized the Chinese were able to do, and that's a very commendable job. And that did prove that in this situation, the chemotherapy is actually better than immunotherapy for cutaneous, for mucosal melanomas. Again, just to make a point, just because the words are similar doesn't mean this biological behavior of this treatment is similar. Now, this is to show you the data of cutaneous melanoma when resected, stage 3 and stage 4. If you give adjuvant nivolumab or ipilimumab, they do much better. But these results have limited applications with respect to mucosal melanomas. Similarly, BRAF mutation is common in mucosal melanomas, again has limited application application in mucosal melanomas. So the first point, if you have a rare tumor, something like a mucosal melanoma, you need to gather samples and see the genomic data of this. Your mutation profile may differ. Just because it is a melanoma does not mean it will follow the same pattern that the common tumor is planning. You need to have studies to be done in this situation also. And I'll give you an example of palliative treatment here also. And we all know that today if you get a melanoma, obviously immunotherapy would be the choice for palliative treatment. But this hardly works in mucosal melanomas. The response rates in mucosal melanomas for immunotherapies are below 15%. Dabrafenib trametinib would work only if at those 5% of mucosal melanomas in which the tumor is present. The second thing, as clinician, you need to be aware of, you need to be aware of small data sets. Now, when you have small data sets, retrospective data sets or data sets which are gathered across multiple countries or multiple institutes, and we try to do a match pair analysis or something, please understand that there are going to be bias in this data set, and you need to use your common sense to see whether this bias does not percolate in your clinical practice decision making. And to make that example, I'm going to take example of another rare tumor, which is salivary gland tumor. Now, salivary gland tumors, when they are resected, there's always a debate whether you give radiation or chemoradiation. Radiation is like, it has been traditionally there for 100 years, not much studies have been done, so it's given. So the debate actually is whether you want to add chemotherapy to radiation or not radiation. Now, these are the standard indications which would be debated upon. Now, there is evidence in favor of chemoradiation and there is evidence in unfavor of chemoradiation, and I'll use this example to explain how the small data sets can skew your findings. When you look at the data sets which are in favor of chemoradiation, these are being done by propensity matching. So these have been matched for multiple factors, or what we could say adverse prognostic factors this tumor had. For example, if the tumor is large, the tumor has margin positivity, tumor is poorly differentiated, tumor has lymph nodes metastasis, which are likely to fail more. When you match these factors, you do see that there is certain advantage of giving chemotherapy in this situation. Now, but if you look at few other data sets, and if you don't match, like you see that histologies have not got matched, grades have not got matched, tumor size have not got matched, or nodal status have not got matched. And if you do the analysis for this, obviously those patients who had poor prognosis were the ones who received chemo with radiation. And hence, when these data sets are seen, you would see that it would actually show that if you give chemotherapy with radiation in these patients, it actually leads to poor outcomes. These poor outcomes does not mean that actually chemo leads to poor outcomes. This means that the patients which were selected were biologically bad and they were not adequately matched. So we need to understand that in such situations, we need to have a better propensity matched analysis in these situations when you are dealing with such data sets, especially in rare tumors which are coming from multiple institutes. Let's look at another use. Use of integrated diagnosis and use of genomics can help in rare tumors. Now this time I'm talking about the treatment of these tumors. And again I'll give you an example of salivary gland itself. In salivary gland, if you give chemotherapy, it would give you a variable response rates, and it differs across institutes, but more or less the response is in the tune of around 10 to 20% only. But if you start looking at molecular pathways and oncogenes which are involved in salivary glands, you would get a lot of targetable genes, maybe BRAF, maybe NTRK, maybe TRK kind of BRAF kind of mutations. Now this is a data from Tata Memorial Hospitals which has just now got for publications, showing that even in India mutations are present in nearly 63% of patients of salivary gland. And if you classify them with respect to whether the androgen receptors are present or not present, you would actually see a difference. When the androgen receptor negative, you get a lot amount of c-KIT mutation which responds to imatinib. And if you classify this according to the histopathology also, you would start seeing that in certain types like salivary ductal carcinoma, you see a lot of HER2 positive cases which can easily be targeted with agents like trastuzumab. And does this benefit? Yeah, it does benefit. You will see that the response rates are higher when you use this targeted therapies in in principle, and this has been seen even in our database, where if you use targeted therapies which are appropriate according to mutations, then this patient do better. And just to give you one more example, that you saw response rates of around 20%. If it's an NTRK fusion which has been seen, then the response rates are in the range of around 60 to 70%, and the duration of response is around 2 years, which actually changes the course, which the way these patients would be treated. So the point which I'm trying to make here is, even for the treatment of these patients, you need to have some integrated genomic data to look for mutations in these patients. Up till you get a big data sets which defies that there are no mutations in such patients, you need to do it because no one knows whether they may have a mutation or they may not have a mutation. Now, magic drugs like immunotherapy may not always work. There is a habit that, okay, immunotherapy like checkpoint inhibitors, they work in head and neck cancer, they work in lung cancer, so they work in all kind of rare tumors. Now, we need to be aware that data are there, and again, I'll take an example, salivary gland. I am actually a head, neck and brain tumor specialist, so most of my examples will be from head, neck and brain tumor, is that in such situations, the progression-free survival which immunotherapy adds is only around 4 months, and the response rates which the immunotherapy adds is below 10%, suggesting that initially you may use it in few patients, but you need to do data collections to study whether these drugs which are effective in other tumors, whether they add into any advantage or not advantage. Now, many times in rare tumors, you need to base your decisions on case reports, case series. And the regulatory authorities have to also be aware that you may not get data sets which have huge patient loads. You may have to rely on data sets which have limited number of patients. You may have to rely on statistical methods more from going towards Bayesian statistics, in which in a fewer number of patients you might be able to get an answer. And those of you who do active research, normally we try to keep the type 1 error to a lower side and a type 2 error on a higher side. In a rare tumors, it might be a situation in which you may want to have the type 1 and type 2 error going nearly at the same level, or else you may not find an adequate sample size to make such a decision making. And I'll give you an example of schwannoma, and this is a New England Journal article, and this is about hearing improvement in neurofibromatosis type 2 patients of schwannoma. And what it did brilliantly was, it was a logical thinking that in schwannoma, in neurofibromatosis 2, you have, if you look at the histopathology, there are blood vessels around. These blood vessels are leaky, so they leak water inside the tumor. So obviously the tumor swells, and because the tumor swells, the hearing power of the child decreases. So what they did was, they put the patient on a pure tone audiometry monitoring, and when this hearing decreased, at that time they get bevacizumab to the patients, and it was given to till there is a clinical improvement hearing and the PTA, pure tone audiometry findings were stabilized, and then the patient was kept on observation. And the patient, after that, they kept doing pure tone audiometry to check for whenever there was a decrease in the pure tone audiometry, then they would again give bevacizumab. Very logical, very interesting, and very innovative way of doing research in such kind of situations. And we need such innovative ways of looking at such research. I'll give you an example of something which we developed in Tata Memorial Hospital called metronomic chemotherapy, and that was developed especially for head and neck cancers, because most of our head and neck cancers are manual laborers, and so they cannot afford the routine chemotherapies and immunotherapy. So these are basically our drugs which are available, who are lost patents, and we would give them at 1/10 of the maximum tolerable dose. And we had done previous phase 1, phase 2, and now phase 3 studies also to prove how these drugs act, mainly by anti-angiogenic methods, and how effective they are. What I'm going to show you an example of is the effectiveness of these drugs in hemangioendotheliomas, and this is an example of a lady which I treated in 2018. And she had a lot of scar and nodules over the neck, and she was not willing for any chemotherapy. So we gave her endoxin, 50 mg, and that was the metronomic dose of endoxin, which is given for 20 days on and 10 days off. And she did not wanted to take break. She was basically a fashion designer, did not wanted to take a break from any of her work. And what you could see is over the period of time, the tumors completely getting disappeared. And this is the PET CT scan of the same patient, just to show that objectively also it completely disappeared. Such things need to be developed in such therapies. The issue is none of us would have enough numbers. And so collaboration is an important principle for development of therapies in rare cancers, and you need to have innovative designs. You need to have master protocols like umbrella design or a basket trials in which multiple of these patients are treated with either multiple therapies or multiple therapies are been tried in a single disease, which can effectively use this resource which is rare. And in a country like us, this is possible because of the sheer numbers which we see. I'll give you an example of basal cell carcinoma and how nicely this was done in this study, in which though the numbers which you see are 1,227, the data which I'm talking about is applicable only in 30 patients, in which they tried vismodegib in this international trial, and which they did show that this has a response rates which are around 66.7%. Suggesting that if we accumulate data, we can come up with good data. Now, if you don't have data, common sense is very important in treating. This is there for every cancer, but more so for things like, and I'll give you an example of external auditory canal or temporal bone diseases. Now, they do very well when they are T1 or T2, but when they are like this, when they are like T4, which has destructed the whole tumor, come out. If most of the external auditory canal tumors in India have squamous cell carcinomas, we have a good wealth of data of head and neck squamous cell carcinoma research which has happened in India on development of metronomic chemotherapy, low dose immunotherapies, and even repurposing of certain drugs. And in such situations, it might be worthwhile trying such agents, because they can give to quite a bit of remarkable results in such situations. Now, I'll give you one more example, meningiomas. As I told you, most of my examples will be of CNS or head and neck. Now, meningioma, it's not rare, it's very common. But the problem is, when it recurs, those type of meningiomas are rare, and when they recur and you exhaust surgery and radiation option, at that time systemic therapies options have been tried, and none of the systemic therapy options actually work in meningiomas when you have such malignant meningiomas. We actually at present running a clinical trial to see if we can repurpose gemcitabine in this recurrent meningioma. It's a 30 patient trial, and over the last 6 years we have been able to recruit only 24 patients. I think we should be able to finish in the next one and a half year to see whether this works or not works. Now, do innovative treatments now like CAR-T, TCR, or do they work in such kind of tumors? We don't know, only time would tell. But just to give the flavor, we have a TIL therapy which has now got approval for advanced melanomas, and this approval came in March of 2024. This year of 2025 is supposed to be the year of TCR receptor therapies, and just 2 months back we have got FDA approvals for TCR therapies for advanced synovial sarcomas. This would be one of these. Most of the therapies are based on mutation analysis and on presence of unique neoantigens on this or on the cell membrane of these patients, and maybe the way forward. So what do I conclude here? The incidence is low. So you would always have a small number of clinical samples. So it would come back to collaboration. You would have lack of standardized protocol. Institutes will have different protocols. So again, it will come back to collaboration. You would have delayed diagnosis due to rarity. So you need to have tumor boards, or you need to have tumor boards for rare tumors. So it will again come back to collaborations. We need to talk to our regulatory authorities together. They won't hear to one voice, that there are economic challenges in developing drugs for rare tumors. There is no market for that, and at the end of this, if there is no market, no pharma company is going to use it. So we need to have innovative design. So again, it would come back to collaboration. So for me, rare tumors is all about collaboration and collaborative research, because just because they're rare doesn't mean that we leave it to level 5 evidence. We need to generate, and it's our responsibility to see that we generate at least good level 2 or level 3 evidence in these cancers. Thank you.
Thank you, Vijay. I think that was a really difficult topic to speak on, and you did a fantastic job. Like, my question to you is that if you have a rare tumor in which very little literature is available regarding treatment, is it justified to do an NGS and look for potentially targetable genetic mutations in all cases?
So,
And how wide
yeah.
do you want the genetic panel to be?
So what we do, I'll let you know, sir. We have a rare tumor clinic which runs in Tata Memorial Hospital, and it's open for nationwide. Any institute can present the case, and there are at least 24 to 30 experts who are there who have been seeing rare tumors. So the way I do it is I would take it to such tumor boards to discuss the case. Now there is a very thin gray zone here. It will depend upon the patient profile also. If the patient is young, the patient is failing, his performance state is 0 to 1, I've used whatever there was in literature, then yes, I would definitely offer the patient NGS, and if the finances are there. If the patient is 80 years old, his performance status is not great, he has multiple control comorbidities, then I may not be fighting. But I would always take an opinion from multiple people who have previously treated such tumors which are there in the rare tumor boards, and they do give some logical advice in this situation. So.
Thank you. Any other questions?
Thank you for this interesting presentation. I was wondering, so in genetics we also started with phenotype first and then we changed to genotype first. Might this also need maybe an approach you might need if you start collecting worldwide data? So not from the phenotype, but starting with the genotype. Of course, it needs an enormous effort, but then you get all the data all together. Especially for rare disorders, this will be important, but someone has to take the lead there.
Sir, I completely agree with you, because in rare tumors, especially because 50 to 60% of them many times have a genetic cause also associated with them. So a genotype first data would be the way forward. The problem in country like India is genomic profiling is still quite costly. So in my practice, when I sit on the private side, out of 100, all 100 patients would do it. But on the general side, where nearly 60% of our population would be there, only 10% of the population can afford the genotype data. So we need to have a kind of a, but we can contribute to biopsy samples. The patients would be, because no one treats in India or even globally without doing a biopsy in these patients. And we do take, we have very good surgeons and interventionists, so we do take a lot of specimens in the samples. So if there is an initiative like such, I would really like to have your number, and I would put with my colleagues from Tata Memorial Hospital so that we can actually do a collaboration. Because though we say it's a rare tumor board, let me tell you, every rare tumor molecular board which happens weekly, we have at least 35 to 40 cases which are discussed. And so it's a huge, big amount of database which we have.
It starts with 1, 2, 3,
Correct.
4. Just start.
Yes,
yes. And try to set it up worldwide.
Correct.
If you have special interests, I think.
Correct. Thank you.
Thank you so much, sir. We are privileged to have Dr. Geeta Kadyaprat with us today to share her knowledge, vision, and expertise. Dr. Kadyaprat is an esteemed senior consultant in breast surgical oncology and oncoplastic surgery, currently leading the Apollo Women Center in Delhi. She dedicated her career to advancing cancer care and raising awareness about breast cancer. As the founder president of the Comprehensive Breast Collaborative Society and the Delhi Breast Care Oncology Group, she has been instrumental in shaping the landscape of breast cancer treatment and education in India. A leader is the one who knows the way, goes the way, and shows the way. Dr. Kadyaprat co-founded the Bliss Foundation, an NGO that strives to create awareness, educate communities, and offer support to cancer patients. Through her leadership and mentorship, she has influenced countless young oncologists and empowered patients to face cancer and knowledge and hope. Her dedication to excellence is evident with over 50 publications in prestigious journals and her recognition as an ET Inspiring Women Leader Awardee in 2022. Thank you so much for sparing your valuable time for this conference. May I invite you to please deliver a talk on clinical genetics and approach to hereditary breast and ovarian cancers. Over to you, ma'am.
Thank you very much for the kind introduction. I thought we're going to see more students here because not going to be talking about rare cancers. I'm going to be talking about actually the commonest cancer that afflicts women in our country and I think abroad as well, that is breast cancer and ovarian cancer. But what is rare is how many of them come forth for genetic counseling and testing. So mine is a very, very basic lecture. It's just to share my acknowledgements. So, we constantly badger with our genetics consultant just to figure out which is the way that we are going in terms of unraveling the genetics of both breast and ovarian cancer. But although this is a syndrome that we are aware of, hereditary breast ovarian syndrome is something that we commonly deal with. And slowly we realize that, we are getting to a point when patients are more forthcoming and also clinicians are more forthcoming in offering genetic counseling and testing. And a lot of times what happens in our country is that if there is a test available, you'll find that a lot of people go for the test without actually going for a counseling, which I think is not the right way to do it. So I'll just take you through what we should be doing. So we do know that all cancer is genetic, but not all cancer is hereditary. So if you look at breast and ovarian, we would say 5 to 10% of it is hereditary. So we do know a larger number of cancers are sporadic. When we talk of hereditary cancers, we do know that every cell in the body does carry that mutation which has led to the cancer. So why should we be diagnosing hereditary breast cancer? We should know, to do that, we should understand why cancer develops and how we should be able to guide medical care. And we have to clarify personal cancer risk because the patient often comes up with this question, why did it happen to so many in my family and what is my risk? So that is what we need to clarify. So there are various red flags to look for and this is pretty straightforward. If there are multiple cancers in the family, that's a red flag. It could be 2 or more primary cancers in the same persons or 3 or more on the same side of the family, whether it is the father or the mother. If there is a young person with any of the cancers, which could be breast, ovary, pancreatic, uterine or prostate under the age of 60, that's a red flag. And since we're talking rare cancers, so male breast cancer is pretty rare. There are many people who believe that it does not happen in men at all, but 1% of all breast cancers happen in men. And ovarian cancers, again, not so very common, but yes, it is coming to rise in our country. And triple negative breast cancers are rarer in the western part, but in our country it is close to 20% of all breast cancers. Ancestry, certain races are known to have more of breast and ovarian cancers. The Ashkenazi Jews are very well documented. And interesting, even in our country, there are pockets of various races or families where you find a lot of clustering of breast and ovarian cancer. And testing for a known familial pathogenic mutation is, that is, if there is a known familial pathogenic mutation, then of course that's a red flag for the other person to get tested. And multiple generations, if related cancers are seen in multiple generations. And tumor testing may also suggest a possibly hereditary mutation. So if you find a red flag, which genes to test for is the question that one needs to ask. And a lot of times we find that in our country you would see that patients just get tested for a BRCA1 or a BRCA2. Actually, the story may be much more than that. And if you get a BRCA1 or a BRCA2 negative, that does not necessarily mean that the patient is not carrying a mutation. So I think we should be looking for more. So it is a multi-step process. So you have to identify at-risk patients. provide pre-test counseling and consent the patient through the process and select and offer the test which is most suitable to that patient, and then disclose the result. And once when you disclose the result, there has to be a post-test consult on what it entails and follow-up. So a lot started happening after Angelina Jolie. There are actually a lot of patients in our situation where you have a breast cancer on one side, they may not even get a genetic test done and still want to have the other breast removed. And I think there was a spate of such events which happened in the US also, because I remember in early 2000s, breast conservation was to the tune of about 70 to 80% in the US, and that reversed after post Angelina Jolie, and there were many more mastectomies happening. Even prophylactic mastectomies really shot up after Angelina Jolie. So what we need to do is, in the pre-test, you would be looking at a full pedigree analysis. In our country, again, if you look at how we were to do a pedigree analysis, the information would possibly be limited to just a couple of generations prior to us, and you may have absolutely no knowledge of what happened in generations prior to that. But even 2 generations prior is a good place to start. A risk assessment has to be done, and personal cancer risk has to be related to the patient. What are the genetic test options? What are the options for risk assessment? And also, you have to support the patient. It is not an easy time to be, and even during genetic counseling, the patient can be very anxious. And then there is the post-test counseling, where again, you will be discussing what needs to be done with that patient, but also what is going to be the likely risk of passing on the mutation to the offspring, and what about cascade testing in terms of the at-risk relatives, and of course the psychological implications. And I would also add the social implications of such tests should be discussed in the pre-test counseling as well, because then you may just choose not to have the test at all if you think it is going to affect, have social issues which can arise out of knowing that you are a mutation carrier. So this is the usual process of genetic counseling, like I've already told you. So all this needs to be placed on the table. And so these are the various kind of results that you can expect out of genetic testing. One is a very clear positive, the other is a negative, but the trouble is when you have a variant of uncertain significance. So what we started off with was just the familial information that we had, and then we used to do single gene testing. But with the human genome being unraveled, we have moved further, and we are on to multi-gene testing and also site-specific testing. So it is very clear, almost all organizations, for us, the American Society of Breast Surgeons and also the ASCO, ESMO, all of these say that breast surgeons and other trained cancer liaison staff with in-depth knowledge of genetic testing indications can provide genetic testing services and recommendations. The only issue is for the clinician, it can be a tough ask considering that there are so many clinical responsibilities to be taken care of. So it is always good if you can have counselors who are trained to do the same. And not just BRCA1 and BRCA2. If it does not, it should not be limited to just BRCA1 and BRCA2, although we do know that about 25 to 30% of hereditary mutations in breast cancer are BRCA1 and BRCA2. We should be looking at other mutations as well. And so is the case with ovarian. So all women diagnosed with epithelial ovarian or fallopian tube and peritoneal cancers should receive genetic counseling and testing. So, these are the most common hereditary breast cancer genes, like I told you, the BRCA1 and BRCA2. So if you look at the increase in the lifetime risk for those who carry these mutations, so the breast cancer risk is pretty high. In BRCA1, in fact, it can be close to an 80%, with about 70 to 80%, and with BRCA2 close to 40 to 60%. And the ovarian cancer risk is also high, as are other cancers like male breast cancer. So if you compare it with the general population, it's quite a significant risk if you were to be carrying these mutations. So as we have grown in experience, and as the field of genetics continues to advance as we speak, the uptake of hereditary cancer multi-gene testing has also gone up. So comprehensive multi-gene testing is what is the order of the day. And you can see, while we know that the BRCA and 1 and 2 contribute to close to 48% of the known pathogenic mutations, but an equal number of non-BRCA mutations also exist, although our knowledge regarding what is the kind of risk that we can assign to those mutations is a little low as of today. But what we are seeing is we have to look beyond what it entails in terms of risk of developing cancer. There are medical implications to it also. So if you look at various genes other than BRCA1 and BRCA2, if it is ATM or CDH1 or CHEK2, PALB2. So now we know PALB2 is possibly the BRCA3 mutation that we were talking about, and there is about a 33 to 58% risk with PALB2 also. And here we need to, if you're talking in terms of how to screen them or keep them on surveillance, then we need to look at breast and MR mammograms to be done at intervals of 6 months, and consider surgery in those who are a BRCA1, prophylactic surgeries in those who are BRCA1 and 2 and ATM gene mutations or PALB2, P10 or P53. But if you ask me how many prophylactic surgeries I've done purely for those who are carrying mutations without having the disease, it's just one. So that is my experience with prophylactic surgeries. But if you look at a Tata Memorial also, they possibly have not done many wherein patients are carrying a mutation and they undergo prophylactic surgeries. So we do know that there is a certain penetrance to the gene to be able to express as disease. So we do know that there can be high penetrance genes like a BRCA1, BRCA2, or a moderate increased breast cancer risk with BRIP1, RAD51C and D. And also Lynch syndrome, interestingly, there is a possible association with increased risk of breast cancer in those with carrying the Lynch syndrome genes also. So like I said, with BRCA1 and BRCA2, there are clearer indications on how to keep patients on surveillance, starting with an annual MRI done between 25 to 29 and an annual mammogram starting age of 30, primarily 10 years prior to the index case is what we're looking at. So when you're doing the pre-test counseling, you should be discussing the various options of surveillance as well as prophylactic surgeries. And that can be kind of the breaker in the discussion whether she wants to go for a test or not. And so like I said, for various mutations, there are various targeted therapies that can be used. So with BRCA1, most of the germline mutations are the one where we do offer treatment in the form of PARP inhibitors. So if there is a germline BRCA1, BRCA2 mutation, then these patients do become a candidate for targeted treatment in the form of PARP inhibitors. Olaparib started off being used in ovarian cancers with carrying the germline mutation, and now it has also been approved for the treatment of germline mutations in breast cancer. So all these genes, if you see even PALB2, so you do get high-grade invasive carcinomas. The BRCA1s are usually triple-negative breast cancers, known to be aggressive cancers. BRCA2 could be ER/PR positive, HER2 negative, and those also have various treatment implications, like you have the CDK4/6 inhibitors that can be used for treating these patients. So a whole lot of genes that we are aware of, but like I said, in the RAD51C, BART1, and P10, we do not have any target to attack them as of today, but I'm sure this is work in progress, and we will be seeing more and more patients being treated specifically for a certain gene mutation. So CDH1, again, diffuse gastric cancer could be there in the pedigree, and you could actually be showing up with lobular breast carcinoma. So that is, again, something that one should be aware of. But again, there is no target to treat these patients. P53, unfortunately, is kind of an across-the-board gene mutation, and you could come up with a whole lot of malignancies for those who have the P53 mutation, but again, no target to treat them. So there are a lot of benefits to genetic testing. You can empower your patient to undergo individualized screening, very, very important, even if they do not want to consider the path of prophylactic surgeries. It gives the patient a chance to make informed decisions and also empowers your patient's family members to access appropriate cancer screening and possibly even opt for a test if the index case carries a mutation. Also, family planning is also an important implication of genetic testing. So if there is a patient who's diagnosed with, a young patient diagnosed with breast cancer, desirous of having a family subsequent to her treatment, so we do offer fertility counseling and do oocyte preservation or embryo preservation. And at the time that she's ready to have her child, the embryo can be subjected to a pre-implantation genetic testing, and those embryos which do not carry the mutations can be implanted, which I think is a great service for a person who's already so caught up with her own disease and doesn't want her children to go through the same. So the challenge with genetic testing is, of course, VUS. This is something that we deal with almost every other day when there is this VUS. So VUS is there to stay, but we know that as the information pours in from various parts of the world and as we continue to populate the genetic database, we will figure out those mutations that we see infrequently today may actually be more significant, and there could be some treatment implications to those as well. So an active follow-up is advised for those who are carrying a VUS as of today. I'll just share this case capsule of a 47-year-old. She's got she had CA breast, and she was ER/PR positive, HER2 FISH negative with a Ki67 of 70%. She underwent surgery for the same. And this is all that is there in the pedigree chart. She had a mother who had breast cancer at the age of 68 and an oral cancer. And she had it, and she, being less than 50, was offered genetic counseling and testing. So this is what came up. She has a VUS in PALB2, not a very common mutation. And she also has a VUS in PMS2. But again, so we had looked up the database, and the last submission on this mutation is October 2024. This is for the Lynch, and for the PALB2, the last submission was May 1st of 2024. So this patient is going to remain on follow-up, and there will be a reanalysis again after 6 to 12 months. She has to ask the genetics person as to whether there is any new information on the VUS. So again, molecular profiling, like I've already told you, various markers which are there, which associated with various genetic mutations leads to treatment options, especially we know of triple-negative breast cancers where there are various targets that we are looking for, because the conventional targets don't work in triple-negative breast cancers. And so is the case with HR positive. Now we do know there is PIK3C mutations, and also we are looking at these are HR positive, so we do have CDK4/6 inhibitors, which by themselves are a big add, and they actually potentiate the effect of hormonal treatment in these patients. So most cancer syndromes are inherited in an autosomal dominant. Some may be recessive. And of course, the risk varies with the penetrance and expression of the genes. And approximately, like I said, 5 to 10% of cancers are hereditary. And the way to go is multi-gene panel testing and not just limited genetic testing. And we are obviously looking towards the future for more medical management of patients with specific gene mutations, and molecular profiling can certainly help guide treatment options. Thank you very much.
Thanks, Dr. Kadayaprat. That was a really nice talk. Just a couple of points. The first was about ATM. So we run a national pediatric AT clinic in the UK, and we've looked at cancer risks in mums of those kids that we see in that clinic. And recent meta-analysis seem to suggest that the overall cancer risk in ATM carriers is actually not up to 4-fold, it's just 2-fold or less. And that 2-fold risk is primarily in ATM PTVs, protein truncating variant carriers, and not so much for missense carriers. There's one specific missense variant, which is Val242 for GLI. That confers a high risk, a very high risk. So maybe for that one, the risk is high. But otherwise, we would not recommend surgery, prophylactic surgery for that cancer. And the second point really was about your VUS situation. So there has been a study published recently. You might find it in, I think it might be in JMed Genet, where they reclassified VUSs over a period of time. I think it was around 2 years. And what they found was that when you do a reclassification, your VUSs tend to become benign or likely benign on reclassification rather than pathogenic or likely pathogenic.
That's nice. That's great news. Thank you. Yes, Doctor.
Okay, a comment for you is, you know, NF1 patients have 5-fold increased risk of developing breast cancer under the age of 50. In my group, we have studied approximately 100 NF1 female with breast cancer. And it's interesting that I mentioned in my talk that about 5 to 10% of NF1 patients have microdeletion.
Okay.
And in our 100 patients, we have not seen any microdeletion.
In the breast cancer patients?
Yeah.
Wow.
So this is interesting because it's obviously indicating something
else.
Potential genotype-phenotype correlation.
Yes.
And I was just wondering whether in your study you've come across any trend towards genotype-phenotype correlation.
So we haven't looked at it, but I think that's a very interesting talk, and I should discuss this with my genetics people to figure out. Because you know there are patients who come with neurofibromas, but it's quite insightful. I will talk to them and figure out. Yes.
Yes, given that these microdeletion patients have increased risk of having malignant peripheral nerve sheath tumors.
Sure.
So thank you.
Yeah. Thank you so much. Okay. Thank you.
Thank you so much, ma'am, for this wonderful presentation. Now we move ahead to a panel discussion on 2 critical topics: genomics in early diagnosis of cancer and the genetics of rare diseases. These areas are reshaping the future of personalized medicine, offering new hope for early detection and effective treatments. For the same, I would like to invite on stage Professor Meena Upadhyay, Dr. Vijay Patil, and Dr. Geeta ma'am again to please take your seat on the dais. And to moderate this discussion, I would like to invite the Master of Masters, Dr. Hemant Malhotra, for his valuable insights and direction. Please join me in welcoming our distinguished panelist and Dr. Hemant Malhotra to the stage as they lead this fascinating discussion.
So hello again. I think all of you would agree with me that we've heard 3 really brilliant talks, quite disparate subjects. So I think we will, if there are any questions from the audience, then we'll do that first. If anybody wishes to ask any of the 3 speakers any follow-up questions, then we can do that first. Okay, so maybe I'll start with Professor Meena. So madam, we see in our clinical practice a reasonable number of patients who have neurofibromas. They come to us with these skin bumps. Some of them have few of them, some of them have lots of them. So how do you assess their malignancy risk, or should you do molecular testing on all of them? And do you do a germline testing? Can you do it in the peripheral blood? Do you need to take a tissue biopsy? So can you elaborate on that?
So first of all, I mentioned in my talk that benign cutaneous neurofibromas never become, they do not have a malignant potential.
Okay.
So it's only the plexiform neurofibromas. In our center, we take a biopsy from the patient's tumor, plus also analyze the germline mutation. I think if you just extract DNA from biopsy, the sensitivity of detection of somatic mutation is reduced because a plexiform neurofibroma has multiple cell types, and it's only the Schwann cells which carry the somatic mutations. So we have also, in my lab actually, we culture Schwann cells from the biopsy and then extract DNA from that and look for somatic mutations.
And can you look for mutations germline in the peripheral
Germline
blood?
mutation is from
These
the
are
blood
germline
sample.
mutations. So you can do the sampling from the peripheral blood.
Yeah, so we look from germline mutation from DNA extracted from lymphocytes and somatic mutation from Schwann cells.
So like similar question to Dr. Geeta. Geeta, I have a 40-year-old patient with triple negative breast cancer, a little bit of family history also. We've done a core to, kind of start the treatment. So you would ask for a mutation testing germline in the peripheral blood, or would you ask for a somatic mutation testing on the biopsy? What is the first thing to be done?
The first would be a germline. We would do a germline testing, so it will be a blood test. So if there is nothing there and then you still think, there is a family history, you're not able to figure out what is happening, then possibly a somatic, but otherwise it has to be a germline testing, yeah.
So, as I understand it, and any one of the panelists can, educate me, germline mutation means that it is there in all the cells, including the tumor cells, right?
Yes,
so why do we not do this? Why do we do the sequence and not do just the tumor? Look for the mutation in the tumor. So whether it is a germline mutation or a somatic mutation, you will pick it up, and the treatment implications are the same.
So for somatic mutations, you would not. The treatment implications are not the same.
Treatment implications are not
so
the
if
same.
you were to do targeted treatment, if you want to use PARP inhibitors, you would not do it in a somatic mutation, you would do it in germline.
You
Yeah.
agree, Vijay?
So the treatment indications vary across to disease, sir. So if this was the case of ovarian cancer, I would have happily submitted it for somatic mutation. Because in ovarian cancer, whether you get somatic mutation or you get germline mutation, PARP inhibitors are recommended. But as she rightly pointed out, the recommendation on 1 year of adjuvant of olaparib is specifically for patients with germline mutation. So in a breast cancer, I would be more asking for a blood related. So it would depend upon how the therapeutic implications play. The therapeutic implications, the approval is for both somatic and germline, then I would first go with the tissue. And if the tissue comes positive, then I would ask for a germline mutation. But if the approval is for a germline mutation, I would directly ask for the blood to be tested.
I think that's a very important and valid point. So one more question to you, Geeta. I'm a little, concerned about the VUS. So you spend a significant amount of money of the patient in getting the testing done, and then you have a mutation, and then you tell the patient, I don't know what to do about this. Is this deleterious or not? I do not know. How do you deal with that? Or you leave it to your genetic counselor to deal with that?
So eventually the patient will ask you, and that is the truth of the matter. We do not have clear-cut answers on VUS. We have to wait it out, and we have to tell her that she has to come back to the genetics person and find out if there is any new information which is reclassified, and it is really, because you just told us that most of the VUS actually classify as benign, but yeah, with experience we will know whether if there is a change in the status of the mutation.
So again, expanding on the same situation, You have a VUS which is VUS today, and it is proven to be a deleterious mutation in, say, 2 years' time, or maybe a year's time. Whose responsibility is it to convey this to the patient? So the patient is lost to follow-up, which is a reasonably common situation in our country, and that particular VUS is now classified as a pathogenic mutation, and the patient or one of the patient's relatives develops a breast cancer. So can they take you to court that why did you not convey to me? Why did you not track me, trace me and convey to me?
So I think the responsibility is both ways. I was just talking the other day to my genetics consultant that there has to be a method to recall the patient after 12 months and give them renewed information on what is the status of the mutation. I think the responsibility is ours as much as it is of the patient, because if anything new comes up, they should be able to flag it up and convey it to the patient as well.
Any questions, comments from anybody? Yes, sir, please.
So I just had a comment about one of your previous questions, Dr. Malhotra, and that was about when should you actually prefer to do testing in tissue as opposed to germline. So there are some tumors, some hereditary tumors, where there's a very high risk of somatic mosaicism. For example, retinoblastoma, neurofibromatosis type 2. And in those situations, you may want to start with tumor tissue if you have it available. Often that's not the case. But if you do have tumor tissue available, that's a better way to go. Do the tumor tissue first, and then come to germline. But yeah, in other situations, you'd probably want to do germline first. But there are some situations where it is preferable to use tumor tissue. So that was one thing.
Oh, sorry, yeah. You're absolutely right, because I think I've had cases in my lab where, as mentioned, you have somatic mosaicism, and then you never find a germline mutation in the lymphocytes. So what we have done, we have taken 2 or 3 different tumors and looked for mutation there, and if we find a variant which is common to all 3 tumors, that is your germline mutation. And that way it's much easier. If we had just relied on blood sample, we would have missed that.
Yeah, so I did say that the situation is a little different in UK as compared to India, because your NHS will probably cover sequential testing, while when you have a economic constraint, which is usual for most patients in this country, then if you can get away with one testing, either somatic or germline, and you would prefer to do that.
There's also another comment which is about not putting too much emphasis on VUSs, because we have had situations in the UK where we have told people that they have a likely pathogenic or a pathogenic BRCA1 variant or a BRCA2 variant. And then on the basis of that information, they've gone on to have prophylactic surgery. And then 2 years down the line, we found out that, in fact, that isn't a pathogenic variant at all. That's likely benign. It's likely benign or benign. We've had to go back and contact those people and say, we're really sorry we told you that. You've had your breast hacked. I mean, but, you can't change that now.
You can't change that, yeah.
So it can work both ways.
Yeah.
So, so I think a VUS is a VUS. And as I said, that, sometimes, many times, VUSs will turn out to be likely benign or benign.
The majority of the times they'll turn out to be
yes.
benign. Yeah.
So it's much more common for VUSs to become benign or likely benign if they are in BRCA1 or BRCA2, because that is a proper study done looking at that.
So like a question to you, I think all of us would be interested in the answer, that what is the percentage, say somebody has a BRCA1 positivity, what is the percentage of ladies with a BRCA1 mutation asking for a prophylactic mastectomy? Out of 100 patients, how many would finally get a prophylactic mastectomy done?
I'm not sure I'm the right person to answer it. I think Dr. Kayapatha may want to answer that.
So he's possibly asking about what happens in the UK. Yeah. Pick up the mic. So he possibly is asking as to what happens in the UK. I'm sure you may not, like you said, you may not be the right person to answer that
I'm not
question.
a cancer geneticist.
Yeah, he's
I'm
not a cancer geneticist.
geneticist.
He's more a pediatric. So in our country, like I've told you, the prophylactic mastectomy without having cancer at all, pure prophylactic because you're carrying a mutation is very, very low.
Very, very low, yeah.
Very low.
That's what my
So like I
impression.
said, I operate about 400 breast cancers a year, but I have only done one prophylactic because the sister was in Canada, very empowered, BRCA1 positive, mother had bilateral breast cancer. She tested positive for BRCA1 and she went ahead with prophylactic breast surgeries and ovarian. That's the only one that I've done in so many years. And I spoke to Dr. Rajiv Sareen, who's got a lot of work in genetics in our country, and he says not more than 5.
Not
Prophylactic.
more than 5 at the...
5 have undergone prophylactic surgeries without the disease, meaning just carrying the mutation.
Risk reduction mastectomy. And does the same hold true for oophorectomies also? Or it doesn't?
So oophorectomies, so this is what we need to, so I'm not a big fan of oophorectomy, but if you're a BRCA1 mutation, you should. And that has to happen between the age group of 35 to 40. But if you're BRCA2, you can delay it a little more. Say 40 to 45 is when you would want to do prophylactic salpingo-oophorectomy. PALB2, no oophorectomy. It has to be just mastectomy, no risk reduction for ovaries.
I had a question for Meena. Meena, why do you see splice site variants and missense variants in schwannomas, NF1s that present primarily with spinal schwannomas?
Yeah,
Why?
I wish I had an answer for that. Yeah, I think to my knowledge, there are only 2 publications based on spinal neurofibromatosis. And both the studies indicate missense and splice site. We have to do more, we require more additional patients to really...
And also with your malignant peripheral nerve sheath tumors,
yeah.
What is so specific about those amino acids, those 5 amino acids in NF1? Do they sit in some particular domain that predisposes to MP-NSTs? Because you said that it's, I think I can't remember, I've written it down.
It is 840 to 844.
Yeah, 844 to 848. Is there something specific about those amino acids, those 5 amino acids?
No, this is a study which was really undertaken by Ludwig Messiah in Birmingham, Alabama. And what she showed in her study is that patients who have mutation in codon 840 to 844 have an increased risk of developing malignant peripheral nerve sheath tumors. And so, again, we need further, we need to evaluate it further, just like splice site and missense mutations in spinal neurofibromas.
So Vijay, like a question to you, when you're doing a genomic profiling for a rare tumor, like how extensive should that be? It should be like 60 gene, 90 gene, 500 gene, and like what is the likelihood of picking up a targetable mutation, and I mean, what do you normally ask for?
So it will depend upon whether I'm doing it in a research setting or whether I'm doing it in clinical setting. If I'm doing it in a research setting, I would want to be it's as extensive as possible so that I get a wide amount of data.
And then probably the research is paying for it also, right?
Yeah, the research will pay for it.
Yeah.
Now, when I'm doing a clinical setting, I don't see any value in doing a whole exome or 1,200 genes or something, because the molecules which are available in India are covered by 70 to 100 genes itself.
Correct.
So the reason why I'm doing it is to offer a treatment. And the treatment which I'm going to offer is if it is covered by 70 to 100 genes, I don't need to do a bigger panel. That doesn't help me.
Very right. So if you have a targeting agent, you look for those targets only. Yeah, kind of, that makes sense. So one more question to you, Vijay. Like would you choose, I'm sorry, you wanted to do a question. Yeah, please go ahead, you.
Is that on?
Yeah, it's working.
I am also not a cancer geneticist, so I'm sorry about that. But I will ask the two Indian doctors about, I'm really struck by the very low numbers of 1 and 5 women undergoing prophylactic breast surgery. I can't give you the number for the UK, I'm a colleague of Dr. Suri's, but I'm sure it is hundreds of women in Nottingham and East Midlands having prophylactic surgery every year, which is a population less than the Malviya Nagar in Jaipur. So what do you think is the reason? Is it the intangibility of being healthy physically, not having had cancer? Or do you think there is a deeper societal, psychological reason behind it?
So maybe Geeta, you can take that.
So it's never easy to convince patients with mutation to have prophylactic surgery. So there is this girl who's 32. She presented with locally advanced breast cancer. She has multiple cancers in the family, and she was being treated. So she has 2 sisters and a brother. All 3 tested positive for BRCA1 mutation. And so I sat the sisters down, the brother was not there, and I spoke to them about prophylactic surgeries. And they're also young. One is 36, the proband is 32, her sisters are 36 and 38. But they won't hear of it, so I said, okay, so you come back to me after, say, a month and we can talk again. In the meantime, they'd seen 3 or 4 doctors, but they did not get it done. So it is very tough. I think it is more about societal pressures also. They don't see merit. I don't know when it will happen, but they don't see merit in understanding that, by doing this, you're reducing your risk by 95% of developing breast or ovarian cancer, whichever way you look at it. And it is a tough conversation, and we have not really found success. And we've had also patients where the sister has been found to have a BRCA1 mutation. She's kind of waiting, and 8 months down the line, she develops cancer in one of her breasts. So this is like sitting on a time bomb. I keep telling them, and I say that if you're not convinced by talking to me, please talk to other doctors also. And if there is any change in discourse, do come and tell me. But I would think that you should seriously consider prophylactic surgeries. It doesn't happen though.
So I may want to tell you that those of us who work in India, we have trouble enough in convincing them to get operated on the diseased breast. So asking them to get surgery on the breast, which is as of just now normal, that's like what Geeta is saying, it's kind of, we face that on a day-to-day basis.
So I presume that this attitude towards healthcare extends across all cancers. So, bowel cancers and other cancers where preventive treatment is available is also low or absent in terms of prophylactic surgery.
Maybe. So I think one of the reasons for this, acceptance and not opting for an aggressive approach probably is like a stronger spiritual mindset, in the sense that they believe that a higher power will take care of them. So maybe that is contributing to it. Yes, ma'am.
Thank you very much. For ladies that do have a mastectomy, for whatever reason, do they have reconstruction? And do you have a support group for people that have mastectomies and perhaps reconstructions?
So the rates of reconstruction, if you put the whole country together, is less than 5%. So in the last, there are 2 components to this. One is the skill set of a breast reconstructive surgeon. So you will have plastic surgeons, plastic and reconstructive surgeons, but you may not necessarily have somebody doing exclusive breast reconstructive work. Because even in the best of hands, you do have issues with reconstruction. So, your adjuvant treatment can get delayed and all of that. So it is less than 5%. So in the center that I'm going to be working in shortly, I am definitely trying to push this up with, trying to create that awareness. So as far as your second question, support group, So I run a very, very active support group, and I've been doing that since 2006. And the NGO is also an offshoot of that support group. That is where it all started. So we address various issues. There's a lot of hand-holding. There's a lot of psychological support, nutrition, fertility issues, bone issues, and all of that is discussed. But reconstruction is not such a huge piece. Only recently, about 2 months ago, we had done a reconstruction, like you said, a breast reconstructive support group, just to make people aware that how important it is to be whole in a real sense. So there are women who want to hear that and want to follow that. But I think we need to put our pieces together. We need to find that person who's going to do a good job. And since the time I've moved to this new institute, in the last 7 months, we've done about 12 reconstructions, which is kind of huge. In the last institute, I would have possibly done just 1 or 2 reconstructions a whole year. But now it is slowly building up, but this is all happening in the private setup. It is not happening in the government setup to which most of our patients go. And you must realize that even today in our country, 60 to 70% of breast cancers present in advanced stages, where the whole fight is just to get and done with treatment, where breast reconstruction doesn't feature.
Yeah, and I would don't know whether you are breast cancer clinicians, any one of you, what is the breast conservation surgery rate as compared to mastectomy rates in England? Is it 90-10 or is it 99-1? And what is the rate in our country, Geeta? Think of both. Maybe Vijay can comment. He's not a breast cancer surgeon or a breast cancer oncologist, but in a government hospital and in a private hospital.
So in the UK, I know it is about close to an 80%, 70 to 80% breast conservations. America has moved away from breast conservations because, like I said, it is a lot about prophylactic surgeries and whole breast reconstructions. That is the way they have gone. So if you look at we have moved a long way since, but this is again limited to private setups. In government centers, it is still mastectomies.
Yeah.
So if you put the entire picture, we are still doing about 70 to 80% patients undergo mastectomies. Even for a 1 centimeter tumor, it could be a mastectomy.
Yeah.
But in my practice, it is close to 50%. Tata Memorial, one of the largest breast cancer centers in the country, it is close to a 60%. So a lot of neoadjuvant treatments happening, downstaging of disease, and conservations happening to a large extent.
Any comments from your side, Vijay?
So, well, now I practice in South Mumbai. So, if you have an educated women, the breast conservation is much higher. It also takes into account that if you do breast conservation, they have to undergo radiation after that.
That's right.
So, working women do take that also into account, that 1 month radiation. Now with the fast forward schedule, 1 week, 2 week, it can get over, but that factor is taken into account, that if you do breast conservation, there needs to be radiation after that.
Yeah. So I can give you a small perspective. I was earlier at the Government Medical College Hospital 5 years back, was there for 30 years. So 90% mastectomies. And here in my present setup, about 40% mastectomies and 60% conservations. So are there any burning questions from anybody? Anybody wants to ask a question at the back? Okay, all right. So we will conclude these panel discussions. I want the panelists to keep sitting here. Aditi has some nice surprise for you. And thank you very much. Please give my panel a big hand, please.
Thank you so much, dear panelist and Hemant Malhotra, sir. As a token of our heartfelt gratitude for our guest speakers today, for their valuable time, insights, and contribution at the conference today, we would like to present them with a memento and a memory that they can take back home. To do the honors, may I invite our organizing chairpersons, Dr. Dhavendra Kumar and Dr. Hemant Malhotra, to please come on the stage to present the memento to our respected guest speakers of today. Can we please have a round of applause for our guest speakers of today? Can I now request Dr. Dhavendra Kumar to please present a token of respect to Dr. Hemant Malhotra for accepting our request to be the organizing chairperson. Thank you so much, everybody. This brings us to the end of the morning session of today. I would like to invite you all for high tea.
So my talk is there, but my introductory slide.
May I request Dr. Suri, Dr. Elting, Dr. Vasudevan, Dr. Shannon, and Dr. Bajaj to please give us their presentations so that we can begin the next session on time. Thank you.
It's here. Yeah. I think Pradeep isn't there.
Yeah, that's fine. That's absolutely fine. एक बार check करो. तो सीधा check करो ये presentations. एक बार check करो.
This is mine. Yeah.
ये मेरा है ऊपर वाला और ये मारियट का है.
So that's okay. ये डॉक्टर मनीष का भी आ गया है. Okay.
ये मैम का है.
Professor Vasudevan.
Categorically mentioned it, so I was like, I'm going to do anything, I'm going to do it.
Is this yours? इनका सेकंड है.
हाँ मैम ये सेकंड ही चल रहा है.
सेकंड ही है ना?
हाँ,
ठीक है.
इनकी पीपीटी है.
ठीक है. अच्छा वो पूरा देखने के बाद ही नेक्स्ट आएगी क्या? Yeah, it works perfectly fine.
And I can do it with this?
Yes.
Yes.
Right. अब नेक्स्ट वो देखो इनका है क्या? प्रोफेसर वासुदेवन.
मैम अब सेकंड में थर्ड में आया सर इसके अंदर.
नहीं ये सेशन 3 है. सेशन 2 में जाओ.
2 में 2 ही आई है.
सेशन 2 में हाँ वो पहली किसकी है? डॉक्टर सूरी की है. डॉक्टर सूरी की और इनकी है. So we need for Dr. Vasudevan, Dr. Shannon, and Dr. Shruti. Please go and have some tea. Sushita, करो यार सब इनको करो. Dr. Pradeep Vasudevan और Dr. Nola Shannon और Dr. Shruti Bajaj.
तो क्या करना है?
Presentations upload करवाओ. फिर 1 घंटा लगाते रहेंगे.
प्रदीप मैम वो जो प्रदीप सर वगैरह की पीपीटीज आपके पास हैं क्या? उनके पास नहीं है.
अभी नेक्स्ट किसकी है उनकी ले लो, फिर उनसे नेक्स्ट में लंच में ले
नेक्स्ट
लो.
इज मोनीश सर.
वो नेक्स्ट की तो हो गई है, पर बाकी 3 की भी तो
हाँ उनसे बात करनी श्रुति मैम तो won't give hers मैम because she's not comfortable she purchases it herself
ओके, बहुत ही खुशी की बात है। अब ये बता दो डॉक्टर नोरा और डॉक्टर प्रोफेसर प्रदीप वासुदेव
वो यहाँ पे थे ये मुझे देखे थे वो है शायद वो बैठे हैं नहीं तो वो तो चैतन्य सर है वो चैतन्य सर है
वो तो डॉक्टर चैतन्य है।
चलो
I think he must have gone out.
मस्ट गॉन
जाके देखो तो सही लगता है। मैं तो ऐसे ही नहीं देखी हुई हूँ।
मैम समोसा खा लो ना 2 ले आओ आपके लिए
दूसरा ही है।
30 का ले आओ कॉफी ठीक है प्रदीप सर एंड यू नोरा मैम ना ठीक है तो आई जस्ट पुट इन अ वर्ड राइट नाउ कि मैम आई वाज देयर आई हैव बीन देयर सिंस पौने 9 पौने आज मैम आज anyone I was coordinating the CVs ma'am that's why I messaged in the morning yeah I'm just please I was under the behind the black box on the faculty group I'll just tell you
हाँ बस नहीं मैं तो वैसे भी बना
I think if I remove this, I won't be able to. I can remove this for the time being. If I don't want it, तभी मैं ये निकाल दूँ. I'm just checking on this. No, yeah, it's irritating me, but it's okay. My legs, it is irritating too much. Why is it not irritating?
Yeah, hi. If anyone needs Wi-Fi access, please contact us.
म्यूजिक बंद करा दें प्लीज.
Namaskar. Good morning, everyone. Sorry, good afternoon, everyone. Welcome back after the tea break. I, Dr. Trapta Goyal, Assistant Professor, Department of Pediatrics, Mahatma Gandhi Hospital, Jaipur, will carry on the further sessions. I hope all of you gained a vast insight from the previous sessions and are now ready for the upcoming enriching sessions full of knowledge and wisdom. We now move on to our pre-lunch sessions of deliberations on genetic diseases. The first presentation is the key lecture on what are birth defects, its classification, and epidemiology. I invite the respective chairpersons for this session to take their place on the dais. Dr. Deepak Shivpuri, Director and Head of the Department, Pediatrics and Neonatology, Surya Hospital, Jaipur. Dr. Kuldeep Singh, Professor and Head, Department of Pediatrics, AIIMS, Jodhpur. Dr. Kusum Devpura, Professor and Head, Department of Pediatrics, J.K. Lon Hospital, Jaipur. Dr. Anurag Sharma, Senior Pediatrician, Secretary, Indian Medical Association, Jaipur. Dr. Kapil Garg, Senior Professor and Head, Pediatric Hematology, Oncology, J.K. Lon Hospital, Jaipur. Since I think nobody is there from this, so I would like to call upon Dr. Priya Marwa, Professor, Department of Pediatrics, Mahatma Gandhi Hospital, to chair this session. I now have the honor of inviting the speaker for this session, Dr. Monish Suri, Consultant Clinical Geneticist, Nottingham University, United Kingdom, to take the stage and grace us with his knowledge.
So good afternoon, ladies and gentlemen, and many thanks to the organizers for asking me to give this keynote address on what are birth defects, epidemiology, and classification. So in my talk today, over the next 25 minutes or so, I'll tell you about terminology, give you a definition of birth defects, talk about major and minor congenital anomalies or birth defects, and then discuss a pathogenetic classification, followed by a clinical classification. Causes were covered yesterday by Dr. Cabra, but I'll just very briefly allude to them again, and then give you 3 examples of environmental causes which are becoming of some importance now. So to begin with terminology, I think it's absolutely fine to use the word birth defects as a scientific word for a scientific conference, for a book, or for a journal. But it becomes difficult to use this term with families. And the reason for that is the word defect. That is pejorative, and most families dislike it. Similarly, congenital defects, again, the word defect is something that isn't liked. And similarly, congenital abnormalities, abnormal is considered pejorative. So I think when you're talking to families, it's probably better to use the word congenital anomalies, or developmental anomalies, or morphologic anomalies, which are all equivalent. It is important to remember to use these terms correctly. So for example,
a malformation is not the same thing as a congenital anomaly. It is one of many types of congenital anomaly, so those are not equivalent words. So here are two definitions of birth defects. The first one is very simple and the one that I prefer. The one at the bottom is from Professor Hennekam's paper from 2013. But I'd just go with the first one. So if you read it, it says alteration of a structure or function. So it doesn't only have to be structural, it can be a functional problem of a tissue or an organ. That word tissue is really important because dysplasias primarily affect tissues, whereas malformations primarily affect organs. So the structure or function of tissue that is present at birth, so it may actually be visible when the child is born or even antenatally, or of a process that begins before birth. So the latter half is actually quite important. So what it's telling you is that the congenital anomaly or birth defect may not be visible when the child is born, but will develop over a period of time. And that is very true of dysplasias. So in dysplasias, you may sometimes get a skeletal dysplasia that's visible at birth, like achondroplasia. Sometimes you can get one that's visible prenatally, like thanatophoric dysplasia. But sometimes the dysplasias will only present much later in life, like multiple epiphyseal dysplasia. So you need to remember that that is still a dysplasia, it's still a congenital anomaly, but it's not visible at birth. So in general, when we talk about congenital anomalies or birth defects, everybody has this figure of around 2 to 3% of pregnancies are affected with a birth defect. So that's the sort of population prevalence. And that's probably correct. In some parts of the world, it might be from 2 to 6%. So these are figures from the UK, and these figures are taken from the UK National Congenital Anomaly and Rare Disease Registration Service, or NCARD-RS, from 2019, and these are available on the web. So the prevalence of major congenital anomalies is 2.16%, so it falls between the 2 to 3% figure that I'd mentioned previously. And the vast majority of pregnancies that have a major congenital anomaly result in a live birth, so 80%. In terms of the organ systems that are primarily affected in the UK, it's cardiovascular, limb, genitourinary, and CNS. So congenital heart anomalies are the most frequently seen major congenital anomalies in the UK. And how important are they in terms of mortality? So if you look at perinatal mortality, perhaps about 1% of perinatal mortality is caused by major congenital anomalies, and similarly 1% of infant mortality is directly linked to a major congenital abnormality or a major birth defect. And again, these are figures from UK NCARD-RS. What about the situation in India? So this is taken from the same source that Madhulika had mentioned in her talk yesterday. So it is the paper by Bhide and Kar that was published in BMC Pediatrics in 2018. And the figure for India is quite similar to the figure for UK, so 1.84 versus 2.16%, so a little bit less than the 2 to 3% population prevalence that we see. And Madhulika had also mentioned in her talk that it's the 5th commonest cause of neonatal deaths in India. Apparently, the leading cause is prematurity. What about the organ systems that are primarily affected by congenital anomalies in India? So it's different from UK. Musculoskeletal, gastrointestinal, CNS, genitourinary, and congenital heart disease is actually 2.3%. And I think that Madhulika mentioned yesterday that perhaps this figure is somewhat skewed because echocardiogram facilities are not available everywhere, and were they to be available, then maybe the figures wouldn't be that dissimilar from what we see in the UK. So coming now to major congenital anomalies versus minor congenital anomalies. So how do you define a major congenital anomaly? So the philosophy is that any congenital anomaly that has significant medical implications or quite significant cosmetic implications would be considered a major congenital anomaly. And there's a list over there. Most of these are malformations, actually. And the figure on your right is of a child with trisomy 18, so Edwards syndrome. You can see the baby is dysmorphic, but baby also has a major congenital anomaly, which is bilateral cleft lip. You can also see that the xiphocernum is a bit short, which is a feature of trisomy 18. What about minor congenital anomalies? So any congenital anomaly that has no medical significance or has a little bit of cosmetic significance, but nothing too much, would be considered a minor congenital anomaly. And here's an example on your right. You can see the iris of a child with Down syndrome, and you can see the white spots around the iris, and those are brushfield spots. So we would consider that to be a minor congenital anomalies. And then there's another list which you can just read off the slide, so epicanthic folds, preauricular pits, and so on. So I want to spend most of my time really on this particular slide, which talks about pathogenesis of congenital anomalies. So you can classify all congenital anomalies into 4 types: malformations, disruptions, deformations, and dysplasias. And that is what I meant in the beginning when I said that a malformation is only one type of congenital anomaly. It's not the same thing as a congenital anomaly. You have to use the word in context. So what is a malformation? A malformation is a primary error of morphogenesis. So what that means is that the blueprint for the development of that tissue or organ is abnormal. So if you look at the figure on that side, you can see that that's normal development. So the developmental program here is a square, and that leads to normal development. So in malformation, the epigenome or the primary genetic makeup is abnormal, and as development proceeds, it results in a congenital anomaly. So these are usually not progressive anomalies. So they are sort of static, and they don't get worse as the kids get older. Many of the malformations that you see are multifactorial in origin, so that is important to remember. Then we come to disruption, and these are completely different from malformation. So remember, in a malformation, you have the blueprint that's abnormal, but in disruption, the blueprint for development is normal. Development is proceeding normally until an event occurs, which is here. And this might be a vascular event, this might be an infection, this might be amniotic bands. So that results in destruction of normally developing or developed organs and tissues. So these abnormalities are also static and non-progressive, but they are not reversible. So that is a disruption. Then we come to deformation. Deformation is like disruption in that you have, if you look at these 3 images here, the developmental blueprint is normal. Development is proceeding normally until a mechanical force is applied to certain parts of the developing baby. So for example, a fibroid might press on the developing head of the baby and cause non-craniosynostotic plagiocephaly. So that would be an example of distortion, of deformation. And the thing about deformation is once the baby is born, the deforming force is removed, and then gradually over a period of time, the tissue or organ comes back to normality. Sometimes this happens just passively. Sometimes you need to actually help it happen. So for example, splinting of a talipes, where the talipes has been caused by pressure of a fibroid or something on the baby. And then lastly is dysplasia. And this is actually quite a difficult concept to get your head around. So what are dysplasias? So like I said before, dysplasias affect tissues rather than organs. And in whichever organ you get that tissue, all those organ systems will be affected. And dysplasia represents abnormal organization of cells into tissue, so abnormal histogenesis. So you can see here the last of the images that the development blueprint is not normal. Over a period of time, you have abnormal organization of cells into tissues causing the dysplasias. And so the skeletal dysplasias are good examples of this, also ectodermal dysplasias, and so on and so forth. So 2 things about dysplasias. Firstly, many of them are monogenic. And secondly, they are progressive. They are progressive entities. Some of them may not be obvious at birth and might only become obvious as the child grows a lot older. So here are examples. So mitten hands, mitten feet in a child with Apert syndrome. These would be considered malformations because the developmental blueprint for the formation of the hands and feet are abnormal because of a gain-of-function variant in FGFR2. Here are 3 examples of disruption. So here you can see that the hand was developing normally until amniotic bands formed and truncated those 3 middle digits there, resulting in pseudosyndactyly as well. Similarly, truncation of the middle digit there because of an amniotic band, and you can see a deep groove over the thumb because of an amniotic band. And then this distal leg of this baby has a very deep encircling band, which is also causing problems. So this would be considered a disruption as well. Here are two examples of deformation. So non-craniosynostotic plagiocephaly here because the fibroid was pressing here and didn't allow the skull to form so well on this side. You have protrusion of the, it's really odd. It's sort of got skewed somehow. You should, on the same side as you have the plagiocephaly, there should be frontal prominence and the ear should be placed more anteriorly. So that's a deformation of the head, and this is a unilateral talipes caused by pressure of a fibroid on a growing limb. And so the plagiocephaly will normalize with time. You can try a helmet sometimes. Some people use helmets to improve the head shape, but mostly in the UK we don't use helmets at all. And for talipes, you can either do passive physiotherapy, you can just do some splinting or do some casting to make it better. And lastly, here are examples of, this is an example of a dysplasia. So this is achondroplasia. So you can see the unusual face, the rhizomelic shortening of the limbs with these excess skin folds. But then if you look at the tissues that are affected, you can see that there is iliac hypoplasia with narrow sacrosciatic notches here. There's shortening of all of the long bones. There's proximal femoral radiolucency there and sloping metastases. So bones are involved in this dysplasia. So moving on now from pathogenetic mechanisms of birth defects to a clinical classification. So obviously, any birth defect can occur as an isolated anomaly or could be part of a constellation of congenital anomalies. And when you have more than one major congenital anomaly, then you can assign one of three patterns to that. So the first pattern is a syndrome, the next is association, and the third is a sequence. And again, you need to be very clear about what these terms actually mean and not just use them randomly. So a syndrome is a pattern of anomalies that are causally related, which means all of the anomalies are due to the same underlying cause. Also, when you see a syndrome, you will see that all the children that are affected with the syndrome tend to have a recurrent pattern of anomalies. So you get the same pattern. So all of those are causally related. If I come back again to the example of Apert syndrome, if you have a gain-of-function variant in FGFR2, it will cause craniosynostosis, facial abnormalities, mitten hands, mitten feet, and they are all linked to the abnormality in the FGFR2 gene. So you can clearly call that Apert syndrome. So association is different. So first of all, there are very few associations. In fact, there are only two. There's Vactorel and there's Merck's. And in the past, we used to have charge, but when a cause was found for charge, it was found that all of the anomalies of charge and association were all linked to the causal gene CHD7, and so they changed it from an association to a syndrome. So in association, you have a pattern of non-random anomalies, but you can't link the anomalies to each other. You're not sure, are they all linked or not? That's one point. The second point is that although the anomalies are non-random and tend to occur with each other, if you take the example of Vactorel, you might have a child with Vactorel that has V, A, and C, vertebral anomalies, anal anomalies, and cardiac anomalies. And other kids with Vactorel may have cardiac anomalies, tracheoesophageal fistula, and renal or radial anomalies. So you don't get the same consistency as you would get perhaps with a syndrome. But the important point is that there is no way to link them all together, and that's what an association is. And the third pattern is sequence, and this is really interesting. So in sequence, what happens is that you have multiple anomalies, but there is one primary anomaly, and that is usually a malformation. So you have a primary anomaly, and then everything else, all the other anomalies, follow on from the primary anomaly as a cascade of events. So that's a sequence. So here's an example of a syndrome, and this is a very interesting syndrome. This is TARP. So TARP, you can see as at the bottom of the slide, stands for talipes equinovarus, which in this setting would be considered a malformation. Atrial septal defect, which in this setting would also be considered a malformation. Mandibular hypoplasia. You can see the mandibular hypoplasia in the middle image there. The jaw is really small. So M is not in the title. What is in the title is P, which stands it's R. So it stands for Robin sequence. So the mandibular hypoplasia makes the tongue fall back, and it stops the palatal shelves from closing. And because the palatal shelves don't close, you get cleft palate, and so you end up with the Robin sequence. So The mandibular hyperplasia is the malformation, primary malformation resulting in the cleft palatal rubber band sequence, which is actually a sequence. So this syndrome has not just features of a syndrome, but it also has a feature of a sequence. And then persistent left superior vena cava is a malformation. So why do we know that these are all linked? Because we know that this is caused by variants in a gene called RBM10. And we know that RBM10 is expressed in the branchial arches and in the mandible, and also in the developing CVS. And so you link up all of those things together. So it is, by definition, a syndrome. This is an example of a sequence, Potter sequence, which everybody is familiar with. And again, so what happens here is that there is a primary malformation, which is the severe renal anomaly. It might be bilateral renal agenesis or urethral obstruction. That causes reduced fetal urinary output, which in turn causes oligohydramnios. So now you have the baby sitting in the womb, and there's very little fluid surrounding the baby in the womb. The uterus presses on the baby's face and distorts the baby's face. So you get Potter facies. Potter facies are a deformation. You get pulmonary hyperplasia because the baby's lungs are not able to expand fully, and without having enough amniotic fluid, lungs will not develop. So the lungs, you end up with bilateral pulmonary hyperplasia. In this setting, it would be considered a disruption. And then lastly, dislocated hips and talipes. Again, the uterus is pressing on the baby's limbs. It's dislocating the baby's hips and causing talipes. So this is a deformation. So malformation is the primary event, and the other three anomalies at the bottom are all cascading or secondary events. But in terms of their pathomechanisms, they are different. And here's what you would see in somebody with Potters. So you see here the baby with the squashed nose, the micrognathia, these deep infraorbital grooves. And if you look inside the baby's mouth, you might see that there is a cleft palate, almost like a Robin sequence, because the mandible is crushed, the tongue falls back, the palatal shelves can't close, so the cleft palate would be a sequence as well. There is multicystic renal dysplasia here, and that is the primary cause, the primary malformation, and then bilateral pulmonary hyperplasia there. So I don't want to spend too much time on congenital anomalies because Madhulika spoke about yesterday, and there are only a few points to make here. The first is that if you take all genetic causes, so monogenic causes, chromosomal abnormalities, and multifactorial inheritance, together they account for around 30 to 40% of congenital anomalies. Environmental factors in this study from Harvard, about 3.4%, but in most other studies, it's somewhere in the figure of around 5 to 10%. And then the important figure is this one, which Madhulika also mentioned yesterday, that over half of congenital anomalies have no known cause. And then if you drill down into the environmental causes, these are the environmental causes listed here: maternal illness, exposure to infections, exposure to drugs and chemicals, and physical agents such as ionizing radiation. And this is the same study from Harvard, and you can see that the leading environmental cause of congenital anomalies in their hands was diabetic embryopathy, so maternal illness. And of the drugs and chemicals, that was the next, and that was fetal anticonvulsant syndrome. So those are the two commonest causes. So I want to move on now to give you 3 examples of environmental syndromes or birth defects, or whatever you want to call them. So this is brachyteliophalangic CDP. So this child here has this Binder facies, which you can see here. And brachyteliophalangic CDP is a skeletal dysplasia. It primarily affects boys. It's inherited in an X-linked recessive manner, and is caused by hemizygous variants in aryl sulfatase E. But you can get exactly, so before that, let me just show you where the chondrodysplasia punctata is. So you can see the inverted distal phalanges of the hands. You can see some punctate calcification here at the base of the proximal phalanx of the index finger. In the symphysis pubis, you can just see some chondrodysplasia punctata there. In the distal phalanges of the toes, again, the inverted appearance of the distal phalanges. In the tarsus there, and then you can see it better on this image here. So about 60% of brachyteliophalangic CDP is actually caused by variants in aryl sulfatase E, but in 40% of cases, that is 40% of patients, that's not the case. But you can get exactly the same phenotype if mom is taking warfarin antenatally. and that results in fetal warfarin syndrome. And how does this happen? Why is fetal warfarin syndrome a phenocopy of brachytelial and phalangic CDP? Warfarin will cross the placenta. It'll inhibit vitamin K in the baby, and low levels of vitamin K interfere with activity of aryl sulfatase E, and so you end up with the same pattern. Also, you can get brachyteliophalangic CDP if mums have hyperemesis gravidarum, or they have small bowel syndrome because they're not able to absorb enough vitamin K, and that causes fetal vitamin K deficiency resulting in brachyteliophalangic CDP. And lastly, if mums have autoimmune disorders, then the autoantibodies may also cross the placenta, and they may somehow interfere with vitamin K metabolism in the baby, although nobody's sure how that happens. But maternal autoimmune disorder can also give rise to phenocopy brachyteliophalangic CDP. So you're all aware of TORCH and how TORCH can cause congenital anomalies. So those are disruptive congenital infections causing multiple congenital anomalies. But I just want to draw your attention to congenital parvovirus B19 infection. And you might ask why? Well, because there has been a resurgence of acute parvovirus B19 infections in pregnant women in 2024 in the UK, but also across Europe. And we have been discussing patients with mums who have babies with what we think are congenital parvovirus B19 infections in some of our fetal MDTs as well. So it's becoming a very big problem. So about a third of pregnant women are at risk of primary infection with parvovirus B19. And of these mums, in about a third to half, the virus will be transmitted across the placenta to the baby. Once it gets into the baby, it will affect red cell progenitors, causing severe fetal anemia, which if severe and prolonged can cause hydrops. If the hydrops persists long enough and the baby is born, you'll start to see changes in the brain. And if these babies survive, you can see abnormalities of neurodevelopment. And there is an increased risk of miscarriage, IUD, neonatal deaths as well. It is a treatable condition, so you can treat congenital parvovirus B19 infection with fetal transfusions. But once hydrops develops, even if you give intrauterine transfusions, the prognosis is poor. So what does this look like on scans? So there you can just see, sorry, the arrow should actually have pointed to the dark space. That is ascites, fetal ascites. You can see a thin rim of pericardial effusion and a thin rim of pleural effusion in the baby's chest. You can see hyperechogenic bowel. You can see hepatomegaly, a massive placenta, placentomegaly, and polyhydramnios. So that is how you would make this diagnosis on antenatal scans. And then the third example I wanted to give you is of this new entity called fetal fentanyl syndrome. And this is becoming a big problem in the US because of widespread fentanyl use. And that's all non-prescription fentanyl, just people just taking it because it's an opioid analog. So geneticists in the US actually started to see babies that looked like Smith-Lemli-Opitz syndrome, but clearly didn't have that. And they were able to talk to each other and find that all of these babies, their mums were on non-prescription fentanyl. And they were able to recognize this syndrome. So what are the clinical features of this? So it is a phenocopy of SLO. The babies presented with IUGR, feeding difficulties, distinctive facial dysmorphism. I'll show you that in the next slide. Cleft palate, genital anomalies in karyotypic males, and then there's 2-3-toe syndactyly and adducted thumbs as well. Hyperplasia of the corpus callosum. And if you looked at the blood biochemistry, they actually had elevated 7-dehydrocholesterol, just like you get in Smith-Lemli-Opitz syndrome. The difference was that in SLO, the 7-dehydrocholesterol, that will persist in the blood for long periods of time, whereas in fetal fentanyl syndrome, after a few months, it disappears. Also elevated levels of 8-dehydrocholesterol, which you can get sometimes with SLO, but sometimes with X-linked dominant chondrodysplasia punctata or Conradi-Huneman syndrome. And why does fentanyl give you a phenocopy of SLO? The answer is that fentanyl crosses the placental barrier, and once it gets into the baby, it disrupts sterol biosynthesis, particularly cholesterol biosynthesis. And as you know, Smith-Lemli-Opitz syndrome is an autosomal recessive disorder that is caused by variants in DHCR7, which catalyzes the last reaction in cholesterol biosynthesis pathway. So you get exactly the same phenotype, but it's a phenocopy of SLO. And so this is what the babies look like. So on the top panel here, you see this baby has ptosis on that side, but around the nose, they are all very similar. And then on the lateral view, they have micrognathia. And if you look inside the mouth, you might actually see the cleft palate as well. the single palmar crease, the adducted thumb, talipes, 2-3 toe syndactyly. It looks just like SLO. And so I just want to summarize my talk by saying that terminology is important. It's fine to use the word birth defects in scientific conferences and in books, but perhaps when talking to families and to patients, to adult patients, I think you should be using the word congenital anomalies or developmental anomalies, because you just want to be using words that people don't find pejorative. Congenital anomalies are still an important cause of perinatal and infant mortality, even in the UK. Presumably, they are more so in India. The constituent features of syndromes and sequences may have different pathogenetic mechanisms, as I showed in those two examples. Genetic causes, so monogenic, multifactorial, and chromosomal anomalies account for around 30 to 40% of congenital anomalies, but the majority, or just over the majority, so 50% or more, have no known cause. And if you know what the underlying pathogenetic mechanism is of the anomalies that you're seeing in your patient in clinic, it does help you to work out, are you going to find a cause if you do any kind of testing? And what might the recurrence risk be if these parents were to have another child? So it is very, very helpful to know that. Thank you.
Hello. Thank you, Dr. Suri. It was a very elaborative yet concise and well summarized talk. And a few of the points were wonderful, especially the definition of the congenital anomalies, the classification as the pathological as well as the clinical. It was very enlightening. And all the more, the two entities that you mentioned, the new ones, the resurgence of parvovirus, and secondly, the fentanyl syndrome. And it was very surprising that they are able to acquire it on non-prescription basis, because we thought it is only possible in India, not in the other countries. And of course, the diagnosing the conditions, and it's really a hallmark that we are only able to diagnose 50% so far, the cause behind it. And so the mankind has to progress a lot still. Lot of work has to be done, because once we make the diagnosis and then we can do the genetic counseling, and we can definitely prevent some of them and treat some of them. Thank you so much.
Thank you.
Any questions? Yeah.
Thank you for this lovely presentation. So I enjoyed it. So I have two questions. So first of all, so I was intrigued by the fact that you say, okay, when it starts prenatal and it has an effect later on, then we call it birth defects. I fully agree, but with this definition, you will also include intellectual disability and even autism as birth defects, because there are things happening in the brain already early, and then suddenly the child needs to start speaking but doesn't do it. What are your ideas about this?
So the first question is about autism. So I suppose that if you have a child with autism, and you can show, perhaps maybe by MRI scanning of the brain, perhaps using a 7 Tesla scanner, that there's some subtle anomaly there, then I think that it would be correct to say that that is actually a birth defect. In terms of function, it's probably a little bit more difficult. So I know that the WHO does allow you to allow functional anomalies also to be classified as birth defects. But when you look at the literature and you look at Professor Hennicam's paper, I think he's talking more about structural anomalies than functional anomalies. So, I think that the line is not so clear there.
No, I fully agree. So I think it's functional and start very early, and then it evolves. And the second thing, you nicely showed the charts association becoming a syndrome. Don't you simply think that the other two will end up as a syndrome, but we haven't looked very carefully yet, or we haven't had the clues to pick it up? So the factor probably, so I'm a believer it will end up as a syndrome. But we don't have the right tools yet to pick it up. What are your thoughts about this?
So I think that you should only use the term syndrome if you are able to establish a causal link between those anomalies. So if you haven't been able to establish a causal link between the anomalies in a particular condition, then very correctly you shouldn't be using the word syndrome at all, unless perhaps you've done some experiments, perhaps in mice or something, where those things keep happening together, showing that they are causally linked. And then maybe you could use the word syndrome, but without that, without establishing a causal link, it probably isn't correct to use the word syndrome.
No, but I'm thinking ahead. So I think it will become a syndrome, but we haven't found a clue yet. Okay.
I mean, people use the word syndrome for many things.
No, we shouldn't be using it now, but we will be using it in the future.
Yeah. Once you get a cause, yes.
So it's more looking forward.
Yeah.
So like charge association become a syndrome after some further testing.
Absolutely,
okay.
yeah.
Just to add to Bert's point, Dr. Suri, that the recent, probably unpublished research has shown that there is an episignature which is unique to not just VACTERL, but even to what is acquired condition like fetal alcohol syndrome also.
Yeah.
Do you want to say a couple of things about that? Is that, where would you put a condition which has a unique episignature in the categorization of, in this framework?
So the episignature is telling you that there is perhaps a more widespread abnormality that is affecting transcription of many genes. If you can show that the genes that are involved in the transcription of certain specific genes are involved, that would explain all the things that you're seeing in your patient, I think it's okay to call it a syndrome. Yeah, definitely. Yeah.
Thank you, Monish. That was fantastic.
Thank you.
I've got a question for the chair people, rather, if that's all right. I'm just interested in the fact that my understanding is that diabetes is very common in the population here in India. And are you seeing an increase in diabetic embryopathy?
प्रिया वो क्वेश्चन पूछ रही है कुछ मेरे से क्या पूछ रही है हेलो yeah, could you repeat the question please? Yes,
thank you. I was just interested to understand.
Keep your mic. Oh yes,
sorry. My understanding is that diabetes is very prevalent in the population here, and I wondered whether you're seeing an increase in diabetic embryopathy.
I'm sorry, I didn't get the question. You'll have to speak a bit louder.
diabetes is very prevalent here in the okay, understood. What is the embryopathy means? You are asking what?
Are you seeing an increase in the number of babies that are affected when their mother is diabetic?
I think I am not the right person to answer that. I really haven't seen any of these cases here. We are not even aware about it from the Department of Obstetrics. Also, we have not been told, but maybe HOD sir or maybe Dr. Chaitanya can answer.
Yeah, diabetes is fairly common, and most of the cases are screened for by HbA1c in the early antenatal period. So that's a common norm in our population. And unfortunately, many cases wherein the HbA1c is beyond 8 or 9%, these cases could go for discontinuation of pregnancy. Sometimes they're counseled for discontinuation of pregnancy. So we really do not see a very high burden related to a diabetic embryopathy per se, because most of the obstetricians, they are wary of having those pregnancies beyond 9% being continued and going further. But in many cases, yes, below 9% they would continue, and we do not have much of this thing. But the thing is that there is a significant disconnect between the two. So most of these cases do continue, and we do not get a proper follow-up of these cases postnatally. Though I'm a geneticist, but in the obstetric setup this does happen, but most of them are considered for discontinuation.
And we are basically yet to introduce this as a mandatory test.
HbA1c, I would say in majority, almost in most of the cases, the ladies are screened at the first antenatal visit, most of. So thalassemia and, HbA1c is considered for most cases.
Thank you.
Thank you so much, Dr. Manish Suri. I would request you to stay back so that we can present you with a memento, please.
Yeah, now request Dr. Anurag Sharma to please felicitate Dr. Manish Suri. I now request Dr. Priya Marwa, ma'am, to felicitate Dr. Anurag Sharma. I now request Dr. Gunjan Agrawal to felicitate Dr. Priya Marwa. Indeed, the session was so simplified and crisp, giving us the basics but most important aspects of birth defects. We extend our sincere gratitude to our speakers, chairpersons, and audience for making this session a great success. Now, let us move on to our next session. I'm pleased to welcome the esteemed chairpersons for the next session to take their place on the dais. Professor Bert D. Rice, Associate Professor, Redbound University of Medical Center, the Netherlands. Dr. Chaitanya Dattar, Associate Consultant, Clinical Genetics, King Edward Memorial Hospital, Pune. Dr. Lakhan Poswal, Senior Professor, Pediatrics, former Principal and Controller, R&T Medical College, Udaipur. Dr. Bijay Lakshmi Behra, Professor and Head, Neonatology, Manipal Hospital, New Delhi. Dr. Arun Prasad, Surgical Gastroenterologist, ASHA, Center for Autism and Intellectual Disability, Chandigarh. Now, let us all welcome our next speaker, Dr. Meredith Elting, Medical Specialist, Amsterdam University Medical Center, the Netherlands, to conduct this session on rare diseases of the connective tissue, the Dutch experience.
Yes, there it is. First of all, I would like to thank the organizers of this conference for the opportunity to speak here. And I would like to say some special thanks to Professor Devendra Kumar for the invitation. Actually, my colleague and friend, Mieke van Haalst, had planned to be here, but she couldn't make it, and that gave me the chance to be here. So I'm very happy now joining you here in this conference. And I'm living in Amsterdam. You can see here the canals of Amsterdam. And I'm working in the Department of Human Genetics of Amsterdam University Medical Center. We have an expertise in connective tissue diseases. For instance, we have expertise centers on Marfan syndrome, osteogenesis imperfecta, and other rare bone diseases. And we have several NGS gene panels for these connective tissue diseases. And I will talk about today about one rare connective tissue disease, osteogenesis imperfecta, also brittle bone disease called. And actually the first patient that was described is now in the British Museum, and that is a mummy of a child of 1 to 4 years old. So what do you see here? I don't know if it's really clear, but you can appreciate the blue sclerae, and that is a major sign of one of the types of osteogenesis imperfecta, which has a prevalence of 1 in 10,000 to 20,000. So we use the Sillens classification to describe the several types of osteogenesis imperfecta. And the first type, OI type 1, is the most mildest type and is characterized by the blue sclerae and non-deforming of the bones after fracturing. OI type 2 is an extremely severe type and lethal, with a lot of prenatal fractures. OI type 3 is a progressively deforming type of OI. And you can see that it leads to a short stature, short long bones, and often wheelchair-bound. OI type 4 is a variable type with normal sclerae. And then we have a special form of OI type 5, which shows an abnormal ossification after fracturing. So I would tell you something about the genetic landscape and inheritance of OI. So the main group of patients have an autosomal dominant inheritance based on collagen 1A1 and 1A2 genes. And the special type 5 has a mutation in the IFID M5 gene. And there is a large group of genes which leads to the recessive inheritance of OI. And it's in about 10% of the patients. And very rare, we have an X-linked pattern of inheritance. So we do have an NS gene panel for OI and related disease. Actually, that is osteoporosis and hypophosphatasia. And it's a targeted NGS panel with CNV analysis. And here you can see a picture of a group of 550 patients, and you can appreciate that the most variants are found in the COL1A1 and COL1A2 genes. So 85% of the genetic variants were found in collagen type 1, and there are two groups of variants. The group that leads to a quantitative defect, and that causes a mild type of OI, and the dominant negative variants that leads to a qualitative defect and leads to a severe type of OI. So I will tell some more about the phenotype. The mild type of OI has blue sclerae. They have fractures, but they have no deformities when healing from the fractures. They show hyperlaxity. They have a near normal stature and can have hearing loss in about 60%. And they might have dentinogenesis imperfecta. However, is this type really mild? Well, in adult life, they appreciate a lot of complaints. For instance, tiredness, tendon ruptures, easy bruising, a lot of pain complaints from the back and feet. As mentioned, hearing loss, but also cardiovascular disease, valve insufficiency, and pain because of the deformation that might happen. Even lung disease has been found more in mild type of OI. Not to forget the psychological impact in these patients. In the Netherlands, we have a very active patient organization, the VOI, and they have done a project to look into the psychological consequences of OI together with the care for brittle bones. It's still going on, this project. So I think it's very important to also give attention to the psychological impact when you see patients with OI. The organization of the medical care for OI patients in the Netherlands is in expertise centers. For children, that is in Utrecht, and for the adults is in Zwolle and in Amsterdam. And there are 2 bone centers in Leiden and in Rotterdam that also connected to the European Reference Network for Bone Diseases. So I would like to take you through several cases that I've seen also in the expertise centers. To start with a female with more than 200 fractures, short stature and short deformed bones, a kyphoscoliosis, dentinogenesis imperfecta, and she had hearing aids, and also severe respiratory problems. We did DNA analysis, it was not done before, and we did find a variant in the COL1A2 gene, a glycine to cysteine change in the triple helix, leading to quite a severe phenotype. So as mentioned, this is a progressively deforming OI, and they might have quite a large head and triangular face. They have a high voice, and as mentioned, short bones, deformations, kyphoscoliosis, and a short stature, short trunk. They might have some discolorment of the sclerae and have the dentinogenesis imperfecta. So another case that I've seen in one of the expertise centers was a woman with white sclerae, quite a lot of fractures of the fingers actually. She had a short stature and a scoliosis and hypermobility, a normal hearing and normal teeth, and she had one brother that was affected, but there was no consanguinity in the family, but it leads to the suspicion that it was a recessive type of OI because her parents were not affected. And then years later, she had one son. He had a femur fracture at the age of 3 and an ankle fracture of the age of 13, and her father developed osteopenia and had a few fractures. And this leads to the suggestion of a very intrafamilial variability in the OI type 4, and we did indeed find a deletion in COL1A2, and the son and father were both carriers of this deletion. So it's very known for OI type 4 that it can be very variable. We don't know why exactly. And can be mild, but can also be quite severe. They have white or mildly gray sclerae, and they can have DI, and they can have hearing loss. So another case I would like to show you was a boy that was presented at the ER at the age of 11 months with a femur fracture. He did not have blue sclerae. And when the consolidation of the fracture after 18 months, we saw a lot of bone formation. And at the age of 14 years, he had a radial head luxation and a membrane calcification. So this is typical for OI type 5. They show the hyperplastic callus formation and the interosseous membrane calcification and radial head luxation. And indeed, this patient had a typical mutation in the IFID-M5 gene. So, one more case to show you. I did see a 33-year-old woman in one of the expertise centers. She had a lot of fractures, had a short stature and short trunk, and progress deformations. She had a pectus carinatum and kyphoscoliosis, but also had contractures and webbing, no hearing loss, normal teeth, and white sclerae. And her parents were consanguineous. So this was the suspicion on an OI type with an autosomal recessive inheritance. I think you know all what this is. This is indeed Brooks syndrome. We did find an homozygous mutation in FKBP10 gene, and the Brooks syndrome is typical characterized by the contractures and the webbing. Actually, I didn't mention before the severe type, but prenatal type, the fractures are during the pregnancy, early in pregnancy, of the long bones in the ribs, leading to lung hypoplasia. You do see no mineralization of the skull, a typical frog legs position, and plateau spondylae. In this case, on the left side, we did find a severe variant in the COL1A1 gene. So there's a lot of things going on trying to find some therapy. In our human genetic departments, Dimitra Misha is the head of the section of the connective tissue diseases, and she and her team are developing an OI mouse model, the high OI mouse. And I'm not going to tell you in detail about this, but she did show already in this mouse that there is low collagen production and a typical skin problem with the collagen. So we hope, and I hope, that she might tell you in the future about the possibilities in therapy in the most common type of collagen 1A. So this is my last slide. I hope if you were ever visiting Amsterdam that you will go to see the Night Watch from Rembrandt van Rijn in the museum in Amsterdam. And then I will invite you also to see our own Night Watch of syndromes. One of my colleagues, who is very talented, made her own Night Watch with all kinds of syndromes. Here in the middle you see the Noonan syndrome. On the left side, the Apert syndrome. You can see Cornelia de Lange syndrome, achondroplasia, and, well, we have our conference room, and this is part of the conference room. So you're invited to see it live when visiting Amsterdam. Thank you for your attention. Questions? Yes.
Oh, yeah. Okay,
Oh.
yeah. There's a question up there. Okay, please come forward because... Oh, there's a microphone here.
Yeah, thank you very much. It was a very interesting talk, very concise, but very interesting. My question is that I would want to know your experience on the prenatal manifestations in mild cases of OI. As you know, we had a family where the father was, we did not know the diagnosis of OI in that family till the time the couple got pregnant and we saw there was a bowed femur, there were no fractures, there was no defect of mineralization, there was only bowed femur, because of which the fetal test showed a COL1A1 splice site variant. And then on history, the father had some history of fractures in childhood, after which, there were 2-3 fractures in childhood, and then 1 dislocation in the father. There was no hearing loss, nothing, but the father also carried the same variant.
Okay, yeah.
So, yeah, so your thoughts on,
Yeah, it's very
mild...
interesting. The father had blue sclerae or no? No, so OI type 1 doesn't show any fractures or bowing in intrauterine, but OI type 4 might have some bowing sometimes. But yeah, we run into some really interesting cases also about a girl that had a lot of fractures, was born with a lot of fractures, and now developed into a really mild type of OI type 1. So we don't know yet. We are looking into that if there is a change in the levels of the wild type and mutated variant of the collagen. So we don't have all explanations there. So, but it happens that you run into cases that you can't explain in the typical classification. Yeah. So I don't know the answer.
Okay, okay.
Yeah.
Thank you. I think we'll need more and more, maybe collection of these cases and study of these cases.
Yeah.
The child is doing fine, though. The child is 1 year old
Yeah.
now,
Okay.
and the
Yeah,
child
so sort of
did
similar
not
case,
have any
maybe.
fractures.
Yeah. Interesting. Yeah.
Maybe I can have a question. Actually two. So one of the questions is, so when I look at the collagen genes, they are large. So I suppose you encounter a lot of variants of unknown significance, VUSs. Is that the case or not?
No, not that much, no. We run much more into other gene NGS panels in FUSs. But a lot of cases are or clearly de novo or familiar, dominant inherited. So it's sometimes you have a FUS, but it's not that often.
So what makes you so certain that it's not a FUS or a FUS or a VUS? You can pronounce in different ways, I guess. So
well, a lot of times it's like a typical change from a glycine to a serine or cysteine change.
That's the classic one.
Sorry?
That are the classics, the classic ones.
Yeah,
yeah, okay.
They can see a classification of the variants.
Mm-hmm.
They have a lot of experience, of course, a lot of database with patients. But so in my experience, we don't run that often into FUSs.
Okay, then you're lucky.
Yeah, maybe you have some other experience.
I have a question. Whether do we still classify OGI as type 1, 2, 3, 4, or are there significant overlaps, or it's better to call them by the gene as such? Because there are significant overlaps that we see within the phenotypes and significant variability also.
Yeah. In case of education for today, it's very helpful to use the classification. But in practice, you can, of course, you see a patient and you think it's more typical OI type 3, or sometimes the 4 with a severe direction type 3 is a discussion, because you cannot say it based on the variant actually.
Okay.
And then you can use the variant as a, but yeah, it's helpful to discuss it for education and for the doctors to treat the patients to have a sort of classification.
Correct. The other issue is the resolution of VOUS, as Sir pointed out.
It's a clinical point.
Yeah, so essentially what happens is in our cases, we do find a lot of VOUS variants being diagnosed. So in the index child is showing a VOUS variant, and we do find one of the parent who is very, very mildly affected also carries the same variant, but still classified as a VOUS for the lack of functional studies and other studies.
Yeah, well, I think our lab has a lot of experience that might explain, I don't know, why you have more FUSs. Or maybe it's another population, you know. Maybe it's Indian patients that have, yeah.
So,
I don't have the answer to that.
Question. So, minor question. Oh, you have a question?
Not related to this topic. Actually, amongst the rare connective tissue disorders, apart from osteogenesis imperfecta, I think a lot of research is going on in your area on Ehlers-Danlos syndrome. So.
I didn't get that, sorry. Ehlers-Danlos, yeah.
So a lot of research work and it's going on there. So can we just...
What is your question about Ehlers-Danlos?
A lot of research work is going on in Netherlands on Ehlers-Danlos syndrome. So can you just put some limelight or few sentences over that?
What, you asked me what was my experience with EDS?
She's asking about the research that is going on in Ehlers-Danlos syndrome.
So what my experience with EDS is in the clinical, in our clinic, yeah. So we get referred a lot of patients which are qualified as a hypermobility syndrome, which is not to be confirmed. We cannot confirm that by DNA analysis, so it's a difficult patient group. But we have also some experience with the vascular type of EDS, which is much more rare. And the classical type is even more rare, but we do see these patients, yeah. I don't know if I answered your question, but we have experience with it, yeah.
I think we are out of questions, so then Thank you for this lovely presentation.
Thank you, Dr. Marit Elting, for enlightening us with your knowledge and experience. Learning is a journey, not a destination. Let's enjoy the process. With this note, we move on to our next session. Welcome our next speaker, Professor Pradeep Vasudevan, Consultant and Honorable Professor, Department of Clinical Genetics, University of Leicester, United Kingdom, to talk on relevance of multi-omics in birth defects from birth to late age.
Good afternoon, everyone. It's been great to be in Jaipur. And first of all, I would like to thank the organizers, specifically Davindra and team, for giving me an opportunity to present at this prestigious forum in the historic city of Leicester. Oh, sorry, Jaipur. Sorry, I was going to talk about Leicester. So I come from Leicester, which is a small city about an hour from London. So this is a picture of the main street in Leicester, the town hall, during the Deepavali celebrations in October this year. There are many Indians who live in Leicester, and a lot of Indians consider Leicester as a city of a home away from home. And in Leicester, we host the biggest Diwali celebrations outside India. So this is a map of England. So you can see, sorry. So there is London there. And we are here in the east of England, where Leicester, Nottingham, and Cambridge are there. So these are the 7 genomic laboratory hubs, and Cambridge being our main hub there. And there is Southeast, Birmingham, Oxford, Exeter Lab, which does our urgent R14 or postnatal WGS testing. There's Liverpool and Manchester here, and Sheffield, Leeds, and Newcastle here. So Leicester has about 10,000 deliveries plus in one center. It's probably making it the biggest feto-maternal center in Western Europe. We also cover 2 local hospitals, Northampton and Kettering. It's a big multi-ethnic population. We have about 95 official languages in Leicester, making it UK's first plural city. There is no single ethnic majority there. So there's a bit more about East. You can see Nottingham. We have got many speakers from Nottingham here, and also Cambridge here, and Norfolk. There are about 29 hospital trusts in this particular GMSA. It's always good to start with a case. The topic given to me is on multi-omics, which is slightly different from the topic that I was planning to present. So we posted some interesting challenges. This is, I'll name him Sam. He was referred by an email, through an email by a pediatric cardiologist about 3 years ago. He is the first and only child of non-consanguineous healthy Indian parents. I was born at 34 weeks by forceps delivery, and he had a second trimester diagnosis of duodenal atresia, which was repaired soon after birth. And subsequently, postnatally, he was found to have a VSD. So this is the email I got from the pediatric cardiologist. And he also had hyperbilirubinemia. And he was seen by our regional center in Birmingham, and major causes have been ruled out. Family was quite traumatized by all this, and initially they were given a diagnosis of trisomy 21 by microarray. All of that was ruled out. So the question they were asking was whether there is a genetic cause for his presentation. So I replied, going on to investigations, he had a normal microarray, but the MRI scan, because he developed some seizures, which showed changes of ischemic changes, actually. And the radiologist thought it might be a neurometabolic stroke genetic disorder. So I wrote back and said that we can do request R14 testing through Exeter. It has been about 2 years. We started this in October 2019. So this was October 2021. And we arranged, the important thing about this testing is we need pre-approval for this testing. And before the samples are sent, it's a sample sent as a trio agnostic testing. So it's both parents and the child. And what is our 14 service, which I just mentioned? Exeter lab, which I showed in the initial map, the southwest of England, is the only lab which offers this test in the country. This is only available for England, but not to the devolved nations. And we fund about 1,200 tests per year. But 3 weeks later, I get this email. So this is an email MDT with the clinicians and laboratory scientists. They identified two gene variants in a gene known as POL-RMT. One is a nonsense one, the other is a splicing variant. And they thought about this paper. They mentioned about this paper, which Rob Taylor's group had published that year, early in 2021, about global developmental delay, hypotonia, short stature, and speech stroke intellectual disability in a series of children, 6 children. But the features in our child, our child is young, so difficult to assess that. So they were wondering whether we could do further studies, and they said they will do the mRNA studies, and also to get some more sort of clinical aspects, phenotyping done through pediatric neurology and pediatric ophthalmology. So we arranged that one. This is the paper I mentioned, interestingly, when I look back, this is the only paper on POL-RMT gene in the last, that's the only paper I could find, even now. So it took some time. The child was growing, and in about more than a year later, unfortunately, what they said was the RNA studies failed, and there was a national project at that time for RNA sequencing, and maybe talk to our local GLHS Cambridge to see whether we can make a diagnosis in this case or upgrade this by functional studies. And they issued the report at that time. So again, almost 3 years later now, so this is all done in clinical setting. So I must say this is not in research. I had sent the samples to Newcastle and arranged Rob McFarland and Rob to see this family. And Newcastle is our main sort of mitochondrial center. And they did studies, and they've identified that from the fibroblasts, which is predicted to result in a non-stop transcript and may be targeted by non-stop mRNA decay. So they reclassified this variant from class 3 to class 4. I gave the results early this month, and family were pleased that they have now got a result. After 3 years, it's confirmed. But not a surprise, mother said to me that she is pregnant And so we offered her prenatal testing, and she's in early pregnancy, so probably it'll happen December. But still we are not sure because all the features which he presented cannot be completely explained by pole RMT variants. It might be just coincidence that the cardiac problems are there, a structural birth defect, as Monish was mentioning about CVS anomalies were the common birth defects. So that's him when he was about 6 months old, early 2022, and that's him this month when I saw him. So that is the story, but I'll go into the multi-omics side now. So rare diseases, and rare diseases, individually they are rare. Cumulatively, they are about 1 out of 17. So we have about 3.5 million people in UK with rare diseases. So it's 2 to 3%. We were talking previously about birth defects there. And different types of genetic testing. So you have the light microscopy and G-banding, microarray, which detects copy number variants, and that is the first line testing in most centers at present. But we are moving on to whole genome sequencing. And actually, England has already moved into whole genome sequencing, and many other countries, the first line testing is whole genome sequencing. This is from Bird's paper last year about how NGS has changed over the years. And the number of genes which have been identified has increased dramatically once NGS was introduced. So here it's the green line where it was the traditional testing or targeted testing and microarrays. And you can see the graph, how it's going, the trajectory. It's a steep curve after that. And Bird's paper says that there is we can diagnose up to 35% of cases using just whole genome sequencing as first line investigation. Now it creates a lot of challenges also, because once you have whole genome sequencing, there will be a number of VUSs come in. And how do you analyze all these VUSs? Or if you don't have a diagnosis, how do you identify, is there a gene, we know it's genetic, is there any other issue? As Abhijit was mentioning previously about episignatures, DNA methylation. What can we do? So just to mention a bit about genomic testing in England, we have a national genomic test directory, and it is updated every few months. The latest version is from July. And the first test in this particular national genomic directory is genetic testing for acutely unwell children. And this is, we have different codes. R14 is the code we use. And if you go into this website, exeterlaboratory.com, you'll know more details on R14. So as I said, it's 5 years since we introduced R14 surveys. And initially we started as rapid exome sequencing. And in October, about 3 years later, 2022, we changed it to whole genome sequencing platform. And the diagnostic yield was consistently about 40% there, just with whole genome sequencing. So there is a 4% of cases which would not have been detected by whole exome was detected by whole genome. So there is an increase there, so from 36 to 40. And why is it important? Because if you have a diagnosis, you can offer specific genetic counseling. It helps and contributes to immediate clinical management, and also for future management, prognosis, and prediction indicator. As I said, there is only one lab in the country. And the most important part, as I said in my email, which I replied to the cardiologist, is about that pre-approval from Exeter Lab, so that the right patient is selected for trio-genome sequencing, where they satisfy the criteria. And subsequently, when they identify variants, we have that MDT, It can be through virtual consultation or through an email between the main subspecialties or mainstream specialties, clinical geneticists, and laboratory scientists. Now, coming to the second part is about multiomics. How can multiomics help? And as you know, this is a central dogma of molecular biology. You have the genomics, which is the whole genome sequencing. You have the RNA, transcriptomics. You have the protein, proteomics, and metabolomics. So that is sort of the layered approach there. And there are some nice papers, actually. I was preparing for this presentation. One was from Oxford group. Helen is an author in that paper, Pagnamenta et al., Jenny Taylor's group. And that gives a high hit rate, about 43%, I think, in total, about 122 patients there. And the Alston et al. Paper is on mitochondrial conditions from Rob Taylor's group. And Rhodes et al. Is the paper from Sid Banka's, many of you might know Sid Banka's group in Manchester on DNA methylation episignatures. So this is sort of the strategy. I was put in a more a slide form here, the picture. So you take the sample from blood, you do the genomic studies. It can be a candidate genome. For example, you know the condition, this is clearly Noonan syndrome. You do the particular gene, or maybe a panel, which is the rasopathy panel, or a whole exome, which is probably the most efficient when your budget is limited, or whole genome. And the variants are interpreted, validated, and according to the ACMG classification. So, class 4 and 5 are clinically actionable, but class 3, 2, or 1 are not clinically actionable. So a lot of them presents with VUSs, as Bert was mentioning previously. The diagnosis is established, yes, well and good, we can proceed with further management. However, if it is not established, we need functional analysis. And it can be from the blood, or muscle, or skin biopsy. So you can do the RNA sequencing, and our group in Southampton, Diana Barrell's group, is working on that. Or it can be protein or proteomics, or metabolomics, and then functional validation of the these sort of variants. It can be upgraded to class 4, or it can be said that no, it's clearly a VUS. And again, this is about the overview of gene structure on multiomics. So you can see that if we identify a pathogenic variant, class 4 or 5 in exons, well and good. However, if it could be a transcription issue in the sort of upstream or downstream open reading frame there, or it could be a splicing issue, and various splicing problems could happen. It can be synonymous variants or missense variants. So how we can make a diagnosis there. Going into sort of transcriptomic analysis. This is a graph here which shows the whole blood here, and muscle and fibroblasts in mitochondrial genome, and OMIM genes here. There can be aberrant expression of this, or it could be, we can analyze the pathogenicity by clearly delineating a splice site, or maybe creating a deep intronic variant, because it may be a deep intronic variant creating a pseudo exon or a splice site variant leading to intron retention. So the many ways there it can add to these functional studies. Again, looking at from a protein expression point of view, here, this is again more mitochondrial, but it can be used for other heterogeneous conditions also. Here, this is the disease coverage, and that's for the muscles, and this is for the fibroblasts there, the mitochondrial genome and OMIM genes there. This is the gray color represents normal protein expression, and it could be a protein of interest here, sort of complex I subunit with subunits, which is aberrant protein and complex expression, or could be an aberrant protein, complex expression, and sort of downstream functional consequences along the oxidative phosphorylatory pathway. So the increasing functional evidence of pathogenicity you can see. So summarizing my presentation, I believe that trio-agnostic whole genome sequencing strategy is becoming the most effective method for molecular diagnosis. When there is insufficient support for the pathogenicity, additional functional investigations are required. Multidisciplinary multi-omics approach is key because it gives a bigger picture, a holistic picture supporting the diagnosis. And as I mentioned, transcriptomics, proteomics, and metabolomics has the potential to greatly improve these diagnostic strategies. And combining all these omics data provide a more holistic picture from the data generated and uncover causative changes, revealing disease etiology and potential treatment. So this is again a picture from, there is a big road in Leicester known as Melton Road, where most of the Indian shops are there, and the complete, it's known as Golden Mile. And this is a picture I took in my phone on the Deepavali fireworks day. I end my talk by a quote from Judith Hall, says, "The clinic is my laboratory. For clinicians, the clinic is a fascinating, ever-changing, unpredictable, evolving laboratory full of surprises, a place where your subjects, your patients, present amazing questions and results." Thank you.
Thank you for this interesting presentation. Any questions from the audience? You may think, then I will start briefly. So I'm always intrigued by the multi-omics. So we come off phenotype first, now it's genotype first. And I always miss a little bit in the multi-omics. What happened with the phenomics? Yes, because it's all out there, and I like the remark by Judith Hall that essentially it's phenomics.
Absolutely.
From my point of view, but I'm a little bit biased, I realize. So what are your thoughts about this? Please use the microphone.
I mean, I completely agree. Phenotyping is the most important aspect. Without clinical phenotyping, laboratories and scientists can't interpret this. The pipeline should, it's almost like you enter good data, you get possibly good results, potentially good results. But if you input rubbish data or the data is not good, what comes out is also exactly like that. So I am a clear a clinical geneticist, and I would say phenotyping is more important, whatever be the technology.
Question over there, and the microphone is down here. So if you could move forward or the microphone go upward, either way, it's okay.
Thank you very much. I just wanted to know your thoughts and everybody's thoughts on the possibility of transcriptomics and or proteomics replacing genomics in future, because of the limitations of, we moved from exomes to genomes to now we know that there's a lot of epigenetics. So, and then transcriptomics to a large extent encompasses all of these, of course, with the limitation of the tissue where where the transcriptomic analysis needs to be done. But I would just want to know the comments from anyone on the possibility of this, just the phenomics and transcriptomics becoming the future.
I think the first line of investigations should be genomics, whole genome sequencing to start with, because it produces a good output, like 35% according to Bird study, which I showed that NGS graph there. However, the challenges with omics is the is the data. You produce enormous data, and how do you meaningfully interpret this data? And there is overlapping results to produce a meaningful result for the patient in front of you. So I wouldn't go and jump into transcriptomics or proteomics first. I would probably start, if you are looking at a genetic condition, probably I'll go with basic aspects, probably microarray as the first testing, and then going into whole genome sequencing, though it's changing into whole genomic sequencing, becoming the first one. And then the additional work supporting this. So it's sort of complementary to each other rather than individually they are going to change.
Thank you very much. Very interesting talk. I have a question for you. In the UK diagnostic labs, what is the feasibility of offering a diagnostic test based on functional analysis?
Yeah, I mean, there are specialist labs we have, and specialist it all depends. It's almost like translational projects. So research is done first, and then it translated from bench to bedside sort of approach. So functional studies, in my case, was done by Newcastle, which is probably the top center for mitochondrial. So they are equipped for that. So I agree with the model of having specialist centers in the country where tissues can be sent for one particular sort of omics there. Similarly, DNA episignatures or methylation tests we send to our colleague in Manchester. So I would probably, rather than every lab or every center having all these technologies, I would pool these resources together because that will be the most effective and efficient way, especially when you don't have that much funding.
Yes.
Yes.
Okay. Thanks very
Thank you.
much.
If there are no further questions also here, then thank you, and we close this part of the session.
Thank you.
So please be seated, sir. Thank you, sir, and all respected chairpersons for that insightful presentation. We are truly grateful for sharing your invaluable insights. Now, I would like to call upon Professor Bert D. Rice to please felicitate Dr. Pradeep Vasudevan. So please. I now request Dr. Ashok Gupta and Dr. Dhavendra Kumar to please come on the stage and felicitate our chairpersons. I would like to call upon Professor Bert D. Rice, Dr. Chaitanya Dattar, Dr. Vijay Lakshmi Behra, and Dr. Arun Prasad to please come on the stage. Thank you, sir. As we are running behind the schedule, we have made a little change in the schedule. I would like all to move on to the RK block cafeteria for the lunch session. Please, it's a request to all of you to come back within 30 minutes, so we may be on time.
I just wanted to check that my
Yeah, ma'am,
presentation
sure.
is on there.
Yeah, sure.
So I just close this one down.
For example, it's not just confined to PKU and Gaucher disease where we have a defined enzyme deficiency, but say all the disorders related to autophagy and cytoskeletal disorders, a lot of them now come under the umbrella term of inherited metabolic disorders. And while we understand that it's a growing branch, it's interesting to note that as per literature, 36 to 50% of patients with IMD are diagnosed after 16 years of age. Probably an understatement given the lack of sensitization towards these disorders. We must understand that there are some challenges in dealing with individuals who are adults with metabolic disorders. Firstly, most existing books and diagnostic algorithms still refer to pediatric forms of the diseases. Attenuated phenotypes of many IMDs are far less described. And in an adult, the phenotype is often intermingled due to acquired symptoms resulting from factors such as lifestyle factors and pollutants, environmental factors, and so on. And that's why it becomes difficult to tease out the true symptoms related to the IMD versus those which are not related to it. And again, much less is known about the yield of specific diagnostic test in adults as compared to children. Last but not the least, a very practical problem that even if we do initiate a diagnostic journey for an adult and you land upon, say, a variant of uncertain significance and wish to do further segregation, often parents and siblings could be unavailable because of the age factor and that these individuals are presenting late to the physician. There was an interesting paper study conducted by Professor Fanny Moschel and a group in 2018 where her team conducted a survey of 42 adult metabolic specialists from 18 countries, largely involving internal medicine, endocrinology, genetics, and neurology. And what you see is that nearly 70% of them gained their experience out of practical day-to-day work, and barely 12% of them actually had a formal education at the university. So it's just to say that there is a bit of a lag in our, maybe even in the training that we have towards these adulthood onset metabolic disorders. This other interesting paper by Ferreira E's group in 2023, which spoke about a meta-analysis of the diagnostic yields in AOMD, found that the commonest presentation in individuals with adulthood onset metabolic disorders is neurological, and within that, the common presenting features are extrapyramidal, intellectual disability, psychiatric symptoms, pyramidal tract symptoms with myelopathy, peripheral neuropathy, and epileptic seizures. Although in our center at Bombay Hospital, we see a lot of, it's not mentioned in this category, our experience is we often see a lot of patients with neuromuscular phenotypes in the myopathy spectrum and the muscular dystrophy spectrum at our center. So when should we be suspecting? I think the red flags are pretty much similar to what we see in childhood. It's just that we need to keep these flags alive even when we are seeing an adult patient. Fluctuating clinical symptoms, especially when triggered by fasting, exercise, fever, catabolic circumstances like post-anesthesia, postpartum, clinical signs that suggest a diffuse disease, not just neurological, but other systems too. And of course, involvement of different parts of the nervous system. So you get a pattern where there is cerebellar involvement, leukoencephalopathy, polyneuropathy. These are some red flags to start considering the suspicion for an adult metabolic disease. I have some case vignettes which I'm going to just race through in the interest of time. I've divided them into three categories. The first three cases are those which are adulthood onset presentation of a typical childhood IMD. So I'll take you through the examples. This was a gentleman who presented to us at 23 years of age. He was a firstborn to a third-degree set of consanguineous parents, otherwise had a normal life so far, but at 20 years of age, he started complaining of chronic headaches, focal dystonia of the left hand, and 2 unprovoked falls resulting in head injuries. His MRI showed these periventricular white matter changes with some cystic lesions in the anterior area, and while we were not really suspecting of Wilson or metachromatic leukodystrophy, we just went through the routine important metabolic profiles and it didn't yield much. It's actually the exome sequencing which revealed a homozygous variant in GCDH gene, which was not VOUS, ultimately got upgraded to likely pathogenic because the GCMS values were pathognomonic for late onset glutaric acidemia type 1. It was heartening to actually see the response of this patient. This was after 3 months of giving carnitine and, just one moment. Second. Yeah. Okay. 1 minute. How do I get rid of this laser option? Yeah. Yeah. So you can see that in this video he had quite a bit of abnormal tandem gait, and this is after 3 months that his gait had improved. His headaches had come down by 90%, he said, and of course a lot of well-being subjectively reported. So this is a typical prototype of an otherwise childhood onset presentation, but how it has come in an adulthood in an adult patient. When we speak of late onset GA1, it usually presents after 6 years of age. The symptoms are often non-specific with sometimes just general symptoms like nausea, headaches, cerebellar signs, non-specific really, not something that can take you to it based on pure history. Surprisingly, as against the childhood onset, late onset glutaric acidemia 1 is not prone to acute decompensations and actually has better prognosis, longer survival, and a great response to treatment. The white matter changes are actually typical, especially the presence of subependymal nodules along with leukoencephalopathy has been described by some authors as a relatively specific sign. The good point is the apparent non-susceptibility for striatal lesions. We are aware that this is the factor that actually results in poor prognosis in the childhood period for those that have a neonatal presentation. And we have seen that these individuals respond wonderfully to lysine-restricted diet, carnitine, and riboflavin. It's surprising to note that there is no genotype-phenotype correlation. Individuals with the same genotype and the same biochemical phenotype have been reported as having neonatal presentation as well as those having adulthood onset presentation, which brings to mind the discussion about probably genetic modifiers, epigenetic modifiers, and opens the Pandora's box of how much we really still don't know. This is another interesting case where this was a 31-year-old female. She had severe exercise intolerance, waddling of gait, proximal upper limb and lower limb weakness, hyperreflexia, flexor plantars, fatigability, myopathic EMG. Her CPK levels were like elevated, really elevated, and she otherwise in the rest of the workup had a normal 2D echo, normal hearing assessment, normal ophthalmic assessment, and we did everything that we could from our end. Of course, in hindsight, maybe we would have been wiser had we even done TMS and GCMS, because the whole exome sequencing showed homozygous VOUS variants in ET-FDH, which suggested late onset glutaric acidemia type 2, and the metabolomics actually confirmed it. And she had dramatic response to like 4 weeks of riboflavin and CoQ. This girl actually said she had reclaimed her life. I mean, she needed help to even walk to the washroom in her own house, and now she was climbing stairs, had started doing her day-to-day activities, and it was really heartening to see how a simple diagnosis and a treatable one especially can have an impact in a person's life. And she had never really even climbed stairs in her house for the last 3 years. She was needing the ramp to get into her building, and here we can see that things were different for her now. So this is again another presentation of a common otherwise childhood onset disorder, but glutaric acidemia 2, actually the commoner presentations are late onset ones. Myopathic presentations are known and described. They are also prone to sometimes extreme rhabdomyolysis and pain and exercise-induced intolerance. This lady had actually a triad of vertical gaze, limited vertical gaze. She had ataxia, deteriorating cognition, and it's not difficult to put the pieces together. This was a case of Niemann-Pick type C2, and again, this brings to mind as to why for the same given set of genotypic and metabolomic profiling are we getting such extreme variability in phenotypes. This is a good paper which tries to address at least the variability for Niemann-Pick type C. Could it be related to the type of the variants, something that they call as a lipid bypass exit, which results in a little attenuated phenotype, the role of epigenetics, environment, and so on. So I think what we learned from these three vignettes is that phenotypes could differ in the attenuated AOMDs. Reasons for phenotypic variability are still unknown largely, sparing few like the residual enzyme and the type of the variants. And flagging an adult onset genetic disorder on newborn screening can actually be debatable, and such cases bring to fore the discussions related to such aspects too. Very quickly, so the next vignette is about an adult who actually had presentation in childhood but got diagnosed in the adulthood period. This lady had like foot drop and difficulty in walking, distal weakness. She is a dentist by profession, so really struggling with her day-to-day work. And if you see the pedigree carefully, she had like 2 generations above her who had similar findings. So they actually considered it normal in the initial periods when she had a foot drop, that maybe this is just something familial. And actually the very typical sign which helped us to clinically shortlist our differentials was that she had this very typical weakness of the extensors of the 3rd to the 5th finger. She could raise the 1st and the 2nd, but not the 3rd to the 5th. This all seemed to be fitting into certain type of MYH7 type of clinical phenotype, but the presence of fasciculations and tremors wasn't really fitting into the picture. So while we debated, well, are we dealing with some type of Charcot-Marie or some distal hereditary myopathy, as I said, based on flowcharts and protocols, we did think that we were dealing with MY7 related lying myopathy. It kind of fit into the clinical picture, though it did not explain the presence of tremors and fasciculations. And again, it was an exome to the rescue where we found that it was not just the cytoskeleton related MY7 lying myopathy, but it was an OPTN related additional amyotrophic lateral sclerosis, which segregated with the father who incidentally had psychiatric manifestations and early features of the condition. So I think I'll skip this. It's just that we understand how these various genes are opening avenues into our understanding of pathomechanisms and various pathways within the cellular functioning, especially OPTN and its role in the pathways of multisystemic proteinopathies, which are a group of autosomal dominant disorders with overlapping phenotypes. In the interest of time, I'll just skip this slide. And I come to the last aspect of the, the case presentations, but this is a pure adulthood onset IMD, no childhood onset presentation known, and presenting for the first time in adulthood. So this was a 24-year-old female presenting with difficulty to get up, proximal weakness. While this weakness was progressive, rest of her complaints were not really significant. She had this scapular winging and mild pes cavus. Her distal weakness was actually prominent, areflexia. She had length-dependent axonal type of neuropathy, motor more than sensory involvement. And with all these features, adulthood onset, progressive, axonal neuropathy with weakness, we were wondering, we just tried to get the list of all the adulthood onset presenting features of axonal neuropathy, CMT type 2, but there were features for and against each. Frankly, we didn't suspect SORD, although it was later that the exome kind of revealed that it was indeed a case of sorbitol dehydrogenase deficiency. And the features marked in bold are the features that the patient had. It's interesting to note how this condition is actually due to an inability to metabolize sorbitol, leading to an accumulation, upstream accumulation and toxicity to the motor neurons. And it's interesting to discuss this because there are upcoming drugs which have a promise to probably reduce this accumulated sorbitol, and govorestat, apparently as per discussion with adult physician, is a repurposing of a drug which has also been being tried for other adulthood onset sugar metabolism disorders. This is just very quickly, it's an adulthood onset ALS. I will skip through this in the interest of time. It's just to note that, again, while familial ALSs have 50 to 60% yield, our knowledge about ALSs and the genetic landscape is just evolving. This was an 18-year-old male actually having completely fine otherwise, but at 15 years started having tremors and twitching and evolving claw hand with an unstable gait, bradykinesia, and he had this extrapyramidal involvement too. He had a mix of UMN and LMN features. There was hyperreflexia with extensor plantars, while the rest of the features were suggesting like an LMN pathology, and this was very typical of the ALS spectrum. The NCS also showed active denervation and as well as chronic renovation type of a picture. MRI showed white, subtle white hyperintensities, but the rest of the findings didn't really take us anywhere. It was a surprise when we did the genetic test. We found that this individual actually had a pathogenic heterozygous variant in the FUS gene associated with amyotrophic lateral sclerosis type 6, and we are aware that this a variant in this gene can result in stress pathways within the motor neurons, causing proteotoxicity. It's interesting to know that actually, if we talk only about the FUS gene, 4 to 8% of the cases where there is familial ALS could be related to FUS-related gene, and while most of them present after 50 years of age, this young man had it at a young age of 18 without family history. Interestingly, it's commoner in the Asian cohorts, and as against the SOD gene, which doesn't really have bulbar onset, this type of ALS can have a bulbar manifestation too. So I think that end by giving the take-home messages that there exists phenotypic variability in all, not just late onset glutaric acidemia 1 and 2, but in general with a lot of disorders which can also present in childhood period. And what we've learned is that routine incorporation of these basic metabolic tests, basic metabolic profiling can increase the yield when we are working with adults with suspected metabolic disorders. We need to keep in mind the role of probable genetic modifiers and be cautious while designing expanded newborn screening, because we don't know although rare, we may be flagging a probable adult with a mild and an attenuated phenotype right from the newborn period. I'm thankful to my teachers and all the stalwarts in this picture at Bombay Hospital Department of Neurology. Special thanks to Professor Fanny Moschel, whom I had the wonderful opportunity to interact with during our recent master's course in Barcelona, and I can't thank my team enough at the Purple Gene Clinic. And with that, yeah, thank you so much. Thank you.
Thank you, ma'am, for this fantastic presentation. Inborn error of metabolism has always been a difficult diagnosis to make. I'm a neonatologist, and our center also, we face a lot of trouble in diagnosis of IEMs. So what I have learned is whenever we don't get a diagnosis, we send IEM workup. So very nice presentation, ma'am. We are open for question answer sessions.
Thank you for this lovely presentation. So I was wondering, so we do all those metabolic testing, but at the end of the day, we should simply start with WES, don't we? Whole exome sequencing. It's a little bit provocative, I think, but my experience from all the metabolic testing, and that's predominantly in neurodevelopmental children with neurodevelopmental disorders, you don't pick up anything. Yeah. And with WES, you pick it all up?
I think whether we do the metabolomics first, the basic metabolomics or the genomics first, it depends on the country where we are working and the kind of resources that we have. So for example, during our training at Barcelona, because a lot of their routine tests like TMS, GCMS are in-house, they tend to do those first before going on to genetics. Whereas in our country, actually doing an exome is cheaper than doing all the metabolic tests put together. So yes, that is what is the practice that we are seeing, that after doing some basic phenotyping, basic biochemical test, we do end up going for an exome first and then go retrospect if we get, like in both these cases, that we got the GA1, got the GA2, went back and then did the phenotyping, the biochemical phenotyping. So I think there's no definite right or wrong. It could be region specific, but yeah, in our country, we do exome first.
Very modern, very good. Keep this up. Another remark is, so who's starting collecting this data? Here or elsewhere? I mean, so you have some nice cases and you present them here, but then where do they go to? So you have the experience of late onset. And so yes, of course.
We are in the process of, because the merging of genetics with the Department of Neurology is a recent one at our center, and we are trying to collate data and similar studies to the ones that are done by SSIEM to understand what are the knowledge gaps in India and how do we fill them up in. The data is of course getting archived, and we are in the process of making it more public, but it's in the beginning stages.
So tomorrow I will be presenting about the Human Disease New website series. Pay attention. Maybe that might be a way to collect this data, not only for your region or for India, but for the whole world. Give it a thought.
Professor De Vries is promoting his own website.
It's not my website, it's the website for the whole world. So I'm only facilitating something together with lots of others.
Thank you for clarifying.
Thank you so much. Thank you.
You have a question?
This point of view, I just want to know, there was very excellent cases. We would have rarely diagnosed these cases in our practice. But could you make up a pointer or something which we had missed in the past history, or something which we could have detected, which could have helped in the early diagnosis of these cases? Or we can now go back and do some tests in detail so that in future this will help in the early diagnosis of these cases.
You mean as a pediatrician, are we missing these disorders? So that's why I try to segregate the cases into 3 categories. Those cases which are going to have a childhood onset, like the one with OPTN and MYH7, there of course I think it's a case of a missed diagnosis. But if the onset is going to be at 18 or 20 years, I think there's little that we can expect from the pediatric community, No, I
mean to say, the childhood onset metabolic disorders, now presenting in adult, there is a variation. So is there any indicator or something which could have presented?
No, there were none. There were none in these cases. So that's what I'm telling. There will be one cohort of cases where there's nothing that could have flagged it. And while there are some others which could have, like the example of that MYH7, where the pedigree, the features, they were all like very loud and clear that there is something wrong with the child, but she got diagnosed at the age of 40. So yeah. Thank you. Thank you so
much. Thank you, ma'am, for sharing the beautiful insight and making us a better understanding about the new metabolic disorders. Now I'd like to invite Dr. Christine Couchet to facilitate Dr. Shruti Bajaj. Ma'am, please come on the stage. Excuse me, everyone. I would like to invite everyone to the stage for the group photo. Please welcome. All of you are invited to the stage, please. It must be good on the background.
And I will keep on promoting until I die. That's good you mentioned it. How many genes are there? 100 plus. 1,400 adapted genes.
So what I think is there will be a group of people sitting here, some people standing there, and the young students sitting here.
Oh, I feel young as well. Is that okay?
प्रिया मैडम आगे बैठेंगे आगे
Moving further, now let us welcome our next speaker, Dr. Nora Shannon, Consultant, Department of Genetics, Nottingham University Hospitals, United Kingdom, to continue our journey of learning, to speak on TGF-beta, North signaling, pathway disease, the model of Marfan syndrome and related diseases.
Hello, can I have my first slide, please? I can see it on the laptop, but not up there. Way, fantastic. So I'd like to thank the organisers. What a great opportunity, my first trip to India, and I'm going to tell you about TGF-beta signalling today. So Aortic aneurysms and dissections account for about 1 to 2% of all the deaths in Western countries. Thoracic aortic aneurysms have got an incidence of 10.4 per 100,000 person years. And so when we look at large population studies, we see that 20% of patients with a thoracic aortic aneurysm will have a family history. And if you start to screen those people physically, you'll find that 37% have got relatives who've got some aortic dilatation. So the genes involved in aortic aneurysms have been widely studied, and they encode parts of the extracellular matrix. They also encode smooth muscle cell contraction or metabolism, and the transforming growth factor beta signaling pathway is really important in this area. So it's known to be a key culprit in the etiology of thoracic aortic aneurysms. It's a highly conserved group of ligands and cell receptors, and it contributes to cell growth, to differentiation, homeostasis, and apoptosis. Signaling by TGF-beta involves coupled intracellular pathways, specifically SMAD-dependent pathways and SMAD-independent pathways, including PI3K, AKT, and MAPKs. If you dysregulate one of the pathways, it results in changes in activity in multiple other pathways that are interwoven, and you get aberrant signaling leading to disease. So trying to decipher the contributions of these intersecting pathways is really key in trying to develop therapeutics for patients who are affected in this situation. So I'm not going to spend a lot of time talking about the pathway itself, just to say that if you look at this pathway, you will see lots of familiar old friends. You'll see straight away that we have fibrilin 1 there for Marfan syndrome. You can see that we also have got some of the genes involved with Loeys-Dietz syndrome. SCI is there for Sprintzen-Goldberg, fibrilin 1 for cutis laxa type 1b. And also, we've got to remember that some of the genes in this pathway produce non-syndromic thoracic aortic aneurysms as well. So we have things like ACTA2 there, and we also have myosin that you can see. So I'm going to begin by talking about Marfan syndrome. We all know this condition. It's the thing of medical student textbooks. So I won't labour too much on the physical features of Marfan syndrome, but talk a bit more about the management. And then I'm going to go on and talk about Loeys-Dietz syndrome, which is probably the second most commonly thought of TGF-beta pathway condition. And then we'll talk about a non-syndromic gene. So fibrilin 1 was identified in 1991. It was the beginning of the TGF-beta story. It's a large glycoprotein that assembles to form microfibrils in the extracellular matrix, and it can regulate TGF-beta availability by releasing latent TGF-beta from the extracellular matrix in response to pathophysiological stimuli. It leads to structural weakness of the connective tissues, but it also, the increased signaling contributes to the phenotype we're seeing in Marfan's as well. So you get variants throughout the entire gene, but there are genotype-phenotype correlations. We know that missense variants substituting or producing a cysteine residue have a higher incidence of dislocated lenses that you see in neonatal Marfan syndrome when there are variants between exons 24 to 32, and that haploinsufficient variants, such as nonsense or out-of-frame variants, have more severe aortic problems than variants that lead to a dominant negative effect. So as I said, I'm not going to spend a lot of time talking about the features that we see in Marfan's. Some of these are things that we use for a diagnosis, and some of them are things that can actually cause a problem for the patient. So it's important to differentiate between the two. So things, for example, like having a high palate or having a positive thumb sign or a pectus is rarely going to cause a significant issue for the patients that you're seeing in clinic. Unless you have a significant pectus excavatum, which is impeding either cardiac function or lung function. But these are all things that help us to spot these patients when we see them in clinic. In 2010, the Ghent criteria were revised, and they The revision was aimed to weight things to the most discerning features. There are lots of things that we see in tall, slim people, but and that are also common in Marfan's, and it's to try and separate those two situations. So we know that 75% of patients with Marfan's have got a pectus, and so that's a really good handle to look for in clinic. 15% have got ectopia lentis, which is obviously quite unusual in the general population. And then about 80% will have some aortic dilatation by the time they are 20 years old. So if you use those criteria, you will find that about 97% of your patients will have an identifiable variant on genetic testing. As a geneticist, you know, we're obviously always thinking about genetics, and as we flew over, I noticed that we were passing very close to the home of the Ghent criteria on the plane. So what's important in terms of management for patients who've got Marfan syndrome is, first of all, remembering that their whole aorta is at risk, and that if you're doing surveillance, you need to be keeping an eye on the whole of the aortic tree. They need careful blood pressure management. You need a low threshold for starting either beta blockers or something like losartan, which both reduce TGF-B1. You need to have the right threshold for surgery, which I'm going to talk about in a moment, and you need to be thinking about these patients as they get older in terms of, especially, for the ladies, that you're thinking about preconceptual counselling, things like pre-implantation genetic testing, and making sure that they are having scanning before they enter into a pregnancy and have an aorta that's below 40 millimetres. For young children, they need ophthalmology surveillance because they won't know that they have dislocated lenses, and that can lead to amblyopia. And then they need some lifestyle and sports advice, and I'm going to talk about that in a moment. So there have been two really good publications this year to help us with managing patients who have got Marfan syndrome. The ESC guidelines have come out about management for peripheral artery disease and aortic disease. They've got some very good information about how to take care of patients who have got Marfan syndrome and Loeys-Dietz. They've got some recommendations in there about how often you should be screening people and how you should be screening them, particularly for the cardiologist, how you should be taking the measurements and at what position in the cardiac cycle you should be doing that. And then there are also recommendations about the threshold at which you should be intervening when your patient has got Marfan syndrome. And generally speaking, for someone with no other risk factors, you should be looking at about 50 millimetres before you think about surgery for patients. But when they do have other risk factors there, then you might go down to 45 millimetres, depending on what the family history looks like, etc. The second paper that's come out for Marfan syndrome is also from the European Society of Cardiology, and this is a specific paper looking at management for children with Marfan's, and this has been somewhat overlooked in the past, so this is a consensus paper. It's got some very good information for children who are on other medicines, particularly for attention deficit hyperactivity disorder. But then there's a really good section about exercise, which is a very thorny issue in children with Marfan syndrome. In the past, studies had suggested that you should be very conservative in your advice about exercise, but recent studies have shown quite a lot of benefits to exercise for children who have got Marfan syndrome, and it can actually have some protective effect for the aorta. You don't get significant blood pressure changes during exercise below the age of 10, so you shouldn't really be restricting your children who are below 10, but obviously if they decide they're going to take up, for example, a contact sport, and then you're going to have to tell them to stop it when they get to 10, then you need to be putting in some thought before patients get to that stage. They also have clarified in here, as you can see on the right-hand side, exactly what is meant by competitive sport, and it's more to do with the length of time that you're exercising and the actual intensity. So we're going to leave Marfan syndrome now and talk about the other well-known condition in this pathway. This is a little boy who came to clinic mainly because he'd been found to have some aortic dilatation on his echocardiogram. And the paediatricians had already done some work for him because he had a slightly tall, slim build, and so they'd been having some thoughts about Marfan syndrome for him. He had a cleft palate and a bifid uvula, submucous cleft palate and a bifid uvula, and he had quite soft skin, no atrophic scars. He had a little bit of contraction of some of his fingers. and he had metatarsus adductus kind of appearance to his feet, and you can see this kind of foot appearance in our kids who have Marfan syndrome as well. So he'd had some investigations before he came to see us. We knew that his eye examination was normal. We knew he'd had a skull x-ray showing some sagittal synostosis. And his father had come in to clinic with him. Very poor photograph. Apologies for that, although it projects better up there than it does on here, showing that he had a bifid uvula as well. So we went straight to genetic testing. We had a very good idea of what this little boy was going to have. And he did have a TGF-BR2 mutation, confirming a diagnosis of Loeys-Dietz syndrome. Both the child and the father went on to have further investigations, and the father has got aortic root dilatation. He's also got tortuous vessels, which is very classically seen in this condition. So Loeys-Dietz was described later than Marfan syndrome in 2005. In fact, I've been around long enough that I can remember this. Usually it presents with hypertelorism, a cleft palate or a bifid uvula, and arterial tortuosity. There can be craniosynostosis. They might have some instability of their cervical spine, and they can have dissections outside the aorta. The patients can show quite a strong predisposition to allergic and inflammatory disease, so it's like asthma and eczema. They can also get gastrointestinal inflammation, eosinophilic esophagitis, gastritis, inflammatory bowel disease are all recognised features. Although Loeys-Dietz was initially described as type 1 and type 2, we now know those are actually part of a clinical continuum, and we now know that although the initial genes, TGF-BR1 and 2, were described, there are now a list of genes that can lead to this type of phenotype, but you do find variations. There is a correlation between the gene and the likelihood, for example, that you're going to dissect, and also other clinical features. So, for example, SMAD3 leads to a lot more problems with osteoarthritis. So there's a face that can go along with Loeys-Dietz. It's not always there, but it can give you a clue if you've got that hypertelorism. And when you do more detailed investigations looking at the vasculature, you'll see these very ectatic vessels very often. So you have to be more interventionist with Loeys-Dietz than Marfan syndrome in terms of thresholds for surgery and how often you should be screening them. They need an MRA from their head to their pelvis because they can have widespread arterial involvement, and they can rupture at smaller aneurysm sizes than Marfan syndrome. They need a skeletal assessment, particularly for cervical spine instability, but they can also have congenital hip dislocation and joint hypermobility. The females are at risk of dissection during pregnancy in the same way that we see in ladies with Marfans. There have also been reports of uterine rupture and uterine hemorrhage as well. They're treated medically in the same way that we see for Marfan syndrome, and they also need assessments for problems like allergies. So in with the ESC guidelines, similarly to Marfan syndrome this year, we've got some thresholds, recommendations about how often to screen them and what way to screen them. And then you can see the threshold for intervention, if you look at the whole condition as a whole, is lower than Marfan syndrome at 50. You tend to start to think about surgery at about 45 millimeters for the aorta at the sinus of Valsalva. You can then split your thresholds down even further if you've done genetic testing and you know which gene is involved. And I think this is really interesting that we're moving in this direction, that we have enough patients and enough data to start to be very precise in the way that we treat patients with genetic conditions. And I suppose this goes back to what Bert was saying earlier about how important it is to create databases and collect information about these patients with rare disease, because that's the only way we're going to get this kind of powerful information about how to treat them, and also cohorts that might be amenable to drug therapies in the future. And so for my very last vignette, I'm going to talk about non-syndromic genes that are in the TGF-beta signaling pathway, and just tell you a salutatory tale about the family that we saw. So this is a young lady who had an aortic dissection. She was aged 20 and she had a bicuspid valve, and she was seen locally by cardiothoracic surgeons and cardiologists. And I think possibly because she had a bicuspid valve and we know that's associated with dissection, there wasn't that level of intellectual curiosity about why this young lady had dissected, but they did organise physical screening for her mother and for her sister. And her sister had some very mild dilatation, but it wasn't clinically actioned, so there was a missed opportunity at that point. The sister became pregnant at 28 years, and she mentioned it to the midwife who was booking her, and again, there was another opportunity to look back at that scan that she had had and identify that she had some mild dilatation, and that opportunity was also missed. Sadly, she died before the end of the pregnancy. She'd dissected. The baby was lost, and the family were referred back to us in that very tragic situation. I assessed the lady who was the proband, and she didn't have any physical features of Marfan syndrome or a connective tissue disorder, and we organised genetic testing for her and found that she had a variant in ACTA2, which was also carried by her mother, who has got some very mild aortic dilatation, also by her half-sister, and one of her half-sister's children. So they're all now having surveillance locally, and there are plans for some prophylactic surgery in the family because of the thresholds that we have for intervening in ACTA2 patients. So this is a really useful diagram from the ESC paper that I've been talking about in terms of managing aortic disease, and it shows you the kind of thresholds that we're looking at for intervening when patients have got variants in ACTA2, which is the most common non-syndromic gene that we deal with on our aortopathy panel. And you can see that the point at which you think of intervention is kind of similar to Marfan syndrome. So in summary, we need to understand these pathways in aortic disease. It's key to targeting therapies and to precision medicine. Genetic testing is a precondition now if you're going to follow current consensus management, either consensus that comes out the ESC or American groups. And also, cascade genetic testing can save lives. So if you can do genetic testing for your patients with aortopathy, then you can cascade that testing out to other people in the family and potentially save them from running into the fate that we saw in our last family. So I'd like to thank you for your attention and the opportunity to visit Jaipur.
Can you bring the mic to the mic? Oh, you got no, a mic, please, for the audience.
Thank you. So it's wonderful to see that if you start collecting, that at the end of the day, you really get through advices what to do with sizes. Yeah, so it was good to see. I was wondering, so I have a very old-fashioned question. So when I was trained in a way that Marfan is a clinical diagnosis and don't be too much disturbed by, let's say, the molecular diagnosis, because there are lots of, it's a large gene and you have easy variants all over the place. So enlighten me, is this still the way or should I change a little bit?
No, and you're right. When I trained, we did very little testing for Marfan syndrome because it was very difficult to interpret the results. And we made it purely on the clinical diagnosis, didn't we? But I think as time has gone on, databases have got larger. We actually get quite few VUSs when we do testing on our aortopathy panels now. And I think it's just the way that things have gone over time, that for some of these genes where we have a lot of information about them and their function and their common variants, that you, over time, reduce the VUSs that you have. So now, I would encourage people, if somebody is near the diagnostic criteria, to think about a test, because I've had patients with Marfan syndrome who haven't quite met the Ghent criteria for whatever reason. You, like all genetic conditions, you see variability, don't you? And what we thought of in the past as being our classical patient with Marfan syndrome, what they should have, you now realise that there are people that are much more mildly affected who, you know, may not have had a diagnosis in the past.
Yes, because you have a strong worldwide team working on this, on Marfan, the Ghent criteria and so on. I think here AI might help you far more further in, you have so much data, and so are people working on this using AI and in how to predict based on your clinical features what the outcomes are. It's not so difficult, AI. The only difficulty is you need to have good data. And
yes.
I think
yes,
your whole consortium do have good data.
I think most clinicians will still, when they see patients with aortopathy, they will still fill in some kind of sheet or pro forma for collecting the Ghent criteria, so that when they get their genetic test results back, they have that information. So I'm sure genetic centres across the UK, and I'm sure in Europe, you would find some form of the Ghent criteria recorded in these patients' notes. So there is a wealth of data out there that probably would be easier to put into some form of AI than a lot of the other kind of dysmorphology type of syndromic diagnosis we make.
Because if you do this, you might even get to personalize advice and treatments, even more than group-wise.
Yeah.
Any other questions? No, that's fine. Thank you very much, Dr.
Thank
Shannon.
you.
And do you want to wait? Or?
Yes, ma'am. Please wait a second. Thank you, ma'am, for sharing such insightful thoughts and enlightening us with this new take to the known disease. Now I would like to call upon Dr. Abhijit Dixit to please felicitate Dr. Nora Shannon. Ma'am, please this way. Let this conference be where our aspirations for a healthier tomorrow take root and flourish. Without further ado, let's dive right into the very heart of our schedule. I have the honor of inviting Dr. Divya Agrawal, clinical geneticist, Apollo Genomics Institute, New Delhi, our speaker for the topic, birth defects due to inborn error of metabolism, what's new, to take the stage and grace us.
So at the outset, thank you very much to the organizers for giving me the opportunity to speak here. So the topic that was given to me was the inherited metabolic disorders, birth defects due to inherited metabolic disorders. And essentially, this was too wide to be covered in 15 minutes. So what I thought was that I will try and, do the, make it a little more, sort of focused to the IEMs affecting the brain. And in the morning before lunch, there was a discussion about, whether the birth defects, whether the neurodevelopmental disorders or the neurodegenerative disorders for that matter, should they come under the realm of birth defects. However, what I feel is, and after reviewing the neurodevelopmental and the neurodegenerative disorders being also coming in the purview of, the inborn errors of metabolism which are affecting the brain, we feel that, the neurological disorders, the developmental as well as the degenerative disorders, to an extent, deserve to be called birth defects. So, inborn errors of metabolism have a strong predilection for the nervous system, and that is what I thought I will cover in the talk today. almost all the inborn errors of metabolism display neurological manifestations. About 85% of them display predominantly neurological manifestations, and these manifestations could be in the form of neurodevelopmental problems as well as neurodegenerative problems. Now, neurodevelopment begins in the early fetal stage, and it is a complex process which encompasses the proliferation of the cells, differentiation of the neuron cells, migration, and then integration into the functional circuitries. And any disruption at any of these stages will lead to respective defects of or respective neurological problems. Now, inborn errors of metabolism could be small molecule defects or complex molecule defects, and then finally the energy defects. The small molecule defects, these are those ones which, in which we have clear-cut small diffusible water-soluble molecules which can be easily and rapidly measured, encompassing mainly the disorders of amino acids, organic acid, acyl carnitines, etc. Now, in this also we can further divide these into the small molecule diseases which are linked to the accumulation of the compounds due to the defects of the enzymes which are metabolizing these small molecules, or they are linked to the deficiency of these small molecules where there is primarily a defective synthesis of these small molecule compounds, and accordingly the clinical signs and symptoms are due to either the intoxication or they occur due to the defective, the absence of the critical compound which is needed for a particular developmental process. Usually the small molecule, although they cannot be generalized, but they are usually treatable and require the removal of the toxin. While here the synthesis defects may also be treatable by providing the defective or the absent compound. Now the examples very clear: amino acid catabolism, urea cycle defects, organic acid ureas, all of these come into the category of the small molecule diseases linked to the accumulation of the toxic compounds, while the diseases which are linked to deficiency are defects like serine synthesis defects, manganese transporter deficiencies, a lot of transporter deficiencies which are leading to a defective transport of a molecule, of a critical molecule, leading to its deficiency. And essentially we are talking about the brain here, and also the inborn errors of neurotransmitters will come into this particular category of the inborn errors of metabolism which are linked to the deficiency of the compounds. The complex molecule defects are the diseases which disturb the metabolism of the complex molecules, and these essentially encompass the defects which are involving bigger molecules, glycogens, sphingolipids, phospholipids, cholesterol, glycosaminoglycans, etc. And again here also they are further divided into the diseases which are linked to the accumulation of the molecules or due to the deficiency of the molecules due to defective synthesis. So here in the accumulation we have the entire group of our lysosomal storage disorders, the sphingolipidosis, mucopolysaccharidosis, and the diseases which are linked to deficiency include the cholesterol synthesis disorders, the peroxisomal biogenesis disorders, the CDGs, purine and pyrimidine synthesis and metabolism disorders, all of which have predominant neurological symptoms at presentation. And finally, there are disorders which are involving primarily the energy metabolism, and in this we have three main categories of disorders. One wherein these are due to deficiencies of the membrane carriers of small energetic molecules like the glucose cerebral transporter and the monocarboxylic acid transporter, again very important for the brain. A major category here is the mitochondrial defects, which I will now talk about in detail because these are the most severe and difficult to treat, and the brain manifestations of mitochondrial disorders are extremely frequent and they cover a large variety of early postnatal to late onset adult clinical features as well. And then there are some cytoplasmic energy defects, which if diagnosed, they are partially treatable also, like creatine metabolism disorders. Now I want to just concentrate on the mitochondrial defects, and before that, of course, this particular picture shows the spectrum of these inherited metabolic disorders affecting the brain, from the neurodevelopmental to the neurodegenerative disorders. So the three categories that I just showed, the small molecule accumulation, the small molecule deficiencies, the complex molecule disorders, and then the energy defects. You know, if you see, there is a whole spectrum of these disorders, and as we move towards the right side, it leads to, these are the kind of, you know, the energy defects are the ones which are mostly leading to more severe form of neurodegeneration and even death. So this is sort of the spectrum in terms of the neurological involvement of the metabolic disorders, explained also here by the main clinical presentations. Now coming on to the mitochondrial disorders. Mitochondrial disorders occur due to the deficiencies in the nuclear DNA or the mitochondrial DNA, and we try and clinically, when we try and categorize or diagnose mitochondrial disorders, they are usually identified because of their multisystemic involvement, and particularly the involvement of the tissues which are highly dependent on the aerobic metabolism, and those that have high energy requirements like the CNS, the heart tissue, and the skeletal muscles. But again, the neurological system forms an important component of the clinical picture of these mitochondrial disorders. MRI remains very, very critical for the diagnosis of the mitochondrial disorders, which have typical neuroimaging features. Sometimes, you know, we see typical spatial distribution, and these features also evolve during the course of disease, and hence we say that they have a typical temporal distribution also over time period. The spectrum includes basal ganglia signal intensity changes, cortical signal intensity changes, subependymal cysts, white matter changes in the form of leukoencephalopathy, white matter cavitation, callosal agenesis or dysgenesis, or myelination defects. And this is how all the MRI abnormalities look when we suspect mitochondrial disorders. So we have the various abnormalities of the putamen, thalami, the globus pallidi, the midbrain tegmentum, the hyperintensities in all of these areas, the deep nuclei, the cerebellar nuclei, the dentate nuclei. There it could be cortical involvement, white matter involvement, as well as cerebellar atrophy. So these are the typical MRI abnormalities in terms of the spatial distribution of the mitochondrial conditions. Now, the conditions which occur due to mitochondrial DNA mutations, they usually have typical involvement of specific systems, while the mitochondrial disorders due to nuclear gene mutations also have a multisystemic involvement, but they often present with neurological signs and symptoms, as well as they are the ones which are more severe and have a more neonatal and infantile presentation. Now, the reason why I chose the mitochondrial disorders was also because we have seen a lot of mitochondrial neurological manifestation disorders in our patients, and we have tried to phenotype them and see the similarity of phenotype in all these mitochondrial patients where very diverse mutations have been identified. So this was, I would just like to present our 5 pediatric cases, in fact very young children who were diagnosed with the mitochondrial disorder with predominant neurological manifestation, 1 year, 5 month old. there was just, 2 couples, so 3 couples out of the 5 families were consanguineous. 1 year, 5 month old, the first child. There was, when the child presented to us, the child presented with poor growth. The first symptom initially which led the parents to seek medical advice was a febrile seizure at 2 months of age, and after that there was a mild motor delay with hypotonia that the family started noticing, and till 1 year 5 months of age there had been no regression. As the child presented to us with predominant motor delay, we got and just a history of febrile seizure along with failure to thrive. We got an MRI brain done where there was nothing significant that was observed. On an evaluation of hearing and vision, there was bilateral optic atrophy that was diagnosed. On a VP, there was a complete conduction block, and then there was some increased, I'm so sorry, the last part of the slide is probably not visible. There was some increased liver enzymes and increased lactate values, which suggested us to do the genetic testing for the mitochondrial disorders. We test for the nuclear genes as well as the mitochondrial genes together as a panel, and that is when the child was diagnosed with a homozygous mutation in this LRPPRC gene, which is related to the mitochondrial complex 4 deficiency, typically leading to the Lee syndrome. This child typically not presenting as Lee syndrome yet, probably. Lee syndrome children usually will present, the typical presentation for this gene is a severe neuroregression that occurs usually in late infancy or early childhood. However, this child still did not have any regression. He was mildly improving on therapies. There was just a predominant motor delay and optic atrophy. The next child was a 5-year-old female born to non-consanguineous parents. There was failure to thrive that was noticed at 6 months, because of which the medical attention was sought at first, and then there was motor developmental delay again noticed. So almost similar course as the first child. However, then there was neuroregression from 3 years of age, which was fluctuating, and now again the child was improving since the age of 4 years. On MRI brain, there was leukodystrophy, basal ganglia lesions and cystic changes, and there was a motor sensory polyneuropathy of demyelination type in the NCV. Hearing and vision were normal though, and again there were increased liver enzymes and lactate. Now here again this female had a presentation almost of a Lee syndrome. However, here we found a homozygous mutation in MP17 related mitochondrial depletion syndrome type 6. The third child was a 13-month male, consanguineous, normal growth, again only motor delay, normal speech and cognition, and there was already regression happening starting from 10 months of age with white matter periventricular cystic changes and the rest of the no nerve involvement. Now here I would like to highlight that, in the first case there was no MRI changes that were yet visible. However, in the next 2 cases, there was leukodystrophy, basal ganglia lesions, there were MRI changes, and there was neuroregression already happening. We could see the temporal association here of the MRI abnormalities that is very typical in a mitochondrial disorder. So we saw the spatial distribution, and now we are seeing the temporal association of the MRI abnormalities. There was no clear-cut association with the gene that was identified for the specific mitochondrial condition. Most of these children were presenting with only motor delays with relative preservation of the speech and cognition. Some of them regressed, some of them did not regress. However, like in IBA 57 type of mitochondrial dysfunction syndrome, neuroregression has not been reported very frequently. So, there was not much correlation with the previously reported cases. However, we could see a pattern of the phenotype that we were seeing in all patients of these nuclear mitochondrial disorders, and this was sort of helping us phenotyping them and suspecting them and making clinical SOPs for us for suspecting the mitochondrial disorders clearly. The fourth patient was a 1-year-old male and a very severely affected child with very poor growth, severe feeding problems, developed symptoms right at birth. So he had fetal distress that was diagnosed towards the end of pregnancy, and then had seizures and respiratory distress on day 1 of life, has severe global developmental delay, severe feeding problems, was also had bilateral undescended testes and hypotonia. There was no regression, there was no improvement literally in this child for the past 1 year. In the MRI, there were severe hypoxic changes with involvement of the deep gray nuclei and white matter, and essentially severe cortical and cerebellar atrophy with atrophy of the basal ganglia, as well as thinning of the optic nerves. And there was severe profound hearing loss and thinning of the optic nerves. And here again the slide is sort of getting hidden, but there was a history in the mother of hearing loss. So the child here, in this case, we found a mitochondrial mutation in the MTTL1 gene, the typical mutation associated with the MELAs, and which there was the heteroplasmy level was at about 63.9%, which is at a higher level, and the mother also had the same variant, and the mother had hearing loss. Without any other clinical symptoms. Now, this was a very atypical case of MELAs because such early presentation right from the time of birth has been very rarely seen. We found just one more case in literature where at birth presentation of this kind of MTTL1 gene has been reported before. The last case was a 3.5-year-old male consanguineous couple, and we found a homozygous variation in the NDUFE1 gene, which is the commonest mitochondrial complex 1 deficiency, and a very typical presentation for mitochondrial complex 1 deficiency. The child was doing well till 7 months of age and then had motor regression. Speech and cognition had been normal, and then no improvement after the regression had started. And again, severe, extensive, symmetrical white matter hyperintensities. So all that we could gather here was from the clinical phenotyping that all these disorders were presenting with predominant motor symptoms, regression temporally, maybe in early childhood. We could see a temporal and a spatial distribution of the MRI brain changes, and we did not find a lot of correlation between the gene and the phenotype typically. So the mitochondrial complex deficiencies, there were overlapping symptoms with the mitochondrial depletion syndrome and so far and so forth. So this is what I had to present today. Thank you.
Thank you very much. Very nice presentation. Are there any questions from the audience? Bert, what about you?
Dr. Chaitanya.
There's a question? Next speaker. Okay.
Seeing the spectrum, so how do you see the response to the mitochondrial medications, and are we considering it in all the patients?
Yes, we do give the mitochondrial cocktail regimen in all the children. However, except for in the primary mitochondrial disorders, we have seen that the response has not been, very good. However, in some of the vitamin responsive secondary mitochondrial disorders, the response is good, like the thymine responsive and the riboflavin transporter. They are not exactly the mitochondrial disorders, but in those conditions, the response to these vitamins is very good.
Can I ask you one question, please? You showed us 4 nuclear and 1 mitochondrial DNA disorder. I might have missed it, but did you tell us the level of heteroplasmy for the mitochondrial variant between the mother and the child?
So, yes, so the level of the heteroplasmy in the child was 63.9%, and in the mother it was about 73. And the mother, it's very unusual. And the mother had just the hearing loss.
What tissue?
It was blood. It was blood. So that is the thing.
Okay, if there are no more questions, thank you very much.
Thank you.
Again.
Thank you, ma'am, for sharing these recent advances and knowledge with us. A note of appreciation for all our seated dignitaries and delegates for the presence and patience. Now I would call upon Dr. Amrit Tuteja to please felicitate Dr. Divya Agrawal. Now moving forward, now I would like to call upon our next speaker, Dr. Chaitanya Dattar, Associate Consultant, Clinical Genetics, King Edward Memorial, KEM Hospital, Pune, to speak on a topic, rare disease diagnosis and management in a genomic era.
Very good afternoon. At the outset, let me thank the organizers for this opportunity. So today I'll be speaking on management of metabolic disorders in the genomic era. So Dr. Divya just took you through some case vignettes related to mitochondriopathies. So I'll be covering other IEMs as well. So essentially, we know that there is typicality. This is the other of my passion. I do birding. And you sometimes get a few things which are a little odd than otherwise. But we call them atypical and not abnormal. So this parrot is feeding quite well despite having that deformity. So since it was a bird defects conference, I thought I'll just show this. But despite everything, the bird is thriving quite well. So we get a lot of variation in the population as regards to IEMs as well. So just take 3 case examples wherein the first born of 3rd degree consanguinity was well for 2-3 days and suddenly collapsed, and the diagnosis was citrullinemia. The second case, it's a non-consanguineous parents, no perinatal issues. The baby was doing well initially, but at once there was some intercurrent illness, after which the baby developed an acute encephalopathy, admitted, but improved. Again, the diagnosis is citrullinemia. And the third case, a 3rd degree consanguineous lady, she was absolutely well, normal growth, development, married, developed postpartum psychosis. At that time, hyperammonemia was documented, and again it turned out to be a case of citrullinemia. So you can see the spectrum wherein you have these IEMs presenting. Though we have these typical markers or the clues to pick up IEMs, but things are expanding. Dr. Shruti also showed you various case examples wherein atypical presentations of IEMs are known. So acutely ill child, any seizures, any irritability, posturing, or you have tone abnormalities, unexplained sensorium related altered sensorium, or anything which is intractable. It can be intractable acidosis, hypoglycemia. We must suspect an IEM. So any unexplained physical or intellectual delay, failure to thrive, or also other clues, even scholastic backwardness, to pick up an IEM. And we know from this paper that essentially the spectrum also enters into adulthood, and a condition as simple as treatable as biotinidase deficiency can present with bilateral optic atrophy, spastic paraparesis in the later stage also. Similarly, we know that non-ketotic hyperglycemia has a presentation like autism in childhood. So the spectrum is expanding, so the suspicion should be quite high. And now we know that essentially just for the beginners that the metabolic issues occur when there's a deficiency of an enzyme and the substrate is not converted into the product, and that enzyme is encoded by the gene. So all metabolic disorders are genetic disorders, and now we are in the era of multiomics, wherein we need to look at the pathway in entirety to really reach conclusive diagnosis. But in the Indian scenario, things are a little tricky, wherein some of the cases, people would just prefer to label on the clinical presentation that there is a hyperammonemia, label it as a urea cycle defect. While others in the NICU, they would directly send an exome sequencing and then land up with certain VOUS, which you really cannot interpret. So whether we tilt on which side, whether metabolic side, genomic side, is a tricky question, but we need to balance both and really achieve good outcomes. So there are significant dilemmas and difficulties in IEM diagnosis, as we know. The variable presentation in neonatal periods to infancy, late onset presentations are known. They mimic common conditions like sepsis, encephalopathy, toxicity. So here most of the cases in the initial stages, the IEMs are suspected as sepsis is the commonest diagnosis before they really suspect an IEM. Biochemical presentation may not be too typical in most of the cases. Then earlier it was non-availability of metabolic testing services, but now things have improved significantly. Most of the other issues that occur in our scenario is the distortion of the metabolic profile. Most of the times the treatment is given and then the sample is sent for a tandem mass or a LC-MS and a GC-MS by the time wherein the metabolites would have normalized. And sometimes high mortality does not allow the completion of the workup. So essentially, just to take you through some simple case vignettes that we come across. There's a preterm neonate with hypoglycemia and a mild hepatomegaly. The galactose is elevated and the galt is 0.5 units per gram HB. So do we call this as a case of galactosemia? So sometimes, yes, if it could be a classical galactosemia if you find a compound heterozygous mutations in these particular, but also you can have this biochemical Duarte variant sometimes which can present. So essentially, when we know that if it's a classical galactosemia, you need to give a more strict dietary management, while those with a Duarte variant or biochemical galactosemia, they require lesser restrictions and they have no major complication generally. So similarly, there's a case of third-degree consanguinity, a 1-year-old child with a developmental delay, motor more than mental, and has a poor head control and truncal tone. He's very, very tremulous, and you can see a hypopigmented child. Now, obviously, you find the TMS value that shows a phenylalanine which is elevated. So obviously, the level is 1360, which goes in the PKU range generally. But when you're doing a genetic evaluation, we know that we have a PKU and a non-PKU hyperphenylalaninemia which can also present. So essentially, we know the PKU will present with a more severe phenotype with delayed developmental intellectual impairment. As compared to that, the non-PKU HPAs could be more amenable to treatment and they present more like a movement disorder, tremulousness, ataxia, etc. So this turned out to be a PTS the deficiency and this was very much well treated. Just that once we started the child, there was significant, we restricted the phenylalanine, we started DOPA, and it was a BH4 responsive, and therefore the child could achieve milestones and now goes to school and is absolutely well. So what we find is that though phenylalanine was very much in the range of a PKU, it turned out to be a very well treated condition. This is one of the common disorders that we find in this particular region, and we had significant issues in diagnosing the case, and finally after 3 or 4 years we could diagnose based on genetics. This was a case of ketotic hypoglycemia. He used to have one episode every year. When this child used to go on a vacation somewhere, he used to have these episodes and hypoglycemia, vomiting, and he used to have altered sensorium. And at each time, all the metabolic workup would turn out to be normal. And one fine day, when genetics became available, we could identify that this was a case of fructose 1,6-bisphosphatase deficiency, a very well-treated condition, after which the child did not have any further symptoms. So essentially, identifying the genetic cause of a metabolic condition helps in proper management. But sometimes you can have, even on a metabolic management, you can identify this. The child on the left is a case of behavioral issues, hyperactivity, dislocated lenses. While on the other hand, we have a neonate who was well till day of life 3, developed severe apnea, severe respiratory distress, became extremely floppy, and urine showed a raised homocysteine and blood showed a hyperhomocystinemia. So both cases were raised homocysteine, but we know the difference lies that the one with the CBS gene is a classical homocystinuria, while that in the MTHFR gene is a MTHFR deficiency. We have significant number of cases with MTHFR deficiency which are diagnosed. So a low methionine versus a high methionine diet is, so in MTHFR you have to give low methionine, while the methionine is low, while the CBS deficiency, the methionine is elevated. So methionine restriction is the key in the classical homocystinuria. But sometimes things can present a little differently, the IEMs. As such, this particular child, both babies were full term, cesarean section delivery, good birth weight babies, both did not cry at birth, and the first baby was not investigated. When the second baby was born, was shifted to the NICU and showed classical hypoxic ischemic changes in the brain. And of course, obviously, in the Indian scenario, most of the times it is thought that there were some delivery complication, and as a result, this HI would have happened. But it turned out to be an MTHFR hyperhomocystinemia due to MTHFR deficiency. So picking up these cases and clues help us in reaching a diagnosis. Similarly, those with seizures. Now, the child is well till day of life 3. Now, this child was admitted with an abnormal EEG, was given a trial of pyridoxine in the ICU because the EEG was very, very chaotic, and responded fantastically to medications, and the child was doing well. So obviously, do we label it as a pyridoxine responsive seizures or not is always the question, and whether to stop pyridoxine or not is the other one. So obviously, we could did a urine pipecolic and alpha assay could not be considered. So the question was whether to continue or discontinue pyridoxine. Obviously, if the mutations are identified in the common genes, the LDH7A1 or PNPO, we would continue lifelong pyridoxine. But if no other genetic cause is identified, possibly you can taper off pyridoxine and continue antiepileptics as indicated based on the clinical profile. So having a genetic diagnosis helps us in taking proper medical decisions in these scenarios as well. Similarly, as we saw earlier, the glutaric acidemia type 2, this is glutaric acidemia type 1. So we know that all children with unexplained macrocephaly should be worked up with this. Now, this child did not show any pathognomonic metabolites related to GA1. Obviously, on TMS or GCMS, you would find classical metabolites. But there was a GCDH gene homozygous likely pathogenic variation which was identified in the GCDH gene pertaining to glutaric acidemia type 1. So this was a low excretor phenotype which could be picked up on genetics only. And we know that this particular condition should not be missed, because even if you, in a single acute crisis can be really debilitating. So in these cases also, genetic diagnosis helped us in a proper metabolic management. Now I take you to this family. When it's a consanguineous family, the first child had severe intellectual disability. At 9 years, you can observe that there is dysmorphism. He had no speech. He had abnormal tone, brisk reflexes, clumsy gait, a very, very happy demeanor, a profound intellectual disability with autism features. The mother was concerned for the second child, who also presented with a global delay. There was no speech had developed. There was increased tone, and the child was extremely tremulous, and the AV responses too were quite inconsistent. Obviously, you can appreciate the child also is significantly hypopigmented and sparse hair. So we did a genetic study in this patient, and we found that there was a BCKDK homozygous exonic deletion from exon 3 to 9 in the BCKDA gene, and this is postulated as one of the treatable causes of intellectual disability and autism.
So obviously here it's the reverse of an MSUD, wherein you have elevated branch chain amino acid. In this particular condition, this is one of the rate limiting steps there, and that causes a reduction in the branch chain amino acids. So, and on search of literature, what was found that lower BCAA levels also quite deleterious for brain development. So as our high levels, similarly the low levels are also quite deleterious for brain development, and certain knockout mice were provided with a BCAA enriched diet, and these mice did show improvement. So just based on that particular hypothesis, we did the testing on the blood and CSF, and we did find that the levels of the branch chain amino acids were low. Now in the Indian context, now we have these amino acids freely available by certain companies here. So we could start the child on leucine, isoleucine, valine at a good amount of dose which we calculated based on the available guidelines. And within a few months, after with physiotherapy as well, the child started walking. There was reduced tremulousness in about 3 months' time. The social responses had improved. The child started smiling purposefully. They started saying bisyllables in about 4-5 months' time. There was reduced irritability, and the hair pigmentation also improved. Though the child is not completely typical and normal at this stage, but the mother is, there were significant gains after starting this supplementation and putting him on a special diet. So this shows the importance of a proper diagnosis and, considering these, measures wherever the therapies are available. Sometimes things can trick you a little bit. Now this child, non-consanguineous, has a developmental delay, speech delay with dystonia, very clumsy, with reduced attention span. The MRI brain did suggest that there was iron deposition in the brain and the deep nuclei. So it was suspected to be an NBI spectrum. And when an exome was done initially, it showed a VOUS in the IFIH1 gene, and it was a heterozygous variant which was not really clinically matching. The child did not regress, but rather improved. So this was a little tricky as to why the child improved. Again, the repeat MRI brain did show a similar feature as in NBI, which was shown earlier, but there was no increase in the signals. The child was lost to follow-up, and after 2 years, we did a data reanalysis and found that there was a deficient, that there was a mutation which was there in the FUCA1 gene, a likely pathogenic variant which was identified. And further, we did a functional analysis by enzyme studies, and that did show a deficient fucosidase enzyme. So this was a case of fucosidosis, and the X-rays gradually did reveal the features of dysostiosis multiplex, though it was quite mild. So obviously there are atypical features or atypical presentation of fucosidosis that we now know, and obviously a bone marrow transplant, HSCT, can be considered in this particular child, especially the mildly symptomatic cases. This child underwent an HSCT, is now doing well. So essentially proper initial, even though there is some variant which is identified, we need to follow up these cases over time and possibly do a data reanalysis to really reach some conclusive diagnosis. Now this particular family was a consanguineous family. First child had died. It was a delayed cry at birth with excessive sleepiness, global delay. The MRI brain was normal. And the second babies, there were 2 twins who were born. They were normal. That was from a donor gamete conception. The third pregnancy, they followed up in the US. Essentially, they had done an NIPT. No genetic studies were carried out. NIPT was screened to be normal. Again, this baby presented at 1.5 months with apparently well till 1.5 months, but started having seizures with upgaze, and thereafter showed global developmental delay by 3.5 months. Again, the brain MRI was normal, and the exome sequencing reported this SLC18A2 gene, homozygous mutation, which at that point was not really given a particular phenotype, but later 2 years down the line, it caused the brain dopamine serotonin vesicular transport defect, which was identified. And obviously the marker available was serotonin, which was considered. So it was low. So obviously it is a diagnostic marker. So obviously now in this particular patient, this child includes, the symptoms include oculogyric crisis, Parkinsonism-like features, facial dyskinesias, ptosis, etc. And management is by giving pramipexole. But obviously despite all these measures, the child could not survive and succumbed at 3 years during an intercurrent illness. So obviously sometimes ending the diagnostic ODC helps the families to pursue further reproductive options as they would want to. Now, this was one of the antenatal case related to a structural abnormality. There was first pregnancy, the child is normal. The second pregnancy was discontinued at 19 weeks after the anomaly scan, as it showed absent corpus callosum. Again, the same thing recurred in the next pregnancy, that is the third pregnancy. So a fetal MRI was done, which showed agenesis of corpus callosum. So obviously we know that there is a whole big list of genetic conditions which can be associated with agenesis of corpus callosum. Initially, microarray was done which was normal, and a whole exome was considered, and that showed a glycine, the AMT gene homozygous pathogenic variation, so which related to glycine encephalopathy. So a metabolic condition presenting with a structural brain abnormality in the antenatal period. So now we know that the risk of recurrence for the future conceptions of the couple is going to be 25%. So similarly, now again, I'll show you this particular little adult case herein. So this child had a normal, individual had a normal development, born of a consanguineous family, had 1 to 2 episodes of vomiting every month from 14 years of age. And at 17, and he required a couple of admissions for, and the child used to fall unconscious suddenly. So had vomiting, unconscious, had to be brought to Pune in a cardiac ambulance as well. Otherwise, the child is normal in between the episode. So he has had at least two episodes such as this, almost near critical episode. Only one TMS did show a raised citrulline at that time, but there was no particular diagnosis available. When an exome evaluation was done, that showed a DLD gene mutation, a homozygous pathogenic mutation in the DLD gene, which would present in this particular manner. So obviously, this is the individual. We started management. We told them how to manage the critical episode. A prompt symptomatic management was suggested. Avoidance of dietary triggers and stress triggers was suggested. We started him on carnitine, coenzyme Q, alpha lipoic acid, and multivitamins. And since then, the child, the significant reduction in this episodes of vomiting and all is noted. Obviously, there's again, in this particular case, there's no consanguinity, no antenatal perinatal concerns. The child had developed walking by around 1 year, speech by around 1 year, was going to school, was well till 3.5 years of age, and obviously then started toe walking, frequent falls, and poor control while running. There was increased weakness. So usually in the periods of illnesses, she used to get weak and she used to stop walking. So there were no obvious seizures, and we could see the bilateral symmetric cavitatory signals, in the corpus striatum and the medial thalami there. And obviously this turned out to be NDUF FAF5 mitochondrial complex 1 compound heterozygous variations. One was pathogenic, the other was likely pathogenic variant. Obviously, once we started the mitochondrial medications, there was significant improvement in tone, power, the speech improved, the activity was better, and there was no regression which was noted now almost since the past 1 year or so. So considering mitochondrial medications in selected cases possibly helps in keeping stability, but at the same time, proper therapies and all these things are quite crucial. So similarly, a 3rd-degree consanguinity, there was one sibling death. This child achieved walking a little delayed at around 17 months. Again, the child had frequent vomiting, fever, infections, and recurrent PICU admissions. And then the child started had a failure to thrive. Obviously, MRI brain showed Lee-like changes there. And when we did the testing, it was found to be a SERAC1 gene homozygous pathogenic mutation which pertains to 3-methylglutaconic aciduria with deafness encephalopathy with Lee-like syndrome. Again, we explained the emergency management. We could give a proper dietary therapy for this patient and gave supportive mitochondrial medication. Now, in the last 2 years, this child did not have any major intercurrent illness, has a good weight gain. There was improvement in liver parameters, and brain MRI has not shown any additional changes there. So obviously, the child has hearing impairment and is using hearing aids. So the management potential of these mitochondrial medications we can say it's still uncertain, but yes, it can lead to some stabilization is what we find from these cases. Obviously, proper diet, nutrition, and rehabilitation is also the key. Then you're getting a lot of these cases with diarrhea spectrum, unexplained diarrhea is presenting. So again, a 3rd-degree consanguinity, one sibling death with diarrhea at around 10 months of age. Now this child is presented at 8 to 9 months of age with severe loose stools, with a motor delay, failure to thrive, with a mild hepatomegaly. Otherwise, the immunological workup was normal. The reducing substances were 1+, and therefore, they stopped lactose and all. And it turned out to be a congenital sucrase isomaltase deficiency, a likely pathogenic variant which was identified. Obviously, at 20 months, this child still has a little lower on weight, 9 kilos, but now stands. He started walking with support. There was the organomegaly has regressed, no loose stools, normal cognition. And obviously, we know that once the child is supported in the pediatric age group, this condition will improve with age, and the tolerance to these foods are also going to improve. So it is very critical to manage the initial stage. But not all things are quite rosy in our practice here, because again, a third-degree consanguinity, this particular child has severe failure to thrive with abdominal distension, no organomegaly, and a speech delay. TMS GCMS was normal, but a homozygous reported pathogenic variant was identified in the PCCA gene. Now, this child had never had a presentation like a propionic acidemia. Again, the father was found to be homozygous for the same variation. So the debate whether to do a metabolic or genetic first, we see a lot of such cases wherein a lot of variants which are likely pathogenic or pathogenic are found to be possibly benign in our population. So whether we really rely, whether it's like being a reported variation. Just my last few slides. Now, this particular child, the older child, is a known case of a VLCAT deficiency under my treatment. The second baby died in the neonatal stage, possibly because of recurrence of a VLCAT. The third pregnancy, they came to us, and the fetus was found to be affected with a VLCAT deficiency. Obviously, the parents were very insistent on continuing with the pregnancy. So we started the mother on carnitine and an MCT-based diet, obviously from 22 weeks onwards. And when the baby was born, they did show a biochemical derangement, but the child is now doing absolutely well. Now is almost 3 years of age and has not shown any major symptoms. So overall, perinatal management in certain IEM cases are also what we are now targeting. So proper counseling during the antenatal period is crucial. Now this case is my last one, wherein this is a case of a child presented at 4 years, was absolutely in a vegetative state, could not move, and the father was like, we had diagnosed the condition it to be a methylmalonic acid, that is a cobalamin metabolism defect. And we told them that there could be limitations in managing the child, but obviously the parents were very much interested in considering or pursuing management. They started a proper medications, diet and therapy. Now the child is going to a special school. Though she has limitations, she can do many activities on her own. So that she can eat by herself, she can inform about toilets. So many things have improved after starting medications. So genetic metabolic, so just in summarize, genetic metabolic investigations are not exclusive, they must complement each other. Obviously, a molecular diagnosis is must, even if an IEM is suspected, even if the metabolic workup is apparently normal, and a genetic diagnosis is crucial for prognostication, change of management, and for prenatal diagnosis. Thank you so much.
Very informative and excellent presentation, sir. I have a question. I want to know how is your experience on outcome of hyperammonemia if we are able to diagnose in neonatal period?
See, hyperammonemia, first thing we have to first identify the cause for that. So what we get is a transient hyperammonemia in the newborn period is quite common. So generally, any symptomatic neonate, you have to check the level of ammonia. If it is beyond 150, then you have to treat these children. So generally, if they are asymptomatic at that stage, you can ignore that hyperammonemia. So any symptomatic neonate and the ammonia is beyond 150, you would tend to treat. And then obviously you're just checking the ammonia, and you can start benzoate if required. Obviously you're going to send the basic metabolic workup, that is your blood gas, tandem mass and GCMS, to pick up any common IEMs as such.
Yeah, symptomatic at diagnosis, then they do well, or?
Yes, see, sometimes transient hyperammonemia of newborn period also comes with the child is a little drowsy, not crying well, not very active. And this improves by itself. You don't need any treatment. But generally, if the child is symptomatic, you have to treat that with sodium benzoate, and if required, arginine you can add. But obviously, you should aim for a metabolic and, if required, a genetic diagnosis.
Thank you. That was really fascinating.
Thank you.
Can you tell, I'm sorry if I missed it, but can you tell us how you're accessing this testing? Are you doing panels or individual genes, or are you doing exome genome?
For the, for most of the cases, we are doing whole exome sequencing, usually as a solo, because the thing is that in our country, the finances or resources is a big issue. So generally, we do a good phenotyping with a solo exome evaluation. Only in very certain scenarios where we are not able to reach a conclusion, we go for a trio analysis. But it would be generally a whole exome based evaluation with a good phenotyping.
Thank you.
Thanks.
Thank you, sir, for this valuable information. Now, we'd like to call upon Dr. Abhijit Dixit to please felicitate Dr. Chaitanya Dattar. Thank you all the seated chairpersons for their valuable time and teaching us to question the known diagnosis and seek the missing elements and empowering our management protocols in this new genomic era. I would like to call upon Dr. Saurabh Singh to please felicitate Dr. Abhijit Dixit, sir. I would like to call upon Dr. Sanjay Khatri to please felicitate Dr. Kristen Kushe. I would like to call upon Dr. Nikita Pal to please come on the stage and felicitate Dr. Amrit Tuteja. As said by Mahatma Gandhi, the father of a nation, live as if you were to die tomorrow, learn as if you were to live forever. With this note, we move forward to our next schedule. I would like to call upon the next speakers, next chairpersons for the sessions. Dr. Sanjay Khatri, Associate Professor, Department of Pediatric Cardiology, Mahatma Gandhi Hospital, Jaipur. Dr. Saurabh Singh, Associate Professor, Department of Neurology, Mahatma Gandhi Hospital, Jaipur. Dr. Helen Stewart, Department of Clinical Genetics, Oxford University Hospital, United Kingdom. Dr. Chandradeep Mastan, Assistant Professor, JLN Medical College, Ajmer. Dr. Helen Stewart. Proceeding with this session, I am honored to call upon our next speaker, Dr. Chaya Prasad, Clinical Director, ASHA Child Care and Developmental Center, Chandigarh, to talk on a very rare topic, understanding intellectual abilities in children with rare genetic diseases.
ICBD. This one.
Good afternoon, everybody. And with the permission of our chairpersons, I begin with my talk. Thank you to the organizers for having me here. It's been a real pleasure learning with you all. And without taking any further time, the topic allotted was understanding intellectual abilities in children with birth defects and genetic disorders. So I'm really happy to be speaking on these because it's been 18 years that I have been working with children with all kind of intellectual disabilities and developmental disorders. And I was really blessed to watch these children who were labeled with all kind of problems and intellectual disabilities. I was happy that as we begin working with them, we could see those changes, and these children were able to get integrated back into the schools and into the societies. And that's why I'm really happy speaking about this today, and I will be sharing some cases at the end of it. As we all know that mental retardation terminology is really out, and intellectual disabilities is the term that is used, and it includes intellectual disability, global development, as well as unspecified intellectual disability. So two different diagnostic terms. I was thinking there'll be a lot of students, and hence I had put some basics into this, that general pediatricians and doctors should know how to differentiate intellectual disability from global developmental delay, and intellectual disability diagnosis should only be made when the mental abilities and the adaptive functioning are significantly below average, and developmental delay, of course, is another reserved term. And whenever we are doing IQ assessment for children, we must take into account that these children may not be ready for the assessment, and they may be having a good intellectual potential, but maybe they are not ready for the assessment, and hence we should call the parents again and get the reassessments done after the therapeutic interventions are done, which I'll be talking about it shortly as well. So just to bring a few things here, that India is a country with a huge population of persons with disabilities, and as per the NSSO report, we can see there are more than 2 crores people with disability, and if we really look into it, for children below the age of 6 years with disabilities, that number is huge as well. And as the RBSK has given the list of various disabilities, birth defects, and intellectual impairments that they include under their list, there is a huge list, and most of them are also enlisted in the Persons with Disability, Rights of Persons with Disability Act, which has been revised in 2016. So understanding the challenges and the assessments and interventions for these kids, first of all, there is definitely a dearth of experts across the country, because as we see, developmental pediatricians or doctors themselves are not doing the IQ assessments, and there are psychologists, they are very good psychologists, but then nowadays there are a lot of other developmental experts and other people who are also carrying out these intellectual assessments. So it's not always a very good idea that anybody can carry out intellectual and developmental assessments for children. Definitely there should be highly experienced, trained people who can understand in depth the problems that the child is facing and how to carry out these assessments, when to carry out these assessments. And as I said yesterday also, that until and unless a doctor or whoever the developmental expert is does not have a good passion to work with children, only science is not going to help. So it has to be a combination of science and empathy and compassion and the pure intention to help the child and the family, and only then we can understand what are the intellectual abilities of these children. In the last 18 years that I've been working with these children, I have seen that even if they are not able to talk, if they are quiet, they do understand whether the person in front of them is there to help them, is there to help them learn more, or is just, whiling away time with them. So they are actually quite intelligent beings, and it's only us humans who have developed our own certain ways of understanding the intellectual abilities. So just a few lines, that I have taken from a book, that children are born as creatures with a spirit of inquisitiveness. We all know they like to ask so many questions and they like to learn so much, and they have a certain intuition, and they keep on learning as they are growing, as per their intuition, as per their environmental awareness, as per their experiential awareness. And with this kind of sense and with their play behaviors and the play activities they are doing, their intellectual abilities are improving on a daily basis. And much of this information, the intellectual information, they actually gather from their home environment before they actually venture out into the second environment or the home environment or into the creches. And it's very important to note over here that whether it is a child with intellectual disability or a child who is growing typically, with the experiments with the experiences that they are looking forward to on a daily basis, and with repeated practices, they learn a lot. And that's why during the therapies, we focus a lot on these children learning how to imitate what the therapists or the parents are doing, because imitation is something that helps build the intellectual abilities a lot. So a few words about the neuronal plasticity, and you all know that the initial few years are very important, and the ages between 6 months till 3.5 years, the number of neurons are increasing from a few thousands to a few million and billion, and the brain has a very magical ability that it kind of starts pruning itself after the age of 3.5, 4 years, and it says that, whatever I've learned, whatever neurons are used on a daily basis, I'm going to retain them, and whatever is not used, whatever the child or the brain is not using, they're going to remove it. It's like a natural computer, and children have a good ability to learn 2 languages, good ability to build at least 80% of their intelligence in the first 2 years. And this early plasticity is actually helping the baby to develop the brain and learn so many things from its experience and from its environment. And coming to this thing, we know that all of the child's developmental trajectory is, getting impacted with a lot of factors, not only the genetic factors, but the epigenetic play that comes into role now. A lot of chemicals and environmental toxins and psychosocial stressors, everything is playing a part on the developmental trajectory, which may cause little setbacks into the child's life, and they may keep on changing the developmental trajectories, and it keeps on increasing the risk of cognitive deficits, where the child, by the time the child reaches the main school, and the teacher and the parents may realize that this child who appeared very bright in the early childhood period is not able to learn as much as probably he should, and is having scholastic difficulties and educational problem. So looking over here, we know that humans were not really born to read and write. That was not the intention, of humans being created. But if we see over here, humans are the only ones who have the ability to make this pincer grasp and to have a good approximation of the thumb pad with the index finger, and that's how children learn a lot of activities. But what is happening nowadays with the use of digital devices and a lot of scrolling, using a lot of index finger right from the beginning, this is also causing a change in the way the child is building up their intellectual abilities. So I would not really say that it is damaging. It is damaging to some extent, but yes, it is bringing about a change, definitely. So this was a life cycle approach to child development, which was given by Professor M.K. Nair, sir. And he said that this is a philosophy that encompasses all of the actions, beginning from the future motherhood, joyful pregnancy, safe delivery, optimal growth and development, and responsible parenthood. And one word I have put into it is also joyful parenthood, because if children are not learning to use their intellectual abilities for their day-to-day abilities, it's a burden on the parents, and the parents do not know, they do not have the knowledge and the expertise to manage these children. So, few words about what actually is intellectual ability. So I always tell parents, intelligence is not what the child will go into the classroom, A, B, C, D, 1, 2, 3, he will learn all those things and come and learn the rhymes and just put it forth in front of everybody. That is not what intelligence is, that is only a rote memory. But what it constitutes is the reasoning, the problem-solving skills, the ability to do planning, organization, the judgment of its environment, and a good experiential and environmental learning, and also how to take care of themselves, the self-care, the social participation with the family, and carrying out the activities of daily living. So whenever we do IQ assessment, so the number alone is not enough. We must mention in the diagnosis the intellectual quotient along with the adaptive ability that the child has. So it's not just that IQ number. But what actually intelligence constitutes and how it is built. It is built from the beginning with the self-regulation abilities. And what are the self-regulation abilities? These self-regulation abilities are something that the child is learning to regulate all of its behaviors, the emotions, and the activities as per the requirement of the self and as requirement of the environment. And very important thing to remember is that early childhood self-regulation actually is the early life marker for later life successes, not only in the academics, but also helps in improving the resiliency power for later on challenges. So exposure to stress and trauma in the early childhood period, it often results in the ability to regulate these skills. Another thing that impacts the child to use his intelligence, to use the intellectual ability in the early childhood period is the sleep. We have so many children with autism, with sleep disorders, and then we have children with autism with no sleep disorder, and we see that these are the children who have the sleep disorders, that they are not able to learn from their environment, they are not able to learn well in the therapeutic sessions, and until and unless we put the sleep patterns correct, either by medications or by the changes in the lifestyle, then only then the child will be learning better. And it also helps in the school transitions or intervention or transition to any other phase. So sleep is very important, language development is very important. The next important thing for a child to be able to use intellectual abilities is vision. We all have been speaking about it, that how the birth defects, they may impair the vision, but it's very important, how do we pick up these children? They don't have dysmorphic features, they don't have any metabolic disorders, and nobody has checked them, but they are only having difficulties, maybe with reading, writing skills, or maybe they are bumping into objects around them, they're getting hurt again and again. So it's very important to understand and remember what are the signs of poor vision in children, and also be able to detect them early. Children with disability are at a higher risk for visual impairment, and primary visual disorders such as the retinal dystrophies and structural eye abnormalities must be ruled out. We have so many children with all kind of developmental disorders who may be having a poor visual acuity or strabismus and all these things. So, cerebral visual impairment is so common in children nowadays, and it's very important that we look into it and get it ruled out. We have a lot of examples of children at our center, even when detected at the age of 7 years or 8 years, were able to do so much better with the therapeutic interventions. So it's not necessary that CVI gets detected very early at the age of maybe a year or 2 years. And I would like to just share a case over here that the COVID pandemic had just started, and Down, I think 3 or 4 months, her mother calls me from the village, far-off village in Punjab, and she says that I have a 4-month-old baby and my baby has developed autism. And I said, how were you able to diagnose autism at 4 months? So she said that the baby does not look at me and does not smile at me. And then we had to call the family. They had to take some special permission to come to us. And when we got all the investigations done, we realized that this was a baby who was having cerebral visual impairment as well as hearing impairment. And that's the reason the child was not able to look at mother and smile. So coming to executive functions, very important for the developmental of intellectual ability for children, how to use their cognitive flexibility, the working memory. If I had time, maybe I could explain all of these things, but because of shortness of time, I will not be going into too much details of the cognitive functions, but it's very important to understand that executive functions, even if the child is deficit or delayed in these, every child can be trained to do better with their executive functions on a daily basis, and it can definitely be improving to help the child's day-to-day living. The importance of social, emotional, physical health for cognitive health is emphasized over and over again because, as I already mentioned, stress, lack of sleep, lack of exercise, all of these can impair the executive functions in children, especially who have developmental delays and are really not moving much in a well-coordinated manner. We can always improve the social behaviors and adaptive functioning of the children. It's very important for the child to have a good attention span. If the children are not doing well with their attentional skills, whatever therapeutic interventions we may be doing, we may be having the best of therapists, but if the child has not been able to build a good attention span, will not be able to learn much. So again, planning and organization skills. And okay, so few words that how do we help children to improve the organization skills? This is important, and at our center, we are telling these parents on a daily basis, help children to fix their routine, day-to-day routine, break the larger task into smaller ones so that they are able to learn better, perform better. Practice makes a man perfect stands true even today. Help children to think before they act, to think before they talk, and to think before they respond to a certain situation. Again, attention, listening, receptive language, all of these, but most of all, play is very, very important for children to build their intellectual abilities. So never stop children from playing, but even play, it should not be an informal play all the time. There has to be a time fixed for play, and somebody should be supervising and also assisting the child and also supervising the child on how the child is playing. So these are the executive functions which are actually the life skills for children that help them with their intellectual abilities and also needed for their academic behaviors. Disability ethics is very important. Parents are the key element in interventions, not only because they spend most of the time with the child, but because well-informed and supportive environment will warrant a better prognosis. Always use evidence-based models for children. There are some principles of intervention that will help improve the intellectual abilities in children, and it's important to have some written down short-term goals, long-term goals, and whatever we are doing with the child, because if we are working with the child randomly, that the child is doing and coming and doing anything at the center and going, the child is not going to learn anything. So quickly, in the last 2 minutes, I'm going to talk about these 3 cases that I have. So this was baby Myra, whose date of birth is 2014, Feb 2014, and I had first seen her in August 2017 at the age of 3.5 years. The main concern of the mother was, first was school refusal, and then was frequent urination. And Dr. Arun is here. I remember that we sent this girl abroad. We got so many tests done. We were trying to rule out, urine infection, and we were doing all these kidney-related tests, USG abdomen and everything. while the tests were going on, we had a good look at the child. She was having ptosis. Then we noticed that there were some tongue fasciculations. And on taking the history the second time, the mother informed that she was diagnosed with the Bessett's disease just 3 years ago before this girl was born. And also the mother had 3 episodes of very low sugar in her pregnancy. And it was very important to note over here that she was taking the medicine called colchicine because of her Bessett's disease, and she did not stop it during pregnancy because nobody had told her that you're not supposed to take it during the pregnancy, and she continued to take this. So this was a girl here who had some very mild delays in her motor milestones as well as in her language. And when we did the karyotyping, we got this, the 45XX, der 18, T and 22. And we tried to fit in the patterns, but because I am a developmental pediatrician, I focused more on helping this child to integrate back into the school. This translocation, I mean, you're all geneticists, you might be knowing better about this. So what we did with this girl was, we started with the interventions, and she came to us for nearly 2 years with her interventions. We worked on her visual adaptations. She had difficulty seeing objects and people around her due to ptosis. We worked on that, and it really helped her. The most important discussion that went on was, we have the Prime Institute PGI at Chandigarh, and this girl was listed for surgery for her ptosis. And then the parents wanted to know whether they should go ahead for the surgery for ptosis. And then we had to discuss, and the parents said that, our girl looks really pretty with these drooping eyes, and we don't want her to have those big eyes and get the surgery done, and we don't know if the surgery will be really helping her. So we did a lot of interventions so that her visual, peripheral areas could improve, and they decided not to go in for the surgery at least for the next few years. And we were really happy. This girl, her anxiety went away, her language improved, her reading and writing skills improved, and she was able to go back to school. And there were activities that she enjoyed doing, so we would from time to time help her with those activities, and her language abilities were actually par excellent, better than the other kids in her class, and even her reading, writing abilities and all. And of course, she had some misarticulations, and we continued to work on that. But we were very happy to see that we were able to help this child. The another case that I bring over here is this boy, Ayush, who came to us in July 2017. And the main reason that the parents got him was hyperactivity, and that he doesn't follow anybody's instructions. He doesn't like to read and write. And when we started taking the history and we investigated, and then here what it was, 47XYY. So this child was under our treatment again for, I think, nearly, therapies continued for 18 to 20 months because the family stayed in Himachal. So they came to Chandigarh, stayed, took all the therapies, and then they would visit us every month, and we had to put this child on the medicines for ADHD. He was on methylphenidate for a very long time, but this boy was able to go back to school as well. The one thing that mother enjoyed about seeing this boy was that he utilized all his energy, his hyperactivity and everything in helping the mother to clean the house, so doing the brooming and the dusting. He learned to do it, and he would get a lot of praises from there. So yeah, that's it. And this is another case, another girl who came to us, and again with anxiety, with reading and writing difficulties, and this is what we found on the karyotype. This girl is doing very well. She has been coming to us. She's in 10th now, 10th grade, and she's doing well with her academics, with a little bit of social problems. It's all about parents being able to accept that our children have little difficulties, so parents must learn to adjust with that. It should not always be that the parents should not think that the child should adjust to whatever the parents are saying. So until unless the parents come down at that level, accept what the child has, these kids will continue to have the problem. And this is the last case. This was Summer, who came to us in 2018. And again, the mother was very, very adamant, why doesn't he listen to me? Why is he not studying? Why is he not doing better? And with all of, and of course he had a lot of anxiety and some selective mutism that we had seen. And when we did the karyotyping, this is what we had found, and went in through a lot of counseling and thing, because this child later on showed signs of dyslexia and dysgraphia as well. So let's understand that it's a teamwork to help these children, to help their intellectual abilities. These are all the children who are doing very well, and you know, they may have had language disorders, they may have had delays, but they are all doing very well in life because their parents have accepted and their parents have taken the guidance. This one picture I would like to talk about. This was a Down syndrome program we were having, sports day, and this girl, all of them were supposed to run for the race, but she did not start. We kept telling her, like, the whistle is going on, you have to start. She was not starting. And then I went near her and I asked her what happened. She said, this boy that you can see in the front, in the red sweater, she said he doesn't know how to run, he only walks. So let him go halfway and then I will start running, so that both of us reach at the same time. So, you know, this is the beauty of working with these children. You get to learn so much, although we may be ambitious in our own little ways. So this is the girl over here, this one. I have the pictures over here. She's the one who had ptosis, and she's the one I was talking about, and she improved a lot with the therapy interventions. This one girl I would like to speak about. She's doing excellent. She had been labeled as autism, and everybody had said this child will not be able to do anything, stay at home. Now this girl is doing so well with all the interventions and the lifestyle changes with the parents that followed. She's at the national level of skating now, and she's doing very well, although she doesn't talk really well, but she's able to carry out her day-to-day activities independently. And this girl over here in the yellow shirt, she's the one who had cerebral visual impairment and was very scared of walking. Till the age of 8 years, she had not climbed down the stairs on her own. But with good therapeutic interventions, she was able to jump down the stairs, she was able to play football, and she was able to write better as well. So thank you so much. And thanks to my teachers and mentors, you know, who have helped me to groom myself in this field of developmental pediatrics and work with the children. It's been a very blessing time, and of course to my team as well at my center. Thank you very much.
Thank you very much. That was fantastic. It's lovely to hear how much joy your work obviously brings you. So thank you. Are there any questions from the audience? Bert.
Thank you. Yeah, I also enjoy your enthusiasm. I was wondering, so to some extent, do you think that a clinical diagnosis, a molecular diagnosis is always good because that helps the parents to accept what has been going on? So in what way do you think that it also might contribute to the support you're giving? So do you actually use the molecular clinical syndrome diagnosis in your cases? Might that be more helpful for you, or do you think, okay, for me it doesn't really matter because I look at the child and I see what he or she needs and I focus on that?
So coming to this again, because you know, the investigations are very expensive, and to do all these kind of molecular testings and all, we have to send the families across. There's a lot of waiting. So I do advise the parents, but I tell them that these are their building years. Let's focus on that. So if the child is having too many medical conditions or illnesses, we are blessed to have the PGI Institute in Chandigarh, so we remain in touch with the doctors over here. But yes, as a developmental person, I focus more on building the child's confidence, the intellectual abilities, and I keep the doctors involved, and I tell the parents to visit them, because testing as such, I avoid advising too much of things because they're so expensive, and then parents start thinking that we are not able to get the answers because madam had advised those tests we were not able to do. That's why we are not getting the answers. So over a period of time, I've reduced the number of tests that I get done because I know ultimately children are not going to get that kind of a help, or they will be just stuck wasting their time for all the investigations and all.
Thank you. It's very interesting to hear how you manage patients' expectations.
Yeah.
So thank you. Do people ask you why their children have got developmental problems? And
Yes,
do
all
they,
the time.
And
Yes.
do they ask if it might happen again if they have another baby?
Yes, yes.
Yes.
So these questions are there all the time. And of course, if we have the history in front of us and there are pointers to that, we do explain to them that these might be the reasons. And, but, you know, we also know that there are 30% of cases, you know, around 30% of cases which can be idiopathic intellectual disabilities, you know. So we try to give the confidence to parents that whatever it is, let's work on the child, let's focus on the child and let's work on the child, let's understand. I help the parents to see what are the positives in their children. So it's not always about understanding what the limitations are and helping them only with those limitations. It's more important to understand what are the positives in the child.
Thank you.
Thank you.
Thank you, ma'am, for your wonderful work in this field and teaching us that our little steps can make a big impact in kids with intellectual disability. Now, I would like to call upon Dr. Helen Stewart to please felicitate Dr. Chaya Prasad.
Just to add, ma'am, to answer your question, whenever there is a second baby planned or genetic counseling, we definitely send these children to a genetic counselor, and there, whatever tests required, genetic tests, they are definitely being done.
Forgot to answer your second question.
Yeah.
Yes, thank you. Thank you for that. I'm also having short attention span.
Now, moving onwards, I would like to call upon Dr. Shomsekhar Nimbalkar, Professor and Head, Department of Neurology, Pramukh Swami Medical College, Karamsad, Gujarat, to speak on a topic of role of artificial intelligence in detection of birth defects.
A very good afternoon, or it is good evening. We are about 1 hour late. So thank you to the organizers for the invite, especially Dr. Ashok Gupta, Dr. Dhavendra, and Dr. Vaibhav. So I'll be speaking on role of AI in detection of birth defects, and I hope that I will not overshoot my time. So first disclosure, not an expert, so the questions might be easier or not difficult ones, more of an amateur, but done some work on AI, and I would like to show some work that we did on AI and published it about a few years back. And I got interested in AI mainly because of this girl in the picture. She was a 10th grade school going kid, was interested in Down syndrome, and she had learned AI with Google, and she said she wanted to work on Down syndrome, and we worked together. And we worked on basic images and then published this paper. Then she actually then presented also at a EAP conference where she got the Young Investigator Award for her work on newborn screening for Down syndrome. And so that's where I got interested in kind of AI and have worked on it, and we look forward to see what AI can give us in birth defects. So before we got here, for the last many years, I have been seeing things about how looking at images and you can diagnose kind of various syndromes. So this is one of the most interesting things about being a pediatrician. We tend to be interested in a lot of syndromes, and we want to diagnose them. and generally many of these have facial characteristics, and AI began to become interesting because using image processing, you could kind of diagnose a lot of syndromes. So coming to birth defects, so this came from babies whose photographs are taken after birth, etc., and then it went kind of in utero. So we were looking at what are some basic terms about AI and what do we mean when we talk about AI, and look at an overview of AI in birth defects, a brief primer on gestational age estimation, and where AI is commonly used, which are these four conditions in fetal ultrasonography, fetal echocardiography, finding out which drugs might be teratogenic, and some use of genetics and birth defects. So simply AI speaking, it's basically a computer system which kind of mimics human intelligence, but in today's world it might be something which might be crossing human intelligence. We all, if I ask you a question, how much do you know about yourself? You might say you might know everything, and if I ask you who knows more about you than yourself, you might at the most say your spouse, but currently it's the mobile phone in your pocket which knows more about you as well as your spouse. Okay, so that's how AI has gotten into. So basically, we want to say it mimics human intelligence, but it's gotten more smarter than that. Machine learning is a subset of AI which focuses on learning from various rules of collected data and making inferences. So this initially began with data, then basically turned to image processing, and that's where most of our AI detection for birth defects comes to. And deep learning is an even more subset of machine learning, where using vast amounts of rough data that is collected, we can use it to classify images, detect basic changes in the images away from normal, and you can use image segmentation. So these are kind of terms that we'll see over and over again when we look at image processing. So in the study that we did for Down syndrome, we again used a lot of Down syndrome images for processing, training the model, and using normal data and normal human beings and normal babies and pictures of babies with Down syndrome. And then later on, once the data set was trained, we used pictures of babies who are suspected to be Down syndrome. So that's how it kind of works. There are models, so this is deep learning, and there are various models that can be used. And while these are the three names that you can see here, there are many more models, and many of the things that you see that comes with whatever AI that you see in general use. There are various models that are kind of fine-tuned for some particular work. So this is a convoluted neural network, which is again an artificial neural network, which processes and analyzes medical images. UNET is a subset of a deep learning convoluted neural network used for image segmentation, and a recurrent neural network is something which is used to see the images again and again of like kind of the same event, which is a sequential data, and to see how the data has kind of changed over a series of scans. So these are some of the terms that you will commonly see. So a basic overview in the next slide. So this is the most common places where AI is used in diagnosing birth defects in utero kind of or around that time. So fetal ultrasound analysis can pick up defects, mainly heart defects, brain malformations, and limb issues with higher accuracy than traditional methods. It can be used to look at genetic sequencing for identifying potential genetic mutations associated with birth defects. Again, fetal echocardiography, which can detect birth defects, and this might be missed by human interpretation. So we'll see that in detail basically. And there are also AI models, as I said, where you can use find out whether some drugs, because a lot of us use a lot of drugs. Many of the mothers who have taken drugs may take them inadvertently, and we may not know whether it is teratogenic or not. So AI allows us to guess whether a drug may or may not be teratogenic. So what are the advantages? There is improved accuracy. You can be possibly more accurate. More importantly, you can probably detect earlier than normal at what gestation age that we detect our birth defects. How this becomes important, because if you want to terminate the pregnancy for whatever birth defect you are saying, you have found out, you have got more time on your hand to plan, and also it makes it more equitable to everyone. If AI is available to most places, then the expertise which is available in the human intelligence can be made available through machines to many more people. Like the phones are smartphones have kind of reached almost everyone in India, and it has become kind of becomes kind of equitable to everyone. So it's not only the people who have the resources who can use the power of a smartphone. And you can also have personalized risk assessment. There are challenges because if you don't have good data, and this is very important because the current AI models that are built using Western data sets. We really don't have enough data sets from the developing countries, and so there might be changes in data quality which is there, and there might be some things which we do not know. And if you don't have enough data to kind of train the model, then you might not get a very good model that is there, which you can use. It's again, and if you don't use proper data, if the images are not good, then it's like garbage in, garbage out. So you may not get again a good model. Again, as I said, there are ethical considerations as to how much AI you can use in a particular area. So this was very interesting when I was reviewing literature. You can use AI to kind of find out the gestation of a child. Finding out the gestation of a baby who is about to be delivered is kind of a difficult thing. And unless you have a very good ultrasound done by an experienced person in the first trimester, it's very difficult to date gestations of babies that are born. So this study was done in North Carolina and Zambia, where they looked at training people who were not so well trained in ultrasonography and finding out whether AI can help them find out the gestation age of the babies that were being delivered. So these images were used to train the neural networks, and they used 3 sets of images. Babies who were born through IVF, so you knew the gestation, accurate gestation of that set of babies, and this was from North Carolina. A novice test for people who were untrained and tested. This is from Zambia, and then in both the places in Zambia and North Carolina, you had people who had trained of using ultrasonography of fetal ultrasonography, and they kind of did both. They did the ultrasound as well as they had scans done in that particular way that they expected the novices to do. So this is kind of the flow chart where you had around 4,521 participants, and you can see almost double kind of studies. So pregnant women had a normal scan, proper scan, and then they had those sweeps. So they had these training sets, and which was the main training set, and then a fine-tuning set. These are both from Zambia and North Carolina, and they had the images acquired by a sonographer and with commercial and in the low-cost devices. And they had this number of participants. So you can see more participants here. And in the testing sets to see whether the AI model is correct. So most AI models work this way, that you have a training set, and then you have, once the model is trained, then you test whether the model is working correctly or not. And so the testing sets were again from Zambia and North Carolina with a sonographer acquisition and a commercial device. And there was a IVF one, which was kind of the gold standard. And they used the novice test from Zambia, people who were untrained users who did the sonography, and with a low-cost device. What they found was very interesting, that the model performance of finding out the correct gestational age extended to blind sweeps collected by untrained providers in Zambia using low-cost devices. So it kind of tells you that AI becomes, if you get good data and if it is well-trained model, you can actually get a very good estimation of the gestational age. So this is kind of to build the background of how these things get trained and how you can get good data. So again, to go back to my first slides, this is artificial intelligence, which is built by, and then you can use some part of it by machine learning by using data sets. And deep learning is when you use specific neural networks to even use for more training. And this is kind of a continuous feature. You keep on testing and training the data, and once you are testing and training and training the model is done, then you validate the model and you test. And these are the various models that are used. You will see these names coming up subsequently, and many of them are commonly used. And so they are then pushed into clinical application. So this coming to the first set where fetal ultrasounds are being used. So the task can be classification, segmentation, and detection. And we will see that plain detections are quite feasible. Assessment of various biometric, this head circumference, abdominal circumference, biparietal diameter, etc. also is done much better, and we can find out what disease diagnosis can be done. So combining artificial intelligence and prenatal ultrasound improves the efficacy and accuracy of all of these things which I mentioned earlier. Most commonly, as far as like Down syndrome or poor pregnancy outcomes are concerned, we look at nuchal translucency. And AI kind of automatically identifies the neck region and calculates it correctly. And this is again a model where which is called as a Sono-ND, and this has been integrated into commercial ultrasound equipment. So the ultrasound equipment that we get, like our phones, will getting updated software, and many of these AI trained models will get added to our ultrasound machines. Like many of our ventilators, etc., you have newer software that gets updated, and you get new capabilities in the ventilators. Similarly, the ultrasound capabilities will change, and this happens even in MRI machines, etc. Interestingly, for neonatologists, where we look at whether the lung is mature or not, and so we do know that when we give antenatal corticosteroids, there is improvement in lung maturity. This improvement in lung maturity of the fetal lung can be shown by using AI. So you do a lung scan, use it in AI, get it in AI, then you give your antenatal corticosteroids, and then your subsequent lung scan 24 to 48 hours later, you can see that the lung maturity has improved. So this also can be seen by AI. Many of these systems, like here, the AI-assisted image system is called as PECS, can detect and classify 9 kinds of fetal malformations in real time. So not post-processing, like you do a image collection and then you process it through AI and then get the report 1 day or 2 days later. But this is in real time, so it again required less time, and the performance was comparable with experts. You can use it for cranial regions, etc. And so these are the various researchers which have used different kinds of models, and there's, as you can see, you can distinguish between normal and abnormal fetal brains with a quite high accuracy of almost 97%. In fetal echoes, so coming from just general ultrasounds to detecting abnormalities in the brain, limbs, etc., coming to specifically cardiac defects, because they are a significant number, and many of them can be managed after birth, and some of them may not have very good outcomes. So there is a specific interest in finding out whether fetal ultrasounds can show you, fetal echocardiography can show you congenital heart diseases. So there has been a great deal of interest, and a lot of studies have been done. And this sensitivity and specificity are pretty high, as you can see, 95, 96%, and a negative predictive value of 100%. So if you get a negative test, that means that there is no cardiac defect. So it's pretty good predictive value. And as you can see, the sensitivity of this particular model is comparable to that of clinicians and performs well on other data sets and low quality images also. Other researchers have looked at different echograms, what they call as fetal intelligent navigation echocardiogram, along with virtual intelligence sonographer assistance. So this allows them to locate 7 anatomical landmarks. As you can see, when this gives you automatically generated various standard echocardiographic views in seconds, and with which you can identify this congenital heart disease. So as you can see, in where proven cases of CHDs were there, the fine model could recognize abnormal cardiac anatomy quite easily. And again, this has been integrated into commercial ultrasound equipment. When this was combined with 5D heart Doppler, so again this fine was combined with that color Dopplers, it came to be known as color Doppler fine, and that is also integrated into commercial systems. So it shows vascular anatomy, flow direction, velocity, various diagnostic details, which can give you more data and more detailed data about congenital heart disease which is there. This was related to kind of scanning usually in the second trimester, but then there is another person who has developed a model where you can do this thing even for the first trimester, where usually you do not pick up any of the congenital cardiac anomalies. So deep learning for the interpretation of first trimester fetal echocardiography live can recognize congenital heart defects even in the first trimester, which is not really well known. There's another model proposed by Gong, which is DGS-CNN, which can achieve a recognition of 85% of fetal CHD, which is even better than that of experts. So you can see that this is kind of a pretty well-developed field. So it basically improves clinical efficiency, reduces subjective variability due to differences in operator expertise, and if this is made available, machines can move to places, but humans may not be able to move to various places. So it allows you to kind of extend your expertise to peripheral regions and to places where things may not be available. Again, it will be expensive, but if it is used widely, the expense will definitely drop. As I said earlier, if you don't get good images, obesity, etc., and so on and so forth, you may not be able to get good data. So depending upon how the images were trained, whether they were in obese women, when the model was trained in non-obese women, and the model was developed, you might not get good data. So all of these things also are important. This is just I'm just trying to show that these are the various studies that I have from which the slides were made. And so these are for lung, these are for brain, and these are for the heart. And you can see that the performance metrics are there in each and every case, and what kind of AI models were used is also being noted there. So since I have less time, just to show that there is image processing which happens, and then there is parameter assessment which happens, and then there is a disease diagnosis. This is how kind of the AI for fetal echography moves. So simply put, it allows inexperienced people or less experienced people in image recognition and making a disease diagnosis. If you're already an experienced person, AI can help you do it faster. So instead of spending 1 hour to do a fetal echography, you can do it in 20 minutes. So you are able to serve 3 more people rather than just 1 person. It allows you to focus on various other things like differential diagnosis and other important aspects. And it can be, of course, used as a teaching tool for various people. So this is kind of the benefits of using AI for echocardiography. As you can see the text here, I use an AI tool to just put the text in and made it in image format. So there are simple things that we usually can do with AI. I talked about toxicology earlier. So basically what this ReproTox KG investigators have done is they have collected a lot of data from various published abstracts where they looked at drugs and birth defect associations from various studies, etc., and that kind of pulled together all that data into a AI algorithm. And if you go to that website, you can put in the drug that you're trying to use, and it might tell you whether that drug is going to be teratogenic or not. So this is again a website which is freely available and which you can use the website for estimating whether the drug that you're using may or may not be, teratogenic or not. So this is again another study which was published, which can tell you that machine learning can predict a drug's teratogenicity from its structure. So there are various structural activity relationships that are used. So kind of, and it uses structures of various drugs. This particular model is used from drug bank, from safe fetus, from various data sets that they have used, and kind of have reached this particular show that which drugs might be teratogenic. Again, as you can see over here in the middle, there are the various AI models that can be used, or the methods of training the data which is there, which can tell you from, these are the models which have been getting constructed, and you can analyze the structure. So this is again published in molecular informatics, where you have interpretable predictions of phytotoxicity of drugs. So go to the next one. This is for your genetic diseases. It allows you to integrate and model various vast amounts of genetic data. So you can do a lot of analysis, because I think processing genetic data, or when you getting data reports out is a very cumbersome process, takes a lot of time, and AI allows you to can allows you to do it kind of faster. And it will pick up various things which would have been missed by traditional methods, resulting earlier diagnosis and better prognosis. So a lot of companies are involved. As you can see, Illumina is one of the companies which prepares software for interpreting genomic sequencing, etc. And so they are also into this business. I think I'll stop here because this kind of covers most of the things that I've done. So AI is a fast developing field. Most commonly, you can use it in fetal ultrasound analysis, where you can pick up birth defects. You can diagnose several congenital heart diseases, and there are very good models which can be even better than experts. And there are ability to use it for finding out whether drugs may be toxic or not, and whether you can find out which genetic defects might be there which can predict birth defects. So you can use it in these various circumstances. Not taken more than 20 minutes, I hope, and I hope I was not too fast. So as I said, I'm not an expert. So
Thanks, sir, for a wonderful talk, giving us an insight about the artificial intelligence. I am a pediatric cardiologist. It's fascinating to see fetal echo can detect as early as 12th week by artificial intelligence. As we are doing fetal echo between 18 to 20 week, 12 week we are not getting the good window and structures are not visualized. But if this will come, it will definitely boon for the mother if she has a certain complex heart disease.
Yeah, so you'll be able to, because one of the things what has happened now with this change in abortion laws, 20 weeks, say 24 weeks. In India, the laws have changed where you can do abortion quite easily up till 24 weeks. So we are seeing a lot of, we used to not see them previously. Now we are seeing a lot of parents come at 22 weeks, 24 weeks, there's a birth defect and we want to do abortion. And so that abortions have increased actually in India. And this will actually help them to take a decision earlier. What happens today is if you are in a big city, you have easy access, you get a diagnosis at 20 or 22 weeks. But if you are in a peripheral place, to get to a bigger place and get a decision, you end up at 25 weeks and 26 weeks when it becomes a little bit more cumbersome to get an abortion. In India, it's still possible, but it becomes a little more complicated.
Guideline extended to 24 weeks now. So
yeah, so 24 weeks.
Delay, be 22 weeks, 23 weeks, so I can give a proper diagnosis.
Give a proper diagnosis. So, but AI will allow us to do it earlier, 12 weeks, 14 weeks.
So I am waiting for that.
Yes. Yes. I knew you would ask a question.
Yeah, so thank you for this presentation. AI is interesting, and you clearly explained the three levels. I was wondering, so on the fetal congenital cardiac abnormality. So with AI, do they use explainable AI? So I missed this in your presentation. So AI, if you use AI, and you said garbage in, garbage out, I fully agree, or rubbish in, rubbish out, different phrases meaning the same thing. But does AI in that project you showed also showed where it's deciding on? Do you know what I mean? Explainable AI. So does it show us where it's different from the normal situation and that sort of thing?
You are saying whether, does it show using AI how different it is from a normal situation?
Yes, so you said machine learning, so you train your normal and your abnormal against normal, that's normal, or any control group, and you have to be very careful on your control group because that might be also part of your rubbish. Yes. But then, AI can, some forms of AI can show where they make their decisions as well, and they clearly show. So it's not a black box. So it shows what it has been doing, and I was wondering if for this.
So one of the models that I showed you was sequential model. So AI you can pick sequentially. So you might do a AI-assisted echography at maybe say 18 weeks. It might show you something, and you repeat it again later on. You can have both the images processed at the same time, and it will tell you what has changed.
Yeah.
Which you will not be able to do. Humanly impossible to remember or to look at those, what do you say, images and then decide what has changed. But AI will allow you to see what the changes have happened. So you can actually do it's processing of two data together.
It's not only by seeing, it's by showing. I think now that's more a message to the public that's still here, that if you ever use AI, try to use explainable AI that you can actually, because otherwise we as a human are not in control anymore.
Yeah.
So that's more sort of take-home message.
I think I get your point. So the prompts that you use for AI should be more easier, and you should be able to understand what is happening there rather than not knowing anything what is happening there.
It shouldn't be a black box.
Yeah.
So if you use it as a black box, then you're,
you lose control. So you
use control.
You should be knowing what your computer is doing.
Yeah.
If you don't know what the computer is doing, then you are in deep trouble.
Yes.
Is that correct?
Yes.
Yeah. So it was interesting. So one of the things that I work mostly in kangaroo mother care. So in 2016, there was there was a publication from Nathalie Charpak's group from Colombia where they showed that babies who got KMC in 1998, 1994, like where they did a 20-year-old follow-up, they did MRIs of those patients, and they found that of those babies who became adolescents, they found that in the brain, there was significant increase in the brain size of various areas. And they said, and they looked at other evaluations. So they said that babies who received KMC had better brains at 20 years of age. And this was 2016, so AI was not so kind of well known, or models were not available. They put the same MRI images through AI processing software, and they published a study in 2023 where they were able to use the same images which they published a similar study on, and they were able to look at, and because they had images of all these patients, like 400 patients, who had got varying duration of kangaroo mother care, a number of hours of kangaroo mother care, they were able to show that with each day increase in kangaroo mother care, how much millimeter increase in the brain size was there. So that they were not able to do in the 2017 paper because we did not have the AI kind of capability at that time. But in 2023 when they used, they used AI software that was from Boston area, so from that area. So Boston does a lot of, it's good for computers. So they use AI developed in those labs, and those same images they put through that AI processing software. So they were able to get better data and better answers from the same set that they used. So they published that paper in 2023. So very interesting it was. Thank you very much, and it was a good learning experience.
Thank you, sir, for highlighting the role of AI in our diagnostic tools. When the new world meets with the old world, the horizon we achieve is invincible. I would like to call upon Dr. Chandradeep Mastan to please felicitate Dr. Somsekhar Nimbalkar. Sir, please. With this, I thank you to all the dignitaries, our respected chairpersons, for their presence and their participation. Now, I would like to call upon Dr. Professor Bert D. Rice to please come up on the stage and felicitate our esteemed chairpersons. Dr. Helen Stewart. Dr. Saurabh Singh. Dr. Sanjay Khatri. And Dr. Chandradeep Mastan. There is one ancient saying in India in Sanskrit, Vidya Dhanam Sarvadhan Pradhanam. I'll translate this for our guest from West. Wealth of knowledge is most precious and supreme wealth. With this note, we move forward in our journey of learning, and I'll welcome the chairpersons for the next session. Dr. Dipanjana Datta, Genetic Counselor, Organization of Rare Disease India. Dr. Aditi Singh, Lab Director, Advanced Center for Medical Genetics, Mahatma Gandhi Hospital, Jaipur. Dr. Marit Elting, Medical Specialist, Amsterdam University of Medical Center, the Netherlands. Our speaker for this session I'm pleased to invite Dr. Weber Upadhyay, Assistant Professor, Department of Pediatrics, Mahatma Gandhi Hospital, Jaipur, on the topic Rethinking the Diagnosis, Unusual Case of Muscular Dystrophy.
Good evening, everyone. So we are already late, and I'll be very quick with my session. And we have saved the best for the last. So Toshita will be doing the last session. You guys, you all are geneticists, but I'm not a geneticist, so I'll not go too much in detail of the science. But look at this picture. So she is Ferial Sheba, okay, and now this pic also her. So this is Ferial Sheba with her wings, and so I'll tell you a story first. So Ferial, born in Sheba, Tunisia in North Africa, she was a curious and adventurous child, spending hours exploring the sandy beaches and crafting stories. But as she grew older, her parents noticed something unusual. She began struggling to climb the stairs at home. Her legs would tremble, and she often needed to use her arms to pull herself upright. At the age of 6, she was diagnosed with Duchenne muscular dystrophy. Periel has used a wheelchair since she was 11 years old, but her diagnosis has not stopped her from having a positive outlook and living in the moment. After primary school, Ferial attended college where she studied performing arts, film, and theater studies for 2 years. She stated that I am a strong person and courageous woman who rarely complains. I live day to day and enjoy the present moment. I am very positive. So now I will present a case. So this is a female child we had in our OPD. This is a 4-year-old female child born out of consanguineous marriage and via IVF pregnancy. Came with the complaint of difficulty in walking and climbing stairs. So so there was a positive family history. She had 2 maternal uncle who had similar complaints and died later, and one male cousin is also suffering from the same problem. On examination, there was proximal muscle weakness. Gover sign was positive. No other significant abnormality was there. Cardiac and respiratory functions were normal. I would like to play this video. Can you play this video? मिनिमाइज करके बाहर से चला दो अच्छा ठीक है I'll show it later. So there's a video showing the Gover sign positive, and the cardiac and respiratory functions were normal. So then we investigated the child and we did the routine investigations. They were normal, but CPK level was very high. It was 3601, and we did a echo which was normal. Then we did a karyotyping and MLPA. So karyotyping was normal, and MLPA showed duplication of exon 4 to 7 of DMD gene. So there could be 3 scenarios. The first scenario, random inactivation of the 2 X chromosomes, which is a normal phenomena. Other than that, non-random X chromosome inactivation could be there. X autosomal translocation with breakpoints could be there, or X chromosome of Turner syndrome could be there, but X chromosome of Turner syndrome was ruled out by karyotyping. So 2 possibilities were there: non-random X chromosome inactivation and X autosomal translocation with breakpoints. Random inactivation of one of the two X chromosomes, which is a normal phenomenon. It happens during the early embryonic development to balance the expression of X-linked gene between the males and females. There will be a mosaic pattern. Some cells express the genes from the maternal X chromosome and others from the paternal X chromosome. In non-random X chromosome inactivation, specific X chromosome, it will be a specific X chromosome, either maternal or paternal, is consistently inactivated across most or all cells. So imprinted X inactivation or skewed X inactivation will be there, and non-random inactivation can influence the severity of the Duchenne muscular dystrophy. Or X autosomal translocation with breakpoints could happen, but preferentially inactivation of the normal chromosome, a segment of the X chromosome is exchanged with a segment of an autosome. These translocations can lead to disruption of gene function depending on the location of the breakpoints and thus status of X inactivation. Breakpoints with regulatory regions or coding sequence can result in disease or syndrome due to altered gene expression or X chromosome of Turner syndrome. When an individual has only one X chromosome, in such cases the absence of a second X chromosome prevents X inactivation. Single X chromosome remains active in all the cells. So, but in this child, she has a male cousin with the similar complaints, but this child is in our follow-up in OPD. So we are trying to get the male cousin get investigated, and then we'll plan a microarray for this kid. I have mentioned some trials which are going on, but I'll skip it because of lack of the time. So when I was searching for the literature, I got this picture, Save Our Sons from Duchenne Foundation, but then I was going through it. So Duchenne is common in male. So in 5,000 or 6,000 males, there will be one male who will be having Duchenne muscular dystrophy. But in females, it's very rare. It's less than 1 in 1 million. So it should be Save Our Children, not the Save Our Sons. So then the motto of I am taking this topic was ki, this kid went to so many pediatricians and physicians, then came to us. So, but no one was thought of the female DMD. So we thought ki what is the awareness status of the female DMD. So you guys are already aware. So, but I thought ki I'll make some awareness and delegates. So then I was going through it. So I found that on the 7th September 2022, which was Duchenne Awareness Day. So the theme was women and Duchenne. So they tried to make some awareness, but still in rural areas and PHC, CSCs, there are very much lack of awareness about it. And the girl I have mentioned in the first slide, this Fierel Sheba. This girl, she's a very nice and motivated girl. So she made a Facebook group. She made a group, Girls with DMD in the World. So there's a group on social media she made, and she did some exhibitions with her paintings and arts just to motivate the girls with muscular dystrophies. So there are so many girls on this social media platform, and they share their feelings, their emotions, and how they are coping with this. So this is from my side. Thank you.
Can ask questions? Very nice presentation and very rare case, but can you just go back to the pedigree once?
Yeah.
I have two questions. Number one, what were the age the male counterparts, the male people expired? Number one. And
yeah.
And did you rule out LGMD for this child?
Yeah, so the thing is कि अभी we are working on this child. This child is on follow up. We have asked them to bring the cousin male, so
No,
that we can
even
do
if
the.
you bring the cousin male,
Yeah.
understand that because you didn't get anything on the karyotype, all right?
Yeah.
There's a very less chance that it will have a autosomal balance translocation, which if you have to pick up, you need to do optical mapping. Otherwise, there's no other way.
Yeah.
CMA will not pick up a balance translocation,
Yeah.
right? So doing CMA does not matter. Second, a duplication in a chromosome, the other boys might have it and they might have it in a hemizygous state, so they express. But this girl might be a carrier and can also have another diagnosis of LGMD. I think LGMD is more common, and at least for the person, the LGMD should be ruled out. It may be that the child has DMD, it's a female DMD, but when we see, I myself also have a patient with female DMD, but to establish that it's a female DMD, you need to rule out the more common muscular dystrophy in girls, especially you are from Rajasthan, and this is the red zone for LGMD. Even people who don't marry in the same community, still they have children with LGMD in these parts like Rajasthan and Gujarat. So I think with the prevalence, LGMD should be ruled out. That's my comment.
Yeah, that was, I was also thinking we cannot label it for now. So we also thought in the similar line that if we can evaluate the male cousin, so we can see whether the male cousin is also having the same thing.
See, if the
or
male cousin has the same thing, the male cousin might present it also.
Yeah.
Because it's a hemizygous baby. Male will have only one. And her maternal brothers or maternal cousins might have it. But they might be the affected one, but she might just be a carrier.
Carrier, yeah.
And right now, if I'm just looking at epidemiology, the chance that this is an LGMD is far more than the chance that this is a.
Yeah. So, but if the male cousin is also having 4 to 7 duplication, then it okay. Then can we label it as a DMD, or then also we have to do the microarray or optical genomics? We don't need.
Microarray is not needed here in DMD. What test did you get it done on the girl? You didn't show any slide for the test. MLP, did you do it on the mother?
No, we have not done. We have not evaluated yet. We will do it.
So what did you counsel the couple well? Did you counsel for prenatal or anything also?
Yeah, we are in that process. So we are counseling them and we are doing all
I think your
this.
LGMD first should be ruled out. With West India, LGMD has to be ruled out before you label this child. It does show a DMD pattern.
Yes.
Even the mother can be a carrier, but still the child might have LGMD, and there are numerous such cases. So where you stay, this west of India, LGMD is something that you need to rule out if you see a female with that high, that Gauer sign and this thing, because for me, I will first rule out LGMD and then think about DMD or any other rare conditions.
Yes. Thank you.
Thank you, Dr. Weber. I would like to call Dr. Dipanjana Datta to please felicitate Dr. Weber Upadhyay. Dipanjana ma'am, please come. Now, moving forward, now I am pleased to call Dr. Tushita Lakhera, Assistant Professor, Department of Pediatrics, Mahatma Gandhi Hospital, Jaipur, to have a talk on unmasking the gene champion, exploring voice.
Good evening, everyone. As we all know, we're running quite late, so I'm going to wrap this up in 10 minutes. So right at the outset, I just want to mention that the question with this case is something that we face very commonly as a pediatrician, and I'd like a lot of input from our esteemed geneticists present here today. So the title for my case is Unmasking the Gene Champion, and I promise this is going to make a little more sense at the end of the slideshow. So this was a 2-year-old male, AS, first by birth order, born of non-consanguineous marriage, and he was brought with complaints of delay in attainment of age-appropriate milestones. His developmental milestones at the age of 24 months were that he could only run, he could not climb stairs, he had an ulnar grasp, he could only communicate verbally with bisyllables, there was no stranger anxiety, and his approximate developmental quotient was 44%. And some other complaints that were reported by parents were he had decreased pain perception, recurrent upper respiratory tract infection, some facial dysmorphism, repetitive movements, and he had these episodes of nocturnal awakening with aggressive behavior, and their parents would face difficulties in putting him back to sleep. His antenatal history was normal. Birth history was born full term with via lower segment cesarean section. This was done in view of polyhydramnios. That was actually the only antenatal history that we had. Other than that, it was normal. Birth weight was 3.1 kg. Baby cried immediately at birth. There was no history of NICU stay. But what was noticed at birth was penoscrotal hypospadias with chordae and bifid scrotum. Testes had descended bilaterally. There was no history of feeding difficulties, and rest the neonatal period was normal. On clinical examination at 2 years of age, when he had presented to us, he had a flat face, flat occiput, frontal bossing, bitemporal hollowing, plagiocephaly, hypertelorism, upward slanting palpebral fissures, low set ears, short philtrum, tented upper lip, everted thick lower lip, open mouth, high arched palate, multiple nevi and cafe au lait macules, bilateral clinodactyly, hypotonia, micropenis, wide-based clumsy gait, and repetitive movements in the form of door banging. He had an over-friendly behavior, but his anthropometry was absolutely normal. I couldn't put a picture of the patient because parents didn't consent for that. So this is a pedigree. I've drawn a 4-generation pedigree because we have so let's look at the proband here. We have 3 conditions in the proband. One is, of course, the global developmental delay with facial dysmorphism. Second is the hypospadias, and also the patient was diagnosed with hypothyroidism. Now, amongst all of these, hypothyroidism was also present in the parents. The father had autoimmune thyroiditis, and mom had gestational hypothyroidism. And hypospadias could actually be traced back to his great-grandfather. And global developmental delay with facial dysmorphism, however, was only present in our patient. So just summarizing his timeline, at birth, he was noticed to have penoscrotal hypospadias with bifid scrotum and chordae. He was operated for this at 18 months of age. On day of life 15, parents reported constipation. There was no history of jaundice or feeding difficulties, and weight gain was adequate, and this is where hypothyroidism was also diagnosed. At 3 months of age, he was found to have torticollis. He was diagnosed with bilateral exotropia, and again operated for the same at 17 months of age. And then starting from 6 months of age, mom started to notice a developmental delay both in motor and language milestones, and also the fact that he was a little floppy for a child of that age. And at 9 months of age, they finally started consulting pediatricians in view of global developmental delay, speech delay, hypotonia, and facial dysmorphism. So obviously there was a battery of investigations that was done, but I've just highlighted the main points. So there was primary hypothyroidism, there was some mild to moderate hearing impairment, and on his MRI brain there was Vermean hypoplasia, brainstem hypoplasia, and subtle signal abnormalities. And of course his DQ was lesser than expected for that age. So a whole exome sequencing was done for this patient, and 3 mutations were found. The first was SRD5A2. Mutations in SRD5A2 gene, homozygous mutations in SRD5A2 gene are associated with pseudovaginal perineoscrotal hypospadias. Our patient had a heterozygous missense mutation, but that was pathogenic. Parents were not examined or investigated for the same. So phenotype was present, but clinically this may not be relevant because also this is an autosomal recessive condition and he was just heterozygous.
The second mutation was CHAMP1. Mutations in CHAMP1 in the CHAMP1 gene are associated with neurodevelopmental disorder with impaired language and dysmorphism. Our patient was again heterozygous and had a stop gain mutation of uncertain significance. This was definitely a variant of interest because the phenotype was that of developmental delay, hypotonia, impaired language, and facial dysmorphism. But again, the question of variant of uncertain significance as mostly is. This was a de novo sort of mutation because both parents did not carry the same. And the third mutation was in the JAG1 gene. Homozygous mutations in JAG1 gene are associated with Alagille syndrome. Our patient did not have any phenotype for the same. This was also present in the father, so this was just probably inherited from an asymptomatic father, and the phenotype was absent, so we didn't consider it too much. So if you look into the genetics of neurodevelopmental disorders, various genes are associated with neurodevelopmental disorders converge on common processes like synaptogenesis, chromatin remodeling, transcriptional regulation, and chromosomal alignment or spindle assembly. And mitotic defects in neural progenitor cells may cause a decrease in the number of neural cells and defective neuronal development, resulting in intellectual disability, which is probably the pathophysiology of it. So the CHAMP1 gene is located on chromosome 13q34. It has 2 untranslated exons and 1 translated exon. It encodes for an 812 amino acid zinc finger phosphoprotein, and the function of the CHAMP1 gene or protein is to regulate kinetico microtubule attachment and therefore proper chromosomal alignment. And as we alluded to previously, this is very important for proper neuronal development. Mutations that have been reported so far are nonsense, frame shift, deletion, and missense. To date, 41 de novo truncating mutations, 8 deletions, and 2 missense variants have been identified. There have been cases of missense mutations and deletions that have been inheritably passed down, and these patients exhibit a milder phenotype. And as we mentioned previously, CHAMP1 mutations result in neurodevelopmental disorders with hypotonia, impaired language, and dysmorphic features. Previously, it was classified as autosomal dominant intellectual disability type 40. So this is a structure of the CHAMP1 gene. We'll just skip all of this. Again, this is just to re-emphasize on the kinetico microtubule attachment and its role in chromosomal segregation during metaphase. So these are all the case reports over years, and our patient had motor delay, severe speech impairment, intellectual disability, facial dysmorphism, hypotonia, ophthalmological abnormalities in the form of hypermetropia. He had strabismus, behavioral problems in the form of stereotypies, over-friendly behavior and stereotypies. There were those bouts of aggressive awakening episodes at night. There was hearing loss and high pain tolerance. GI abnormalities in the form of constipation and reflux, an abnormal MRI brain, recurrent upper respiratory tract infections, and endocrine abnormalities in the form of hypothyroidism. So all of these were actually present in our patient. Also hypospadias. So hypospadias has been reported in 1 case with CHAMP1 mutation, and that's all that there is to it. So amongst dysmorphism, our patient had hypertelorism, upslanting palpebral fissures, stented upper lip, everted lower lip, low set ears, long face, short philtrum, broad nasal bridge, anteverted nose, pointed chin, and prognathism. What our patient didn't have was syndactyly and a doughy skin and joint laxity. So far, our phenotype did pretty much match CHAMP1 gene mutation. So we were actually stuck with that variant of uncertain significance. But something that we couldn't explain was the hypospadias that was going down for generations. So if we re-look at the pedigree analysis, we have hypospadia starting from the great-grandfather. He had a milder sort of anterior glandular hypospadias, and then his grandfather with the glandular hypospadias, then his uncle with glandular hypospadias, and then he had the more severe type of posterior penoscrotal hypospadias, and then his great-grandfather's brother also had a severe type of hypospadias. So we were looking into the genetics of hypospadias to explain this kind of inheritance pattern and whether it had any implication to our CHAMP1 mutation. So hypospadias can be non-syndromic and syndromic. Non-syndromic hypospadiases are mostly idiopathic. Syndromic hypospadias is associated with syndromes like Dennis-Strash, Smith-Lemli-Opitz. Factors involved in the etiology of hypospadias are genetic, endocrine, and environmental. Amongst the genetic causes, 30% are monogenic and chromosomal, and 70% of genetic factors remain unknown, probably due to non-Mendelian patterns of inheritance. Most significant risk factor would be an affected family member, and that was the case in our patient. Familial aggregation is seen in 10% of cases, so if there is a brother of a male with hypospadias, he has a 9 to 17% risk of also having the condition. Heritability of hypospadias is between 57 to 77% with equal transmission through both maternal and paternal lines. So if we remember the trioexome sequencing report, we had seen an SRD5A2 gene mutation, heterozygous missense mutation in our patient. And what the SRD5A2 gene does is it encodes for the enzyme 5-alpha reductase, which consists of 254 amino acids. And the function of this enzyme is to convert testosterone to dihydrotestosterone that acts on androgen receptors and is responsible for the development of male external genitalia. So if there is a mutation, we won't have this 5-alpha reductase, and hence that can result in all of these hypospadias. Manifests as varying degrees of genital ambiguity with perineoscrotal hypospadias, bifid scrotum, clitoris-like phallus, and rudimentary prostate. So now coming to the explanation of hypospadias in this patient. So first was to take it as part of the CHAMP1 mutation, but the family history is unremarkable for neurodevelopmental disorders, and hypospadias was present in multiple male members on the maternal side, suggesting autosomal dominant inheritance pattern with variable expressivity and incomplete penetrance. The possibility of autosomal dominant isolated hypospadias, while there have been sporadic reports of autosomal dominant inheritance in certain families with hypospadias, the exact genes involved in the prevalence of such cases is not very well established. And then the third possibility was it being part of the 5-alpha reductase 2 deficiency phenotype. So although it is an autosomal recessive disorder, there have been a couple of cases in literature which have identified a single mutation. So Shabir et al. In 2012 had reported a heterozygous mutation in exon 1 and a homozygous mutation in intron. But intronic substitutions, as we know, may or may not have an impact on gene expression. And then Wilson et al. In 1993, that is long back, had reported heterozygous mutations of only one allele in 4 patients. However, even then it was hypothesized that these patients may be compound heterozygotes for mutations that map outside the exons and the immediate flanking intron sequences that were analyzed at the time. So now I would like to open this discussion to our geneticists. How do we go forward with cases like this? Because I've put this down as take-home messages, but one is to consider more than one condition in a single patient, to consider CHAMP as one disease, and then to consider hypospadias as another one, and also how to go forward with the variant of uncertain significance when we know that the phenotype does match.
Yes, thank you for this interesting case, yes. I think, might there be a pseudo-dominancy? Is there a consanguinity up in the tree?
No.
In the pedigree?
No consanguinity at all.
Okay, so that might have been part of the explanation. So, no, I don't know the expression of a heterozygous variant and how you can make that more clear in this pedigree that is part of the phenotype here in a dominant inheritance.
Yes.
I don't have any experience with that. I wanted to make a remark that the Alagille syndrome is not recessive but dominant.
Oh.
But doesn't matter for your interpretation, just a remark.
Yes, all right, right.
So how to continue? Yeah, I don't know, you might go and do some RNA sequencing.
That's what, yeah,
but
so we,
I don't know if it's available or...
Right. So
Yeah.
we were planning to send this across to PerkinElmer in the US, but parents didn't really give us consent for that. But they were willing to do, so what we did plan to do in India was to evaluate all the affected family members for the SRT5A2 gene.
You have a simpler thing to do. Just do a 5-alpha reductase assay.
Right. So, yeah, correct.
Yeah.
So that was what we were thinking.
It's a
Enzyme
much
analysis.
simpler thing to do.
Yes.
So, but I don't think the hypospadias is due to that, because in that case you would see some other symptoms if you are looking at 5-alpha reductase.
All right.
And even if it is an intronic, deep intronic variant which we are missing, probably you would see more symptoms, like 5-alpha reductase would come up with some other crisis which you are not seeing through generation. Also, if you look at it, hypospadias is one of the most common birth disorder which is there. And there are many cases which are familial. So I feel that it might be more of non-Mendelian factors which is playing over here. If you can go back to your mutation report. So the interesting part of your report is this is a null mutation, right?
Stop gain, yes.
So, and it is not present in the parents.
Yes, CHAMP1,
So
yes.
basically, and you only showed that the manner the mutations happen is also nonsense, because there were 41. So you can actually reassess the ACMG criteria.
Yes.
And because you are clinically showing, you can also give the AMP criteria. Your CHAMP1 will actually can be reclassified into likely pathogenic. It's not AVIO US or AVIO USD for that matter. All right. So
So we kind of actually planned to do this. Yeah. So we wanted to evaluate the affected family members, as you said, ma'am, for enzyme analysis for 5-alpha reductase, and we wanted to review classification 6 months later. But as you mentioned, we could.
No, but you can.
Even
like, though
now.
that right now the conditions are very stringent, you need to do a paternity testing and all of that. But then it still can be.
Maybe I can share my thoughts. I think it's rather straightforward. So you have this, the problems with the hypospadias, that's autosomal dominant going through this family. Either, so that's is clear. The other thing is, so when the lab give you a FUS, a variant of unknown significance, a FUS as you say here, I always say FUS. Anyway, then as a clinician, you can upgrade this. I do this more or less on a weekly basis. So the lab, they give their signal based on their knowledge, and then you as a clinician, I can say, okay, thank you lab for your assessment, but I think this fits. I didn't see the photos of the child because you're not allowed to share them, but so that's what you do as a clinician, and you say, okay, it fits the complete picture. It's the kind of mutations that we have been reported. You report 41, and the majority are loss of functions. So 1 + 1 is 3 in this case. So, so don't do too much other work. But it's up to you to compare the photo with the photos of the patients, and that you have to do as a clinician. So.
I agree with Bert. I actually assume that this is fitting with the
diagnosis.
So you can adopt the gene from that.
And you have a dominant hypospadias going through the, okay, nice. So maybe you find a gene if you put some effort in.
So my take-home messages with this case would be interpret variants of and this is for pediatricians, interpret variants of uncertain significance with caution, especially in conditions such as neurodevelopmental disorders, which is an evolving spectrum. Reverse phenotyping is of great relevance in conditions such as neurodevelopmental disorders with hypotonia, impaired language, and dysmorphism, where we don't have any biochemical test available. Always take detailed family history and draw pedigree charts to look at multiple conditions that may coexist in the family, and you can consider more than one condition in a single patient. And even when a gene variant and a phenotype is present, always scrutinize other factors such as patterns of inheritance and zygosity to determine causality. That will be all. Thank you.
Thank you, Dr. Tushita. It's my humble request, Dr. Mary Elting, to please felicitate Dr. Tushita. we feel highly privileged and spacious to have esteemed chairpersons with us. I would like to have it's a kind request, Dr. Shom Shekhar Nimbalkar sir, to please come on the stage and felicitate our esteemed chairpersons. Dr. Dipanjana. Dr. Marriott. Dr. Aditi Singh. Thank you, sir. We are honored to have the presence of esteemed dignitaries and masters of their field from both Western world and India. As we say, Vasudeva Kutumbakam means the world is one family. Such collaboration enlightened and enriched us with such vast knowledge and new advances. Ending the day with a cordial invitation to proceed for the gala dinner at 8 p.m. onwards, Sarovar Premier. I hope you all are enjoying the stay in beautiful Pink City, Jaipur, and we'll all meet up in dinner session then. Thank you.